clinical and investigations. Dr. Divya Jain would be speaking on this. She has done her MBBS from Osmania Medical College, Hyderabad, and PG from the prestigious RP Center. Then Dr. Neelu Mundada will be speaking on basic principles of management, non-surgical and surgical. Dr. Neelu Mundada has done her UG from GMC and PG from GMC Bhopal and fellowship from Arvind Eye Institute. Then I would be speaking on, we would be discussing this topic on a case-based approach. So I would be talking on case-based approach to management of third nerve palsy.
Yeah, I get it. Okay.
Then we have Dr. Vircon Pandey, and senior, very experienced strabismologist from Nagpur. She has done her UG and PG from GMC Nagpur and fellowship from Aligarh. Then the last topic would be management of sixth nerve palsy by Dr. Rishikesh Mai. He has done his undergraduation from Sion Medical College, PG and fellowship from the prestigious Shankar Nethralaya. And he is an executive member of Strabismus Society and Pediatric Ophthalmology Society of India. So we start with our first talk on, and then we have some time for the question answers. Please look into the chat box. If it's pertaining to your talk, please answer the queries which are coming on the chat box. So I request Dr. Divya Jain to start her talk, and the time would be 8 minutes. Please do not exceed your time. So Dr. Divya.
Thank you, ma'am. I hope my screen is visible to all.
Yes, make it full screen, Divya.
Yes, ma'am. Good morning to everyone. A warm welcome to all the attendees for our instruction course on a case-based approach to paralytic strabismus. I, Divya Jain, will be taking you through the basic principles of diagnosis in paralytic squints, including the clinical features and the investigations. So a pertinent beginning in any case discussion of paralytic squint is to start with the extraocular muscles. So here come the extraocular muscles and anterior view of the right eye, with the superior rectus, which is a primary elevator being supplied by the cranial nerve 3, the superior oblique, which is a primary intortor supplied by cranial nerve 4, the medial rectus and the inferior rectus and the inferior oblique all supplied by cranial nerve 3, being an adductor, a depressor, and an extortor.
Moving. The slides are not moving.
Yes, ma'am. And the lateral rectus, which is an abductor supplied by cranial nerve 6. Another salient concept in the topic of paralytic strabismus is that of the spiral of Tillot. So it's a spiral which is formed by the insertion of the recti at varying distances from the limbus, the closest being that of the medial rectus and the farthest of the superior rectus. So the applied aspect of the spiral of Tillot is seen in transposition surgeries, where the muscles need to be transposed along this spiral.
Divya?
Yes, ma'am.
Slides are not moving. We are just seeing the first slide.
Oh, okay.
You have not made it full screen also.
Yes, ma'am. You're not able to see the full screen?
No.
Okay. I'll just reshare, ma'am.
Yeah. Yeah, now it is full screen.
Now it is visible.
Now can you see the next?
Yes, the slides are moving. Yeah.
Okay. So we've already discussed the extraocular muscles and the spiral of Tillot.
Yes.
Now coming to the Sherrington's and Herring's law, these are again an important concept in squint and more so in paralytic squint. So the Sherrington's law states that for any ocular movement, the direct antagonist receives an equal and simultaneous inhibition of innervation. So for example, if the right LR is being innervated, the right medial rectus is equally inhibited. And the Herring's law here states that for a binocular movement, the corresponding yoke muscle receives an equal and simultaneous innervation. So here the right lateral rectus being the agonist, the left medial rectus is the yoke muscle, which receives a simultaneous innervation. Now, a few terms which everyone needs to know In case of paralytic squint is the agonist, which is the primary muscle here. The synergist is the muscle in the same eye, which moves the eye in the same direction. The antagonist is a muscle in the same eye, which moves the eye in an opposite direction. And the yoke muscle is a muscle in the opposite eye, which accomplishes versions in the same gaze position as that of the agonist. So to explain the yoke muscle, like for example, if we take the right lateral rectus, the left medial rectus is its yoke muscle. Now coming to classification of paralytic squint, it could be neurogenic and myogenic. In neurogenic, it could be at different positions. So it could be supranuclear, it could be nuclear, or it could be fascicular or intranuclear. And myogenic squints could be at the nerve muscle junction or the muscle per se which is involved. Could be like hypoplasia of the muscle or a disinsertion because of trauma, etc. Now, what are the clinical characteristics which are common to paralytic squints? Incomitance. Incomitance is a difference in the deviation and different positions of gaze. A limitation of movement, which is obvious, and a difference in the primary and secondary deviation. So the primary deviation is where the person is fixing with the normal or the unaffected eye. And the secondary deviation is when the person is fixing with the paralytic eye. So the secondary deviation in paralytic or incomitant squints is always larger than the primary deviation. Now coming to the stages of paralytic squint, the first stage is the paresis of the particular muscle. Let's take for example, the lateral rectus in this case. The second stage is the overaction of the ipsilateral antagonist. The same eye is medial rectus in this case. And the third stage is an underaction of the antagonist of the contralateral synergist. So the antagonist of the contralateral synergist in this case is the other eye's lateral rectus, where there is a secondary palsy of the lateral rectus called an inhibitional palsy. But how can we differentiate the inhibitional palsy from the primary? Is by covering the affected eye for some time, and we see that the other eye or the unaffected eye takes full excursion in the adductions. Now, few symptoms which patients with paralytic squints present with are diplopia. So it's binocular diplopia, could be horizontal or vertical depending on which muscle or nerve is involved. A head posture, which is a sensory adaptation to the acute onset squint. A past pointing, where the patient says that yes, the patient overshoots objects when they try to reach for something. There could be associated neurological findings like a raised intracranial tension or a space occupying lesion. And systemic disease, which we always ask for vascular causes like diabetes mellitus and hypertension in cases with neurological involvement. Now, here are a couple of tests which we are done in cases of paralytic squint. So, a cover test. This is how they clinically present: the third nerve with a ptosis and the eye being down and out. The fourth nerve with a head tilt, and the typical Parks-Bialchowski three-step test being positive, where the deviation in the primary gaze, in the right and left gazes, and the right and left head tilts is noted. Then in case of a sixth nerve, there is an esotropia in the affected eye. And in case of myasthenia gravis, we have the patient presenting with ptosis, which improves after an ice pack test in the clinic. Past pointing is another sign which can be elicited in the clinic, but let it be noted that this is positive only in cases of acute onset squints. So a septum is placed between the eye and hand to prevent visual feedback, and the person is asked to point towards an object, in this case, a pen's nib, for example, and the patient overshoots the pen's nib. This is because an excessive innervation is given to the affected eye because of the paratic muscle. Diplopia charting is another test which is done commonly in paralytic squints. So with the help of red-green glasses, we dissociate the eyes, and the patient is asked to overlap the images between the two eyes. So we see in this case, the lateral rectus is involved here, and the maximum separation between the two images of the right and the left eye is seen in the left gaze. Now, screen tests for paralytic squints. So these are important tests which are done. They are basically tests which are used to document the relative incomitance of the squints, underactions, overactions of the yoke muscles of the two eyes, etc. The excursions of the fellow eye are charted as the fixating eye is made to fixate in different gaze positions. So the first design over here is that of the head screen, which is the earliest screen test which was done in paralytic squints. Here the eyes are dissociated using the red-green glasses, and the person is, the outer square of 16 dots has an excursion of 30 degrees, and an inner square from the central 0 point has an excursion of 15 degrees, and the pointer is used to mark the patient's positions of different gazes. Yeah, just 1 minute. and the excursions are noted. Similarly, the screen test here, which does not require any color vision or dissociation by red green glasses, is the Lee screen, where a mirror is used to separate the two eyes. This is the Lancaster screen, which again uses red green glasses, but it can also be used to document torsion. Torsion testing is another test which is applicable in cases of oblique involvement. So subjective torsion testing by the double Maddox rod, and the objective torsion testing by fundus examination and by Humphrey visual fields. Force duction test and active force generation tests are also done. The force duction test is used to document the restrictive component in a squint, and the active force generation test is done to document the strength of the extraocular muscle, whether it is a paresis or a paralysis, which is a partial or a complete involvement of the muscle, and the management is based on these findings. Binocular visual fields are another important test, where the normal binocular fields of fixation, these are normal binocular fields, and here we can mark the diplopia free and the diplopia field, and these are used to document progression in the paralytic squints. Saccadic velocity recordings, the movements of the eye are recorded. Normal saccades are 200 to 700 degrees per second, but in paralytic squints, the patient has relatively lower saccades. And neuroimaging, an MRI or a CT scan could be done.
What happened?
I'm unable to hear.
Your screen sharing. Where I am?
Hello?
Yeah, I think.
Am I
Neelu's.
audible?
Yes. Neelu, you can start your talk. Divya spoke well. Now, Neelu can start her talk.
Did Divya stop sharing the screen?
Yeah, we can see your slides.
We can see your screen.
Full screen.
Neelu.
Okay.
And start.
Make it full screen.
Yes, just getting it. Full
Yeah.
screen.
It's not full screen yet.
Yes, ma'am. Doing it.
Huh.
Now full screen, ma'am.
Yes.
Yes,
Good
yes,
morning.
Please go ahead.
Good morning, everyone. Thank you, Bhavi ma'am. Thank you, boss scientific committee. Moss Scientific Committee for giving me this opportunity. I will be talking about the basic principle of management of paralytic squint. Paralytic, as we know, it can be neurogenic or myogenic. Neurogenic is what we are talking about today. One should know about the causes of the neurogenic paralysis. It can be congenital, inflammatory, secondary to meningitis, syphilis, infective, secondary to the cavernous sinus and orbital infections, demyelinating like multiple sclerosis, vascular, secondary because of the neoplasm, and rarely toxic. The prime management, it depends upon knowing your patient well. So you should take a proper detailed history regarding when it has started, the duration, since how long it is associated with systemic illness, preceding illness, past history of trauma or malignancy, and associated neurological diseases. A meticulous examination has to be done with special emphasis on the pupillary reaction, the fundus to rule out papilloedema, look for torsion to a corneal sensation. Detailed strabismus evaluation need to be done so as to see which muscles are involved, what are the state of the muscles, and in which sequelae the paralytic state is there. Battery of tests are needed to know the underlying cause of the paresis, and a supportive radiological investigation has to be done. The management is multidisciplinary. Along with ophthalmologists, we have to take consultation with the concerned physician, neurologist, at times with the oncologist, neurosurgeon, or ENT surgeon. It basically depends in which phase the patient is coming to us, whether he is in acute phase or chronic phase. In early phase, when the paralysis has just started, the main treatment is directed towards the underlying cause, and the treatment is started so as to revive the patient as early as possible, followed by a supportive treatment in the form of vitamin B12, systemic steroids as and when needed. the diplopia has to be minimized, and we try to minimize the sequelae of the paralysis. In chronic phase, we mainly deal with the diplopia. So it can be done in the form of a surgical or a non-surgical form. Non-surgically, one can fuse the images with the help of prism or can use botulinum toxin. Simpler way is to eliminate the second image with the help of occluders or patches. There are various forms of occluders. It can be used for the paralytic eye or the non-paralytic eye. Better used for the non-paralytic eye, the occlusion. So still the paralytic eye gets an initiation to keep on moving. Prisms, they play an important role, especially in cases of small amount of deviation. Diplopia, when it is in particular gaze, it is also useful post-operatively for residual squint. We know how the prisms they act. How do we prescribe prisms? It is given with the base in the direction opposite to the deviation. The amount is required is the minimal amount that allow a binocular single vision and that allows fusion. It can be given either as ground-in prisms or Fresnel's prisms. The ground-in prisms, when given, has to be divided in both of the eyes equally. The advantages are it gives a better visual acuity and a better cosmetics. However, since they are heavy and expensive, we cannot use larger amount of the prism diopters into the lenses. Making also takes time. On the other hand, the Fresnel's prisms have an advantage that they are very thin, around 1 to 2 millimeter, lightweight, and larger amount of prism diopters can be used. It's also useful in cases when the deviation is changing. It can be given in a sectoral form also. Disadvantage with it is they are seen cosmetically. They create distortion and chromatic aberrations, reduce the vision, and they degenerate over a period of time. Botox injection has been used for the antagonistic muscle to the paralytic muscle. It is a neurotoxin which blocks the acetylcholine release. The dose of the Botox, it depends upon the age, the magnitude of the deviation, the muscle which we are injecting, and presence of associated fibrosis. It's basically used in individuals who require rapid recovery, those who need psychosocial gains, in cases of severe limitation of the motility or in case of larger deviation. It's more useful in cases when we are planning to do more than two muscle surgeries, like transposition surgeries, and in presence of significant antagonist contraction or orbital fibrosis to enhance the effect of transposition, the Botox is given to the contracted muscle. It has a role in cases when the patient is unfit or does not want to undergo surgery. These are the doses for the Botox. For the recti, we can use up to 3 to 5 unit international unit. For the vertical, the doses is little bit less, and depending upon the deviation, it can be from 2.5 to 5 units. In cases when there is associated fibrosis, up to 10 international units can also be used. Advantage of Botox is that it relieves the double vision, prevents contraction, and it can be used with the transposition procedure. The disadvantage, it is short acting, can cause ptosis, and is costly. Does Botox injection improves the outcome or recovery? So this is a study that I like to share, published in JAPOS, where it says that in cases of diabetic and vascular origin, the long-term difference between the Botox injected and those who were not injected, it was same. However, in cases with severe paralysis of the traumatic origin, where the recovery is delayed and contraction of the MR progresses, Botox helps the lateral rectus to recover faster. So Botox as such in it's mainly in those, in vascular, it may not be that advantage, but in traumatic, it is advantage. Now the surgical treatment, the main aim is to obtain a diplopia-free field, achieve symmetrical ocular motility, and correct abnormal head posture when it is possible. We follow 3 fundamental principles. First is to improve the ocular movement. Second is to balance the yoke muscle by creating a matching weakness in the other eye and to minimize the creation of the new concomitant deviation. Two important factors has to be considered for making a decision of the surgical plan. First is the amount of the residual muscle function that is present in the parotid muscle, and second, in which direction of the gaze the deviation is greatest. Supposingly the paralyzed muscle has achieved good to moderate function, then depending whether in which deviation in which gaze the deviation is maximum. If it is in antagonist gaze, we weaken the antagonist. If it is towards the gaze of the involved muscle, we weaken the yoke muscle along with strengthening of the parotid muscle. In cases where the muscle has not gained good function and the basic management is to strengthen that side of the muscle by transposition, and better is to weaken the yoke muscle. So what we do, we weaken the unopposed antagonistic. Yes, I finished. We weaken the antagonist by recession, Botox or myotomy, strengthen by resection, plication or transposition. Just I wanted to share one pearl. Don't weaken the antagonist in the parotid muscle which are poorly functioning. This creates a very small binocular field, and because the eye is not moving in either direction. Adjustable surgeries has to be done in cases to achieve optimal result. Thank you.
Thank you, Dr. Neelu, for a wonderful presentation. I think we can take a few questions later on because all the topics are related. So perhaps if there are any questions from the chat box, we can take it in due course of time. I take this opportunity to welcome Dr. Shubhangi Bhave, madam. I think she doesn't need any introduction as such in the forum of squint and pediatric ophthalmology. She is practicing pediatric ophthalmology since last 37 years. She is an alumnus of GMC Nagpur and a recognized postgraduate teacher at Nagpur University. She has been the president of Nagpur Academy of Ophthalmology, Vidarbha Ophthalmic Society, and she is a scientific committee chairman of BOS and a life member of many other societies. She is also organizing chairman of MOSCON, the state conference which was done here physically, the last physical conference we had 2 years back, and she is practicing at Drishti Eye Clinic and Squint Center since 1994. With this, I invite Dr. Bhave madam for her talk on third nerve palsy.
Thank you, Rishi, for that wonderful introduction. Just a minute. I think I just, while checking, I didn't bring it to the... Neelu spoke very well on the broad principles and made our ideas clear about the how we should deal with broadly in paralytic squint. Now we will be discussing each nerve. I'll be speaking on management of third nerve. So we arrive at a clinical diagnosis. The definite diagnosis is by appropriate investigations. Neuroimaging, not strictly necessary in ischemic palsies, but if you are following up a case as an ischemic palsy and then the patient develops aberrant reinnervation, then imaging is must. Acute palsy, we wait and watch, except in compressive lesions, surgical management, if there's no improvement, for 6 months. Surgery in cases of third nerve palsy is a challenge to every ophthalmologist. Achieving parallelism in the primary position, what could be achieved at most, depending on the deviation and ocular movements, we plan the surgical procedures. In partial palsies, supramaximal recession of LR with the resection or plication of MR and might work. Operation on non-involved eye can be used to create a fixation duress and help in correcting exotropias and hypotropia according to the Schering's law, as has been nicely explained by Divya. So we'll take the mainstay of treatment till now in third nerve palsy was superior oblique tendon transfer, which is done in total third nerve palsy. because we have only two muscles which are active, that is lateral rectus and superior oblique. Superior oblique is disinserted and released from the trochlea and then sutured above the medial rectus after keeping the slight in adduction. And this is, of course, done along with the supramaximal recession of lateral rectus. Trochlear fracture is nowadays not recommended. Now, this is a case which showed a right ptosis, right exotropia with hypotropia. The secondary deviation is obviously more than the primary deviation, which you can see, and a right adduction, elevation, and depression deficit is present. This case, we did a supramaximal recession of right lateral rectus with transposition of right superior oblique to right medial rectus. We could achieve a good result in the primary position, though the ptosis remained and there was a decreased adduction, elevation, and depression. In cases of complete third nerve palsy, the periosteal anchoring of the medial rectus, or as we say, the anchoring of the globe to the periosteum, is a procedure which gives a desirable result. Here, this procedure fixates the eye at a desired position with the help of non-absorbable suture between medial rectus and anterolacrimal crest via DCR-like incision, and this is combined with a supramaximal recession of LR. Now, this is a case of a complete third nerve palsy, as you can see. Following a road traffic accident, he had a right-sided severe ptosis with a large angle exotropia of more than 80 prism diopters. Left exotropia was much more. All the movements in right eye were restricted except abduction. Bell's was absent. So we did this procedure. As you can see, the DCR-like incision is made and a non-absorbable suture is taken from the ligament, anterior lacrimal ligament there near the crest, lacrimal crest. And after taking the suture, it is brought out into the orbit above the medial rectus muscle. Slightly older video, so it's not very clear, but tells us the steps which are required. And after the needle is brought out in front of the medial rectus, the suture is tied to the sclera in front of the medial rectus. After keeping the eye somewhat in adduction, this is how the suture is tied. This is the post-op result showing significant correction of exotropia, but since he had a severe ptosis with absent Bell's, we had to give him an crutch spectacles. Now, this was another case, a 37-year-old male with a deviation of left eye outward drooping since birth. He had a severe ptosis with Marcus gun phenomena. Bell's was defective, but he had an element of pseudotosis, which is seen in many of the patients. See, when he's fixating with his left eye, the ptosis is very less. So, in order to take care of this, these are the pre-op photos. He had an 45 to 50 prism diopters of exo with 35 prism diopters of hypo, and there was a depression of adduction, elevation, and depression. And this, we did a lateral rectus recession on the right eye with superrectus recession, and left eye lateral rectus recession of 9 millimeters with plication of 6 millimeters, and inferior rectus recession of 6 millimeters, which significantly corrected his exotropia and hypotropia. And this is the video which is showing correction of exotropia and hypotropia. But we couldn't correct the ptosis very well. Probably we should have done more amount of superior rectus recession. Then the Y-split and medial transposition of LR introduced by Taylor and then Kaufman. In Gokikit's modification, the split tendon is passed beneath the SR and SO superiorly, inferior rectus and IO inferiorly, and tied 1 millimeter posterior to the upper and lower border of medial rectus. And I'll just show this case. She had an traumatic third nerve palsy on the right side, and in brief, this is the procedure. I don't know, we might have to stop the video in between. This is how the split nasal transposition of LR is done to MR. She had a very, very tight LR, as you can see in this video. Sorry. I was trying to push the video forwards. Yes, basically after making 2 slips of the superior rectus, see how free the eye is after this. And then the slips are brought out beneath the inferior oblique and inferior rectus muscle. We can even cut the oblique and inferior superior oblique muscle so that it makes it easier for us to see. This is how the inferior slip is brought. And then just a minute, I'll just finish this. And this is the medial rectus, and they are brought to the posterior border and superior border of the medial rectus and tied, can be tied on adjustable also. Okay, so just a last, though in this patient we didn't get a very good result, probably because the muscle was very tight, and probably we should have done a larger of the lateral rectus muscle. And then we did a periosteal fixation of a LR, and the result was better. And thanks for a patient listening. I'll stop sharing now. Varsha?
Yes.
Start your.
First, good afternoon, everybody. I would like to thank Bhave Madam and Scientific Committee MOS for giving the opportunity.
Share screen.
Yes.
Share your screen.
Yes. Is it visible, madam?
No.
Is it visible?
No.
नहीं visible नहीं.
Varsha, can Rishi
Just a minute, madam. Yes, madam, he can start.
I think you just sort it out. Open the presentation on your laptop, and then I think Rishi, you can start your talk so that we can take Varsha's after that.
Okay, just a minute.
Yeah.
Meanwhile, can we take, ma'am, some questions?
Yeah, if there are any questions in the chat box. Yes, Neelu, you have anything in mind? Rishi, are you ready?
Karun Pauka, madam. Karun Pauka.
माझा आहे म्हणजे मला करून पाहता का?
करून पहा.
मला फक्त शेअर स्क्रीनचा ऑप्शन आला नाहीये.
Is it visible, madam?
Yes.
Now it is visible.
Make
Yes.
it screen.
Yeah.
Full screen खाली असतं ते.
Oh. Is it full screen now?
Yes. Yes.
Yes, sorry for the delay. I would like to discuss the fourth nerve palsy case-based approach. Fourth nerve, as we all know, it supplies superior oblique with action of that is the longest muscle with action of intorsion, depression, and adduction. Fourth nerve palsy is a common ocular motility defect. It can be unilateral, bilateral, and may be masked bilateral, and one must be aware of that, which is seen in again at around 10% of cases. It can be congenital or acquired, and this differentiation is also very important because congenital squint, well compensated, may get suddenly decompensated due to fever, injury, and patient may present as diplopia and confuse as recent onset. And so in such cases, unnecessary tests can be avoided, whereas in acquired squint, neurological and medical investigations, as already discussed, are mandatory. This difference between congenital and acquired already discussed, but most important thing I would like to just emphasize, the facial asymmetry one should not miss, and the ocular torticollis, which is in long-standing cases doesn't disappear on closure of one eye, whereas in acquired palsy, it disappears if the one eye is closed. So the presentation of superior oblique palsy is with vertical and torsional diplopia. There is abnormal head posture, head tilt to opposite shoulder, and there is concomitant hypertropia, A pattern strabismus. It could be mild. As you see in this case, there is hypertropia in down and adduction. In moderate case, there is hypertropia in adduction, and in severe case, there is hypertropia in primary position. So that way we can grade the superior oblique palsy. In coming to the principles of management, in congenital palsy, management depends at what age the patient presents, what are his complaints, and surgery is indicated only if there is abnormal head posture, diplopia, and hypertropia. Basic principle is weakening of inferior oblique or straightening of superior oblique. There is a NAPS classification is a very good guideline for deciding which muscle to tackle. Along with that, sometimes we need to do ipsilateral superior rectus recession or other contralateral inferior rectus recession surgery along with horizontal muscle surgery, depending on the type of squint is necessary. So this is a 5-year-old female with a slight head tilt to right shoulder with chin depression. There's V isotropia with alternating hypertropia. And on Park's three-step test, there is a confirmed bilateral superior oblique palsy. On undoing her head posture, we can see a large isotropia with a hypertropia. So these are her 9-gaze photographs with inferior oblique overaction 3+ and bilateral superior oblique underaction. So in this case, in the plan of action is inferior oblique recession with anterior positioning with medial rectus recession. And one must remember that preoperative attention to exaggerated post-duction test is very important to rule out the tendon laxity. And that this procedure corrected her abnormal head posture, torticollis, and hypertropia. This is an 18-year-old boy, asymptomatic up till now, came with the complaints of intermittent vertical diplopia after high-grade viral history of high-grade viral fever, headache, and eye strain. And examination, he had head tilt to right shoulder with facial asymmetry. There is hypertropia of about 10 PD, increasing in the right gaze and on tilt to the left side. So the Park's 3 test was positive for this patient, and inferior oblique overaction was of grade 2. So the old photographs and the facial asymmetry gave the clue that it was a congenital esopalsy decompensated after fever, giving the symptoms of esthenopia. So this is a short video. In this case, he needs surgical correction for diplopia as there was no relief with the glasses. So this is a inferior oblique Park's recession, inferior oblique isolated, disinserted, and then secured with the 60 Vicryl. And I've taken videos from Bhave madam. Thanks for sharing, madam. And then it was resutured after securing with 60 Vicryl. This is inferior rectus hooked and 2 millimeter lateral and 3 millimeter below the lateral border of inferior rectus. The muscle was sutured. So this procedure corrected his hypertropia. Slight head tilt was improved, but because it was old, total torticollis could not be. But he was symptoms free, and his diplopia was disappeared. This is again a 39-year-old male with complaints of eye strain, vertical diplopia, and especially while playing badminton recently. And he was nearing presbyopic age, so he came for refraction. but he never noticed abnormal head posture, facial asymmetry before, and there was no relief with the glasses. On examination, he had right hypertrophy of 20 PD, rotation of 8 degrees, and 3+3 inferior oblique overaction. And again, in this case, also old photos confirmed that was a congenital and now decompensated, giving him asthenopia during his presbyopic age. So these are his 9-gaze photograph. Definitely, the treatment Parkes 3 test also confirmed the diagnosis, haze screen, diplopia charting, already discussed by Dr. Neelu. So definite surgery is to relieve his symptoms. Inferior oblique recession with total anterior positioning was done. Entire width of inferior oblique was reinserted into the anterior to the inferior rectus. In this case, again, head posture did not improve because of the permanent torticollis, but he was comfortable in all gazes as fusion improved. And another indications of surgery in superior oblique is when the tendon is very lax. This patient had exaggerated FDT showed that their superior oblique is lax, and so superior oblique tuck was done in this case. Here only inferior oblique overaction is very minimal or absent, and maximum gaze involvement is in depression. So this is a small video of superior oblique tuck where the superior oblique is isolated and then hooked, and then with a after total separation 4 mm on either side, that will give you around 8 mm effect of tucking with a 5-0 ET bond, non-absorbable suture. The sutures are given, and then the so this improves the strengthening. This has a strengthening effect in the down gaze, and one should not miss this laxity of the muscle, otherwise you may not get appropriate symptoms pre-patient. Then this photograph of the patient showing comfortable down depression gaze. Then this 48-year-old man came for refraction without any symptoms. It was diagnosed in routine eye checkup, well compensated. So such patients don't need any treatment or surgery. So I would like to just emphasize that congenital cases may present at any age. So depending on the presentation and complaints, we have to decide the plan of action. Then a word about Harada-Ito. This is procedure is done only to strengthen intorsion. And again, acquired palsy already been discussed. In such cases, there is sudden onset diplopia, and we have to investigate these patients to rule out the cause, post-head injury or post-viral fever. So the neurological assessment is important. During follow-up, you have to look main emphasis on his chart to know the see the contractures, and if surgery decision is crucial before contractures develop. So follow-up is important in cases of acquired palsies. And depending on the etiology, prisms, patch and surgery, and exaggerated FDT, again very important to rule out lax muscle. So coming to the conclusion that decision making is crucial at every step of management of fourth nerve palsy. Congenital SO palsy cases can present at any age, but decision depends on the symptoms of presentation. Acquired palsies, proper investigations, regular follow-up is essential to decide the timing and procedure of surgery. So superior oblique surgery properly done is safe, effective, and yields results that cannot be achieved by any other method. So one has to be very careful in doing this surgery to have good results. Thank you. Thank you for the patient hearing.
Thank you, Varsha, for a very nice presentation on oblique muscle fourth nerve palsy. Can you start sharing?
Yes, madam. Yes.
So, Rishi, go in with your presentation, and then if we have time, we will discuss some. Neelu, if you have some queries, please keep it ready.
My screen is visible?
Yes, yes. Make it full screen.
Yeah, just a minute. So, shall I start, or want to take up a question?
Start.
Okay. Okay. So at the side, I would like to thank Dr. Bhavi Madam to make me a part of this particular instruction course, and MOS for giving us an opportunity to share our views about paralytic strabismus. We have, I think, almost extensively covered most of the topics. So I will be just discussing the salient features which perhaps might have been missed in sixth nerve palsy. Sixth nerve palsy is actually the commonest paralytic strabismus, and among them, the most common cause is ischemic or something related to diabetes or hypertension, which happens in elderly age group. In younger age group, trauma can be a cause of it, or in younger children, post-viral infection or vaccination can present with sixth nerve palsy, but usually it recovers with time. In middle-aged ladies, if sixth nerve palsy is present, it can be a false localizing sign associated with raised intracranial pressure, which might be a benign intracranial hypertension or a space-occupying lesion. Congenital sixth nerve palsy is not that common compared to fourth nerve palsy, as Varsha Pandey Madam just mentioned. The salient features or the most important feature is patient will have a sudden onset diplopia and abduction limitation. But this is not the only cause for it, and there are many other cases where sixth nerve palsy or apart from sixth nerve palsy, you can get these presenting features, which I'll be showing just now. In addition to that, the patient has a face turn on the side of the affected muscle, and usually, if depending upon which eye is being used for fixation, the esotropia will vary. If the normal eye is being used, it will be a small angle iso. But if sometimes, for some reasons, the patient has starts using the paretic eye, then you get a secondary deviation, in which case the iso will be larger. Always look for the palpebral fissure changes. As in this patient, he had this squint entity since early childhood. He had abduction limitation, but as you can see, on attempted adduction in the left eye, he has an upshoot, and there is narrowing of the palpebral fissure, as very well seen. And he had abduction limitation, which is one of the most commonest mistake done. This is not sixth nerve palsy. This is the case of a Duane syndrome. Usually Duane syndrome patient doesn't have diplopia, and they have palpebral fissure changes, and it is there since early childhood. Sometimes you will get a large angle squint, as in this child, since early childhood, and they also tend to have abduction limitation. It's not abduction limitation as such. It is basically cross fixation, which the child develops in order to counter the loss of stereopsis or binocular vision. It's a case of an infantile esotropia and not a sixth nerve palsy. This needs early surgery. Coming to the other squint entity, which might mimic a sixth nerve palsy, as in this girl, she had a sudden onset squint, and she also had a diplopia. She had a esotropia, as usually seen in sixth nerve palsy, but the ocular movement is full. This indicates that it's a comitant esotropia. It's not an incomitant esotropia. There exists an entity called acute comitant esotropia, which she had, and I mean, this can also mimic like a sixth nerve palsy. So coming to the sixth nerve palsy cases, I'll just show you how to go start about it in diagnosis and then the further management. This patient had a sudden onset binocular diplopia, face turned to the left side, as you can see very well. And when we force him to use the left eye for fixation, the amount of ESO is much more. This is secondary deviation compared to the primary when the right eye is being fixated. So this is basically a case of a sixth nerve palsy. Without doing ocular motility itself, you can realize that perhaps this is a paretic squint. Coming to another patient, he had a trauma. A gate fell on his head, a poor child actually. And you can see that on attempted right eye fixation, the amount of ESO is much more. He also had a facial nerve palsy in the left side. And you can see that the ESO is much more in the right eye when the right eye is being fixated compared to when he is using the left eye for fixation. The ocular movement also shows abduction limitation, as you can see now. There is hardly any abduction in the right eye. So this is a case of a sixth nerve palsy, a traumatic. Coming to one case, an interesting case of a 64-year-old male who had diabetes and a sudden onset horizontal binocular diplopia since 1 week, and he had a poor glycemic control. Around 369 was his sugar when he presented to me. He had been operated for the right for cataract, so that's why his vision in the right eye was better than the left eye. Binocularly, you can see that he has a left esotropia. The eye which is squinting does not necessarily be the paretic eye. Remember this. So basically, because the vision in the right eye was better, this is what you see is the secondary deviation. Because on abduction, he had mild abduction limitation in the right eye, and diplopia charting definitely reveals that on attempted abduction in the right eye, the diplopia increases, or right gaze the diplopia increases, which is also what you get in orthoptic evaluation. So basically for sixth nerve palsy, you don't need to assume things because sometimes it might be different than what you can actually get. So because he wanted rapid relief from the diplopia, he was a consultant to a software company. We decided to go ahead and give Botox. Usually I don't give more than 3.5 to 4 units of Botox. It can be given under visualization, which ensures that it goes into the desired tissue. It is more like doing a surgery itself. But the advantage of Botox is that it is temporary, and in case of ischemic sixth nerve palsy, usually the recovery, they anyway recover, but you get a diplopia-free interval earlier than what it would have been otherwise. Also, it helps in reducing the contracture of the medial rectus. Botox can also be given using a superior rectus forceps, as in this child who had a traumatic sixth nerve palsy in the left eye. We used a superior rectus forceps, and under sedation, we had anesthetist with us, and I injected around 2.5 to 3 units. Botox doesn't have a cumulative effect. If it doesn't mean that 20 units, 20 prism diopter of ISO will need less Botox and 40 will need more. It is not like that. Usually, we don't give more than 5 units at a time. So this was for this particular patient that the isotropia increased. Just the last case, a 52-year-old female who had diabetes and a sudden onset horizontal diplopia. She had a left face turn. So we'll assume that probably this is sixth nerve palsy. Left face turn means left-sided patient, sixth nerve palsy, and probably diabetes is the cause. It is a sixth nerve palsy, obviously, but don't assume things, as I told you. You need to do a complete evaluation, including fundus, because sometimes you might get this. So she had a post-papilledemic optic atrophy. And again, don't assume that it being a middle-aged lady, it might be perhaps a false localizing sign because of raised intracranial pressure. Go ahead and do an imaging, because sometimes the imaging might show something else. Like in this case, it was a case of acoustic neuroma. CP angle tumors are the commonest in space-occupying lesion causing a sixth nerve palsy. So to conclude, sixth nerve palsy should be suspected in all cases of sudden onset horizontal diplopia. You have to individualize case, take a thorough clear history and clinical examination, and that will help in deciding the diagnosis and management plan. The treatment is case-based. Every case is different, and you have to decide the treatment based upon an individual case. And always try to maintain, the aim should be diplopia-free field in the primary gaze and down gazes. It may not be possible in all the gazes. So the aim of our instruction course is to provide a diplopia-free world to all our patients. Thank you.
Very well presented, Rishi. I think you should have just added the surgical part to the management, but the transposition or the naps or whatever we do. Any questions? Do we see anything in the chat box?
For sixth nerve palsy, madam, for mild cases, we can do a recess reset. We didn't used to do it, but even for paretic muscle, we can do a resection for the sixth nerve palsy, just like for a routine case. Except if it is very severe, then we can do transposition of the superior rectus and inferior rectus along the lateral rectus. That can be added.
So if the forced generation test, you should do a forced generation test. If there is a tuck, when we feel in the lateral rectus, then we can do an resection and recession of recession procedure in sixth nerve palsy. So FGT is important in deciding whether there is any force left in the lateral rectus muscle.
Yes, ma'am. Like what we have discussed, the two fundamental points that will help us in decision making is the power the paralytic muscle that has gained, whether it is moderate or good, or it has very minimally or not at all recovered.
Yes.
And also the gaze in which the deviation is more. Yes. So if it is towards the side of the antagonist, it is better to release the antagonist. But if it is more towards the side of the paralytic muscle, we have to balance the weakness with the yoke muscle. This is because if we keep on recessing the antagonist along with resecting, we will, whatever the opposite side of diplopia free field is there, that is also will create incompetence. So depending on which gaze it is, we should plan accordingly those two muscles or three muscles.
If it is a If it is a mild paresis of lateral rectus, then and primary position, if there is no esodiviation, no significant, you can even get away with just applying Faden to the contralateral medial rectus. I've done it in a patient where she had only an esodiviation in the affected side, that is the left side. She had a mild left lateral paresis, and esotropia was only in the left gaze, and primary position she was almost diplopia free, but even that gaze was disturbing her. So the recession of the medial rectus would have caused an exotropia in the primary position. So I went ahead and did a Faden to her right medial rectus, which reduced the esophoria in the left gaze. So even that works. It is basically when the paralysis is very large, then it is easier to manage. But when it is very less,
actually the smaller angles are much more bothersome, especially in small diplopia and primary gaze. So
you have to put on your thinking cap more in cases of small angles than when the angles are very large.
And maybe the patient are also psychologically well prepared that perhaps the complete relief from this condition may not be possible, especially if the angles are very large. So we have to balance it. But many of the cases are actually milder forms of sixth nerve palsy, and many of them are ischemic, so they usually recover with time. So you have to provide the diplopia free period earlier for them. So that's good.
Any other question? Yeah.
Rishi sir, any tips to avoid this peelage of the buttocks?
There are, I have shown only two ways. When you are injecting under visualization, 2 points only. After injecting, just keep the needle there for some time, because that, the passage of the needle, also the drug can spill over. And after removing the needle, immediately you put a cotton tipped applicator so that the drug remains into the muscle belly for a longer period of time. If you are doing it with a superior rectus forceps, then after injecting, hold the needle there for say around 10 to 15 seconds so that the drug doesn't spill over. Spill over of the drug results into ptosis. That is the most common complication you might actually encounter with. And try to put it into the belly, not into the tendon.
Do you have any experience in using it for obliques? Because they have mentioned in superior oblique palsy. What of inferior oblique? This was one of the treatment mentioned.
To make 1 point for the fixation duress in a third nerve palsy, especially when they have a pseudotosis because of large hypotropia, as I had shown in that case. But I did small amounts of superrectus recession. It is described that we do up to 8 to 10 millimeters or even 12 millimeters of recession in uninvolved eye, so that we don't allow that eye to go up, and that will create a fixation duress, and which will make him
reduce the ptosis in the other eye.
Ptosis in the involved. So that is what we can even do an inferior rectus resection along with superrectus recession in the uninvolved eye.
Can we take one more question?
No, I think it's the time is 12 o'clock. So
yes.
Okay.
I thank all my speakers for actively participating in this workshop. Everyone spoke very well, and thank MOS for giving us an opportunity to do this IC. Thanks a lot.
Thank you.
Thank you, ma'am. Thank you, everyone.
Thank you, ma'am.
Thank you, everybody.
Thank you, ma'am.
Okay.
Stop. Leave.
Good morning. Good morning, all. Can you hear me?
Yes, ma'am, you are audible.
Good morning. Okay. Actually, I'm just waiting for a couple of speakers to join. Just give me a moment. Yeah. Then we'll just begin in 2 minutes. Okay, I think we will begin the session. So good afternoon all. Today we are fortunate to have all great teachers for chairing our session. The chairperson today is Dr. Vaishali Une, who is the associate professor and head of the department at Dhule GMC. And she has many accolades to her credit as national, international presentations and publications. Our co-chairperson is Dr. Jyotika Mishri-Kodkar, ma'am. She is a professor and head of the department at MGM Medical College, Aurangabad, who has a vast teaching experience of 28 years. And she too has many presentations and publications to her credit. And last but not the least, our second co-chairperson is Dr. Rajesh Sinha, who really needs no introduction. He is the professor and of cornea anterior segment, cataract surgery and refract surgery at AIMS. He's the joint secretary, treasurer of AIOS, and with 325 publications to his credit, it is really indeed a pleasure to have you here, sir, today. Thank you so much for coming. And lastly, I would introduce Dr. Neha, the moderator. I don't see her. She is a young, bright ophthalmologist.
ILNP in management of
practicing from
retinal detachment.
I think someone.
Congratulations, Dr. Bavanpure.
Dr. Snehal, hi, good morning.
Good morning, ma'am. Actually, I'm searching for the moderator.
I know. So, Dr. Snehal,
Good morning.
I would like to. Good morning, Rajesh Bhaiya.
Good morning.
Good morning, Rajesh
Ragini.
Bhaiya. Good morning. Good morning, Jyotika ma'am. Everybody, good morning. Good morning. Good morning. Deshmukh ma'am. So, hi, Jyotika ma'am. Snehal,
Yes, ma'am.
Hi. So, everybody, Snehal has made a lot of effort, and I think a complete effort to put this lovely session together. I really take this opportunity to thank Dr. Snehal for this beautiful lineup of stalwarts, and thank you, Rajesh bhai, Jyotika ma'am, Dr. Pradnya ma'am, and Mitali ma'am, and everybody here. Snehal, over to you.
Very much.
And I won't interrupt your session. I just wanted to say hello and thank you.
So,
Some difficulty?
Recording in progress. Also given to Dr. Prashant.
I think the awards function is getting relayed here.
Neil, you're on mute.
Okay. So I'll introduce Mitali Shah. She has completed her MS from MGM Medical College, Aurangabad, and she has completed long-term pediatric ophthalmic fellowship from LV Prasad. I request her to please give her talk on allergic conjunctivitis. Thank you. Mitali, please share your screen.
Am I audible?
Yes.
Yes.
My screen is visible?
Yes.
Yes. Yes.
Good morning, everyone. Today we will discussing the allergic conjunctivitis. Seasonal allergic conjunctivitis and VKC are the most common type of allergic conjunctivitis which we come across in our day-to-day OPD. Seasonal allergic conjunctivitis is IgE-mediated inflammatory response, and the clinical features are itching, redness, and chemosis. Different classes of drugs are available, but most of the time, vasoconstrictor and antihistaminic will suffice. VKC is the most common chronic, most difficult type of allergic conjunctivitis to treat. Epidemiology of VKC is described by Sangwan et al. In IJO 2013 in retrospective study in detail. Etiopathogenesis of VKC is same as the seasonal allergic conjunctivitis. Only difference is in VKC is a IgE with T-cell bound mast cell stimulation, and that's why the inflammation is more as compared to seasonal allergic conjunctivitis. The clinical features of VKC is same as all other allergic conjunctivitis. Tarsal form of VKC is graded as small, medium to giant, and the cobblestone papillae. Whereas in limbal form, we can see the flat, elevated, and the confluent papillae. In corneal involvement, it can vary from superficial punctate erosions, microerosions, macroerosions, and the shield ulcer. Progression of disease can lead to keratoconus, astigmatism, limbal stem cell deficiency, and shield ulcer. Once the diagnosis is made, grading of the VKC is important to select appropriate treatment. If we follow the classification given by the Bonini et al., we can see that from grade 0 to grade 2A, there is only conjunctival involvement, whereas in grade 2B, there is a little amount of a corneal involvement. In grade 3, we will get the limbal involvement along with the little corneal involvement, and in grade 4, there is a shield ulcer. The another classification is given by the Vokle et al. And published in the ISO 2016. According to them, in mild grade, we will have the conjunctival inflammation. In moderate to intermittent, we'll have the little limbal involvement and the corneal involvement. And the intermittent disease they have written is inflammation of and medicine of period more than 2 to 3 months or maximum 3 to 4 episodes per year. In moderate and chronic, we'll have the cobblestone papillae. Chronic disease they have defined as an inflammation-free or medicine-free period less than 1 month. In severe classification, we'll have the exaggerated conjunctival form, limbal form, and the corneal form, but we will not see the shield ulcer. Whereas in blinding, we will see there all other signs are present along with the shield ulcer and the limbal stem cell deficiency. Limbal shield ulcer is graded as a grade 1 if the base is clear. Inflammatory debris with base is grade 2 and the elevated plaque as a grade 3. All grades of VKC require non-pharmacological treatment in the form of protective glasses, avoid exposure to allergen, change of residence or workplace, cold compression, and avoid eye rubbing. Coming to the treatment, different classes of drugs are available for the treatment of the allergic conjunctivitis, such as vasoconstrictor, antihistaminic, mast cell stabilizer. In mast cell stabilizer, we have to start the drug as a prophylactic agent, and the dual acting agent having the action antihistaminic and the mast cell stabilizing. The drug available are the olopatadine, bipotastine, alcaftidine. It has to be given for a longer period like 2 or 3 months, which reduces the frequency of the disease. Coming to the corticosteroid, we have the soft steroids and the potent steroids. In soft steroids, we have lotepred and the FML. If we compare the lotepred with the FML, lotepred has the more conjunctival penetration than the FML. These are called as a soft drugs because they have the lesser intraocular penetration, and that's why the side effects like the cataract and glaucoma, which are associated with the potent steroids, are the less. Now coming to the immunomodulators, we have the cyclosporine. The available commercial strength of the cyclosporine is the 0.05% to 0.1%. But for the treatment of the VKC, the concentration required is more. That has to be ranging from the 0.5% to the 2%, which can be formulated by mixing the commercial available injection cyclosporine, and also the orosporine 2% is available commercially. Coming to the tacrolimus, it was originally prepared as a dermatological preparations, but nowadays the tacrolimus eye ointment is also available. If the conjunctival application tolerance is poor, we can shift to the eyelid application. Coming to the treatment protocol, if it is a mild VKC, we should start avoidance of the allergen, lubrication, and the dual acting agent. If it is a moderate intermittent, we should add the lotepred in pulse. Means we can give for the 4 times a day for a week and then stop it. If it is a moderate and chronic, we will shift from the lotepred pulse to the lotepred tapering fashion. Means it should be given like 4, 3, 2, 1 for a longer period of time and added with the cyclosporine at 0.5%. If it is a severe, we should change from the lotepred to the potent steroid, and the concentration of the immunomodulator drug should be increased. If there is a presence of a shield ulcer, sometimes there is needed to start the oral steroid. and the surgical treatment is required for the grade 3 shield ulcer. For the surgical treatment for the papillae, we should do the we can go ahead with the supratarsal steroid injection, cryotherapy, and the excision of the papillae. GPC and the atopic keratoconjunctivitis are the other types of the allergic conjunctivitis. Now coming to the some cases, here we can see there is a papillary conjunctival involvement along with the limbal involvement, but there is a no corneal involvement. It is graded as a moderate intermittent type of a VKC, and then we'll follow the algorithm like the avoidance of the allergen, lubricating, dual acting agent, and the loteprate is given in the pulses. Now here we can see there is a no limbal involvement, no corneal involvement, only the conjunctival involvement. It is graded as a mild VKC, and we will follow like the avoidance of allergen, lubricating, and the dual acting agent. Here we can see there is a conjunctival involvement along with the limbal involvement, and there is a superficial punctate keratitis. It is graded as a moderate intermittent, and the same algorithm like the ALHM with the loteprate pulse is started. Here we can see there is an exaggerated conjunctival reaction, limbal reaction, and the corneal reaction. It is graded as a moderate chronic, and all the treatment is given, and the loteprate pulse is converted into the loteprate tapering fashion, and along with the cyclosporine started. Now here we can see there is a shield ulcer, then it is graded as a blinding condition, and all the treatment like our protocol ALHM is started, and the potent steroid can be given in the pulse fashion or in the tapering fashion along with the immunomodulators and the plaque debridement along with the amniotic membrane transplant. And for the severe grade papillae, we can give the supratarsal steroids. My take-home message from this presentation is grading of VKC, treatment protocol, guide us to use potent steroid appropriately, exact time to start steroid sparing agent, which will arrest the progression of disease and prevent the complication like cataract and glaucoma. I would like to thank Dr. Thakre Madam and the MOS committee for giving me this opportunity. Thank you.
Okay, thank you, ma'am. That was an excellent talk. It gives me great pleasure to invite our next speaker. We have Dr. Rajesh Sinha, who is a renowned cornea surgeon, and he'll be talking about pediatric corneal trauma today. Over to you, sir.
Thank you. Thanks a lot, Dr. Mitali, and thank you, Dr. Ragini and Dr. Thakre, ma'am, for inviting me in this session. I'll be talking about pediatric corneal trauma. Now, this is a certain topic which situation which we encounter very often. We, in our emergencies, we do get cases of pediatric corneal trauma, wherein we have to manage the patient as soon as possible. So this ocular trauma accounts for nearly 8 to 14% of total childhood injuries, and it can be blunt, penetrating, or can be blast injury, can be chemical injury. And long back in 2002, we had published this article wherein we found out that we just published an article related to pattern of pediatric ocular trauma in India. And we found out that the household appliances and the bow and arrow injury, particularly bow and arrow injury, was more commonly seen because the study was done in the northern part of the country, wherein in the second half of the year, wherein Deepavali and Dashera, after these festivals, children like to play with bow and arrow. So that was one common cause. But another very important cause was, unsupervised sport. And we concluded that children should be supervised when they are playing with anything. Particularly, one should avoid using sharp instruments. Another article which was published from our center was bursting of tuna packets causing alkali burn in children. So all these injuries are very commonly seen. Now, corneal laceration, which we do encounter in our day-to-day practice in our emergencies, is something which is very commonly seen in children. And it can be partial thickness, it can be full thickness. Now, if it's a partial thickness, but if the flap, if there's no avulsion kind of thing, or there's no separation of the edges, then in that case, you can just put a bandage contact lens and that will manage. But if the margins are apart, then in that case, you have to put a suture, even in a partial thickness laceration. In a full thickness laceration, you have to put a suture or multiple sutures depending upon the type of injury. Now, if it's just a laceration, you can repair it. If there is UL incarceration, you have to deposit, or you have to abscise partially or totally full thickness of the tissue which remained incarcerated or prolapsed for a long period. If it's more than 72 hours period, then there's always the risk of causing endophthalmitis and infection in the eye if the tissue is deposited in the same manner. So it should be partially removed, or a layer, a membrane can be removed, and that is how we can prevent infection. And of course, intracameral antibiotic, etc., helps a lot. Now, as far as anesthesia is concerned, in children, there's no other option. The only option left is general anesthesia. Even in adults, one should try to avoid topical or local anesthesia. When there is a adnexal injury as well as the globe injury, so the globe injury has to be repaired first, followed by adnexal injury. Certain things that we have to follow, like the corneal wound is repaired with a 10-ohm monofilament nylon suture, while the scleral wound can be closed with a polygalactin suture. Then if in a corneal injury, if there are bends, then the bends have to be handled first. If it's involving the limbus, then the limbus has to be managed first, because if you oppose the limbus, because this is a landmark which is very clearly visible, so which demarcates cornea and sclera. So opposition of the landmark is essential in order to maintain regularity of the corneal tissue. And that is very essential. So limbus first, and then of course any bend. And then of course the suture should be placed in such a way that if you make a triangle, then the edges should oppose. So the distance of the suture should be in such a way that it should form a triangle with the ends opposing. So that is how it should be done. And if the corneal injury is involving the central part of the cornea, then the suture's bite should be small, because suture bite can also cause some scarring. So the bite in the center should be small. As you go to the periphery, the bite will be bigger. And if you are doing, if it's a corneal scleral laceration, then in that case, the corneal suturing is done first limbus, then cornea, and then sclera. That is the usual trend. But there are certain scenarios wherein you can do sclera first as well, in order to maintain the regularity of the globe. And I'll just show a couple of case scenarios. This is a case of a corneal perforation, wherein there's a uveal prolapse. So you have to create a paracentesis first, inject viscoelastic, and then release this uveal tissue incarcerated from the wound, from the paracentesis. Don't try to push it from the main wound. So you have to create a paracentesis, and then you put sutures, and then you can put a suture in the periphery. Both peripheries can be sutured, and then you keep bisecting. This is how you should do, and that will be the end of it. Now, if you have a corneoscleral perforation, then as you can see here, there is so much of membrane formation as well. So you have to do a little bit of peritomy to see how much is the scleral involvement. And then once you have done it, the first suture, as you can see here, is the alignment of the limbus. And after aligning the limbus, what you do is that you, through the paracentesis, you try to reposit the iris tissue as well as, in the anterior chamber, then put a suture in the periphery. So one periphery has already been, secured. Then you put another, and then you keep bisecting. So you have put one suture here, one here, and then you will put in the center. So you'll keep bisecting the sutures, then you bisect here, then you bisect here. And this is how you keep bisecting. And then after that, you put a scleral suture, and that is how you close the globe. Now, some people do prefer putting scleral sutures first. If you do feel that, majority feel corneal sutures should be put first after the limbus. But in some scenarios when the globe is collapsing badly, there's a lot of vitreous has been lost. In that case, you may do a scleral suturing first, and then, secure the integrity of the globe and complete the corneal suturing. If there's a tissue loss, then in that case, you have to do a patch graft. You may use a conjunctival flap as well. You may use a amniotic membrane. And of course, a very small defect or fistula can be healed with a glue. Corneal foreign body, if you see a patient, if the child is complaining of something entering into the eye, causing irritation, etc., one should definitely be examined on slit lamp, and the foreign body, if it is visible, should be removed with the help of a needle. Sometimes the child doesn't cooperate. If it's a small child, then in that case, it has to be done under general anesthesia. As far as chemical injury is concerned, the goal of management is to remove the chemical and check the pH. So wash the eye, that is the most important thing. And then once you have completely washed, wait for 5 minutes and then check the pH. And if the pH is normal, then it is complete. And then, of course, to remove the particulate matter, you have to do a lid to remove the particulate matter, evaluate the damage. And after evaluating the damage, you have to manage the patient conservatively with the help of vitamin C, citrate, lubricants, steroid initially. And you have to remove the particulate matter as well. And amniotic membrane sometimes helps quite a lot in terms of relieving pain as well as epithelial healing in acute cases. So in conclusion, trauma is common in children, and most commonly it is the unsupervised sport that is played either inside home or outside that can cause damage to the cornea. Prompt and meticulous management is something which is very essential because these children have a long life to live, and in order to provide a good life for the children, a prompt and immediate management is very essential. Thank you very much for your patient listening. Any question, I will be willing to answer.
So I would like to ask a question.
Yeah.
Is the incidence of sympathetic ophthalmitis same as in adults for sclerocorneal perforations?
See, the point is this, that there's no comparative study, first of all, between children and adults in terms of sympathetic ophthalmia. So it is very difficult to say whether it is the same. The second point is this, that, in the current era wherein we have the management options has become so good that sympathetic ophthalmia is extremely rare these days. So since the condition itself is so rare that a comparative study between children and adults is going to be extremely difficult. So that is why there's no comparative study. So I may not be able to tell you the exact difference.
But have you any, do you have any experience of a child going into sympathetic ophthalmitis because of a large scleral perforation?
Not really, not really.
Okay.
I'm yet to see a child with a sympathetic ophthalmia because of a large perforation. I would like to have opinion from others if they have seen this. So,
Une ma'am, any comments from you?
Yeah, thank you, Dr. Rajesh sir. Excellent videos, and the technique was really helpful. And no, I haven't also seen any endophthalmitis in pediatric age group as such. Means, though we have sutured some very badly damaged cornea also, but fortunately enough, no endophthalmitis in.
no, but she is asking about sympathetic ophthalmia. So sympathetic ophthalmia, that's what you asked, no?
Yes. She asked about sympathetic ophthalmitis.
Okay. Yes, I've asked about sympathetic ophthalmia.
So I have seen endophthalmitis cases following trauma, but sympathetic ophthalmia in children, I'm yet to see a case. It is extremely rare condition. 0.01% is the prevalence, and most of the times all these studies have been done long back when the management was not that good. Now in current scenario, if you ask somebody who has done his post-graduation in the last 10 years, they may not have seen a case of sympathetic ophthalmia. So it's so uncommon, extremely rare, that it is something which I guess in current scenario is not a great cause of concern.
Right. Thank you.
Thank you, sir. We next have Dr. Gaurav Luthra. Dr. Luthra, as we know, is the director of Drishti Eye Institute at Dehradun He is also the chairman ARC of IIRSI, besides being in the managing committee of AIOS. Sir is also the chairman of awards committee of the Uttarakhand State Ophthalmic Association. He would be taking us through challenging pediatric cataract situations today. Sir, you may start.
Thank you so much, and very good afternoon to everyone, and sorry for running late 5-10 minutes. And very nice talk, Rajesh. I got the second half of the talk. Thank you. So I'll just share my screen. So I enjoy doing pediatric cataract surgery, and while I'm probably not in the league of some of the big pediatric cataract surgeons, but I'll try to share a few of the things that I've learned along the way. So this was one young child with bilateral, he's a case of juvenile rheumatoid arthritis with a very bad band-shaped keratopathy and a bad healed uveitis. So we had to do a 2-stage surgery where we first removed the band-shaped keratopathy and then waited 2-3 months for the cornea to stabilize. So after that, we realized that the patient had significant astigmatism, and this was when we decided to operate him later. And I did not do the band-shaped keratopathy removal. That was done by a cornea surgeon, and then I was given the task of treating the cataract. And here you can see that the synechia can be really bad. Most of these children have very bad festooned pupils, and you have to be gentle, yet you have to get these pupillary membranes off. Sometimes you have to cut them, sometimes you can peel them, and sometimes you can tease them. And you can then, I like to do this removal under viscoelastic plus infusion. So you can see that in my other hand is an infusion, which is constantly running, and that allows for the chamber to be stable and for the pigment to be cleared up as you go around doing the cleaning up process. And then you want to basically have a proper area for you to be able to proceed with the surgery. And of course, you'll see that a lot of the pigment can remain attached to the lens, and that can be dealt with later. Basically, you want to get a rhexis of a good size so that later on, if synechia do form, they will usually form till the edge of the rhexis. Now, in this case, we managed to get a slightly irregularly small rhexis, but I made up for it a little later, and I was able to complete the rhexis, but I had to still deal with some of the other challenges of the surgery and get the pigment cleared up from here. And then of course, removing the cataract is not such a big deal. And once that is done, here we were planning to put in a toric lens. Patient had significant astigmatism of about 2 diopters and was old enough, I think was in the range of about 8 or 9 years. So correcting the astigmatism was more predictable. And after this remained the challenge of enlarging the rhexis, because I didn't want to leave him with a smallish rhexis. Cleared off all the pigment there, and you can see that it's quite easy to do that. I don't like to put in viscoelastic very often, except right at the beginning of surgery during the rhexis. And later stages, I avoid putting any viscoelastic, and you can cut off some of these finer things which are hanging around from the pupil to get a perfectly sized pupil. And side port scissors are very good. These are MST scissors, I think, and they are very reliable. And now I want to enlarge the rhexis. So we'll manage to create a bigger rhexis here. So these cases are very gratifying, and you can finish off with a good procedure in the end. This child did well. We did both eyes. Both eyes had a similar kind of a situation, and I'd like to do the trypan blue test to check for any leakage at the end of surgery. I checked the IOP. This is how it looked like 15 days post-op. Pretty much, in fact, we did a toric check on the eye trace. Astigmatism was quite well corrected. So it was suggesting a 10 degrees rotation would give us a 0.3 improvement in correction of astigmatism, which is a good result. And the child did quite well and gained well, but that's usually not the end of the story. They need to be nurtured through because they'll continue to have issues. And going on, let me take you to, since our time is going to be limited, so I'll take you to another surgery. So here, this is an old surgery, but again here, this child had very high astigmatism, and we have now about 50 plus children with correction of astigmatism, but all of them have to be relatively older. You can't do it in small children. So once the astigmatism is more predictable and easy to measure, I think we've had very gratifying results over the last 5-6 years that we've done torics in children over the age of 6 years or so. And yes, they may later on still have some uncorrected astigmatism as they grow up, but if 80% or 90% of it is corrected, it still helps a lot. If they're left with, say, half or one diopter or in that range, and usually it helps. So here we had a PC plaque, and we were anyway intending to do a primary rhexis. And then you can obviously put viscoelastic, but not so much that the PC goes down too far, and have a relatively good fill of the chamber, but not a very deep fill. And then you can go with a controlled forceps. This is one of my older forceps, which I no longer use. Now we have a newly designed forceps, which works very well. And sometimes they are friable and unpredictable, but you can still usually manage. In fact, I find doing the posterior rhexis a little easier than the anterior one because it's more controlled. Yet, in some cases, as I'll show you probably in one of the later cases, where it can sometimes be a challenge to get the primary rhexis correctly. So here we were able to complete it and put in the lens into the bag and get a fairly well positioned IOL. A single piece lens. If your posterior rhexis is of the right size and you've not disturbed too much of the vitreous, you can do a vitrectomy in that case. And then here we did not do a sometimes you can. So here we were able to, this is a supraincisional pocket which I make, and I don't suture these children's corneas because that will induce astigmatism, and this is good enough to get a good seal of the cornea. So it's just a pocket which is created anterior to the main incision and hydrated. So going on, let me take you, since we have limited time, I'll just go on to the next one. And this is again a pediatric cataract where we do a smaller rhexis. It was an intumescent one. So here what we are planning to do probably is to make a smaller rhexis first and then enlarge it. And usually they're decompressing the lens as well and ensuring that the intumescence is controlled. And then you can go for a second round. And usually this is easier to, more predictable, and usually never runs out. So making a small rhexis first and then completing it with under viscoat, this frill of capsule will usually not run out and allows you to get a bigger rhexis. Once that is done, of course, doing the surgery is easy, but then doing the rhexis. So this was, I think, the case which I wanted to share where sometimes it can be challenging. We lifted up the small flap and then decided that we wanted to do the rhexis and pushing a little bit of viscoelastic there so that there's a separation between the anterior vitreous space, and here trying to make a rhexis. And as we started, it was this is a little bit of a high-speed video, so that's why you may feel those jerks. But as we went around, we realized that the rhexis was getting a little bigger. I was trying to keep it under check, putting in more viscoelastic at points, but it was tending to go almost the same size as my rhexis, which is not a good thing. It should always be a little smaller. And so you can see that it's tending to kind of go a little out of control. It's very unusual for this to happen because 90% of the time it's very well controlled. But since it was going like this, we managed to complete it, but it came out almost the same size, and I'll close in 5 seconds. The challenge was to put in the lens. We managed to put a 3-piece lens and did a capture, and we wanted to do a double capture. And as we tried to do that, pushing it on one side and the other side, we managed to dislocate the lens into the vitreous cavity, and then we had to kind of retrieve the lens. So this can be a challenge if your posterior rhexis is very big, and that's what I wanted to show. So then we put it out and brought it back and put it in the sulcus, and then did a single capture into the anterior capsular bag. With that, I think I'll stop. Thank you. I'm sorry, I would have loved to show 1 or 2 more videos, but we have to respect time. So
that was a very good learning experience.
Your videos were excellent, sir.
Thank you, ma'am. Thank you so much. And thank you for inviting me for this meeting.
Thank you.
Very nice videos and very good surgery.
Thank you. Thank you, Rajesh.
So our next speaker is Dr. Hemant Anaspure.
Very nice presentation, Fairuz. Thank you, ma'am. It's so much of passion. I think you could go on and on. It's almost like an encyclopedia. So much to convey.
Thank you, Dr. Hemant. Thank you, everybody. Thank you, Dr. Gaurav Bhaiya, for joining.
Hi, Dr. Ragini. Good morning. Good afternoon, actually. Thank you so much for inviting us.
Yes.
Dr. Hemant, who is the Director, Pediatric Ophthalmologist and Strabismologist at Sri Sarveshwar Eye Hospital in Aurangabad, will be talking about myopia progression management.
Dr. Hemant? Dr. Hemant?
Thinks has lost connection.
Dr. Hemant, you can please start your
I think he's
talk.
muted, so he'll probably need to unmute.
Yeah, Hemant, please
Yeah.
unmute yourself. Please unmute yourself. Huh? Yeah. We can't hear you. Talk. No, we can't hear you. I think you you leave and join again. You share the screen again. Till then, we'll take the next talk.
Okay, ma'am.
Hemant,
so
can you?
Okay,
Can you
okay,
be
I will
audible? Yeah. Start. We can hear you.
Yeah, you can hear it. Thank you.
Yes.
So first of all, thank you, Thakre Madam and the MOS committee for giving me this opportunity. I will be talking about the myopia progression management. Okay, this is one of my own patients, and if you can see this thing.
Go to full
she
screen.
came to me when she was just 7 years old, and that time she presented only with the astigmatism in the both eyes. Okay,
Hemant.
and then I'm following her almost every year.
Hemant, please go on full screen. Please go on full screen.
Okay.
Yeah, you do. You press
Is it
down
full
here.
screen now?
No. Press on the right hand side down.
No, right side down. I have pressed. Now? No.
Go to the slideshow at the right hand corner.
Yeah.
Is it full screen now?
No.
Not yet.
Go down.
Well, I'm pressing this. I can see full screen on my screen, but
okay, just go to the next slide. See if it is going to the next slide.
Is it showing full screen now?
No.
No.
Next slide. I think we'll have to. You leave and join again.
Go to the slideshow. No. He has to just click the.
Go to slideshow.
Slideshow. Go to the new share.
Down.
It is showing and.
No. Down. Right and down.
Hemant.
Oh.
Okay. Go ahead.
Can you see a full screen now? Still no.
Yeah, but we are seeing 3 slides of introduction.
Oh.
So it's not full screen.
Okay, you can carry on.
I think it's okay. Let him carry on. It's fine. Hemant, carry on. No problem.
Okay. Sure. Can you hear me?
Clearly, we can hear you very clearly. Go ahead.
Okay. So I will just continue with this thing. Okay. So this is one of my patients whom actually I'm following since she was just 7 years old, and now she's 14 years. So last 7 years I'm following. If you look at her spherical part, initial part, almost first 4 or 5 years, there was no spherical component into the refraction. And then slowly from April 2018 or say January 19 to 20, there was started having a spherical equivalent. Okay, spherical, sorry, not equivalent, but spherical power into the glasses. And last 1 or 1.5 years, almost it has gone from -1 to -3.5. Okay, so this is just shows us that how much the myopia is increasing. One reason may be a lockdown effect, or we don't know, this increased screen time, but she has shown increase. Another part is
Please
myopia has increased
change
after
to
she
the next slide.
Yeah, to the February to October. Now, as we see to the myopia is new epidemic the world is facing today. It is emerging as a public health problem. Some of the South Asian countries, they are showing a myopia prevalence as more than 50%. and other parts of the countries also it is increasing. In India, it is almost between 7.5 to 9.5%. But we have to remember that these are all studies which were done before the corona pandemic came, and now we don't know what is the situation now. But lockdown and global online teaching must have worsened the problem. Now, why we are worried about the increase in the myopia is not because of the number which is increasing, but it increase comes with the myopia complication as well, which are cataract or macular degeneration or retinal holes and tears and the glaucoma things. And it is one of the leading or second most cause to cataract of the visual impairment and blindness, the refractive error as such. So definitely we have to do something to prevent this myopia from progression. Coming to the factors, there are two factors, either a genetic or environmental factors. Genetic, there are multiple inheritance is there. There are so many loci or genes which are identified. Coming to the parents, which is very commonly parents ask, one parent if it is involved, the chances are almost double of getting the myopia. If the both parents are involved, it is almost 3 to 5 times. Now, environmental factor, which are we can say the
Hemant, your slides are not being shifted. We are just seeing the first slide.
Not shifted.
It's okay. I think let's carry on.
No. Okay. Yeah. Now.
Now go ahead.
Can you see now? At least in this.
Yes.
You can see the slide now, madam?
Yes, yes, we can see.
Okay,
go ahead.
Okay.
Carry on.
Now, environmental factors which are increased near work, reduced outdoor activities, or these are some of the environmental factors which we can definitely modify. Now, myopia, we know very simple words that the focus, it is nearsighted, the focus come in front of the retina. And our aim of the treatment is to put the focus onto the retina. Now, how we are clinically manage this progression of the myopia? The environmental or genic condensation, outdoor activities, higher light intensities, then reducing the screen time, genetic factors. So there are basically three main things. Either we can go for environmental consideration, optical interventions, and the pharmacological therapies are there. Coming to the environmental factors that like the outdoor activities, Sydney myopia study has shown that the more the exposure you have, at least more than 2 hours exposure per day outside, definitely can reduce the onset of myopia. But it is more effective in reducing the onset of myopia than slowing the progression. If the already child is myopic, then the chances are slightly lesser, but definitely it is one of the factors that we can consider. Higher light intensities usually increases the retinal dopamine production, which is believed to retard the axial length elongation. There are some reduced screen time, but we still don't know what is the ideal screen time for the different age groups. But usually I tell to the patient that the time the child spent outdoors, you can give a similar time in front of the screen and make sure that he will use a bigger screen and not the smaller screens like mobile. Now, genetic factors are there, but they are difficult to modify. Now, before going to the optical interventions, first thing we have to understand is what is a peripheral hyperopic defocus. This is one of the concepts where actually the myopic eyeball are not exactly circular. Like if you cut the circular shape and if you see, it is not exactly circular, but they have an oval or oblong shape. That's why whatever kind of a correction which you are giving, usually we'll have the image to fall on the center of the retina. But at the same time, because it is an oval shape, the images will fall behind the retina into the peripheral part. And that is called as a peripheral hyperopic defocus, which is considered as one of the important factors of why the eyeball keeps growing is only because of the peripheral hyperopic defocus. And many treatments are basically based on this principle that probably if we shift from hyperopic defocus to myopic defocus, probably we can prevent the myopia from progression. There are different optical interventions which we can have. One is a spectacle correction, either in terms of single vision glasses, which we definitely give in all the patients. Role of under correction is evaluated and studied, but it is shown that it doesn't work, the under correction part. Even it doesn't relax the accommodation and still the child will keep growing the myopia. So that is not something which will help us in reducing the myopia progression. Bifocal glasses or progressive additional lenses or executive bifocal are tried actually just to make sure that the peripheral hyperopic defocus should be corrected with the help of this plus power in and around the glasses. If we come, the spectacle as we know are very safe, but they are cosmetically slightly unacceptable. and it is difficult, the progressive or bifocal, particularly during the sports activities. Similar to the spectacles, contact lenses have the same principle, that the central distance is focused exactly onto the retina, but there will be peripheral rings with the near ad, which will create the peripheral myopic defocus and which can decrease the myopia progression. Orthocare lenses are shown as very effective in flattening the center of the retina, and they also help to reduce the myopia progression. But the major disadvantages with the contact lenses, one thing is the patient acceptance in our population. Parents as well as children are going to find it very difficult to use contact lenses. There is always a risk of infective keratitis. Then contact lens intolerance, rebound myopia is seen if you stop contact lenses at an early age. And again, the cost and other things are also there. Now coming to the pharmacological therapy, which is very well we are now using. All antimuscarinic these medications actually help, out of which atropine is what we are using nowadays. It is high dose atropine gives the better results definitely, but it comes with more side effects compared to the low dose atropine, which is more effective with the less side effects. Now starting the atropine, you have to first assess the risk of the child, whether it is a low risk or a high risk children, before starting the treatment. Now, good parental counseling is something which I feel is very important, because many patients stop the treatment in between after 1 month or 2 months, and they come back saying that we stopped the drug, we couldn't get the drugs, or we couldn't continue with that. So good parental counseling is something which is very, very important when you are starting. First follow-up, usually after 2 months, whether they are comfortable, and then every 6 monthly, we have to keep following the child. And now assess the response. If we get a good or acceptable response, in a smaller child, we can continue with the drops. In an older child, probably we can consider tapering it. In a poor response, there are two things: either we can increase the dose or we can increase the concentration. Poor response, even despite the maximum atropine, then we'll have to consider some other different options. Now, all these children, we can actually follow them for 1 to 2 years, even after stopping the treatment, because they can have a rebound phenomenon. In conclusion, I will just say that management of myopia continues to evolve over the time. With a better understanding, probably we'll be able to manage it more. More work is required to determine how to combine all these therapies and how the treatment is safe in the long term. Thank you very much.
Thank you, sir.
Despite the glitch, it was a good informative talk. Thank you.
Thank you.
Yeah. We next have Dr. Nikhil Rishikeshi. He heads the Department of Pediatric Ophthalmology and Strabismus at H.V. Desai Eye Hospital in Pune. And sir will be sharing some pearls in congenital cataract management with us. So you may start.
Yeah. Thank you, Moscon. Thank you, everyone, for this brilliant opportunity. And I shall be talking about pearls in pediatric cataract management, which in itself is a massive topic. I've tried to concise it as much as possible. I hope I'm audible and visible both.
Yes, sir.
All right. So all of us know these are various types of presentations that we see: bilateral cataracts, monocular cataract, congenital cataracts. And we come up with, we are faced with all these complications as well: capsular phimosis, traumatic cataracts with Zoma rings, again, another trauma. All of these are, but this is our aim: a nice, clear visual axis with a well-centered IOL. Other than the normal lamellar zonular cataracts, we see a lot of aniridia with cataracts, typical iris colobomas, a lot of traumas, and a brilliant talk by Dr. Rajesh Sinha has already illustrated all of them. But you can see the corneal tear out here, and you can see the blunt trauma with rosettes. Complicated cataracts are also there. So I'm not going into the etiology and the incidence prevalence, obviously for want of time. The management generally, all the investigations are generally reserved for the bilateral cases, because the unilateral are mostly either idiopathic or secondary to persistent fetal vasculature, unless proven otherwise. For the bilaterals, you need a full blood count, serum glucose, blood calcium, phosphorus. Hypocalcemias are known to cause cataracts, galactokinase levels. Torch test, obviously, nowadays a lot of rubella cataracts all of us are seeing. Urine analysis for reducing substances in galactosemia, amino acids for Loeys, the oculocerebrorenal syndrome. So what is a visually significant cataract? Do we need to address or operate all the cataracts? This is, I think, an important point. Any visual central opacity which is larger than 3 mm is a visually significant cataract if it is involving all the zones, that is the thickness of the crystalline lens. If there are clear zones and there is a good retinoscopy glow, a good fundoscopy glow, you can still hold on if there is not too much of low vision amblyopia or amblyopia. So nystagmus, strabismus obviously present are definite indicators of early intervention, and poor central fixation after 8 weeks is a very clear indicator. But then if the retinoscopy and the fundoscopy direct, this is where the DO and the retinoscopy I still use in my OPD. Sometimes you are unable to tell whether how well the child is seeing. So this is a good indicator. The PFE with the low shunt and the PFE with the shunt, so the stronger shunt, we know that there will be more bleeding with the stronger shunt, but in the low shunt also there will be a little bit of bleeding possibly. Watch for the smaller optic nerves, those are probably for prognostic purpose. Smaller eye will be there. And with the bigger shunt, the lot of risk of intraocular bleed would be there. So phthisis chances should probably take into consideration. These are the lamellar cataracts. Some of them have good visual acuity despite the central location because they're not very close to the nodal point as the zonular cataracts are. So you can actually observe them for a while if you want to get through a very critical period, either systemically or anesthetically. Glare and contrast sensitivity problems can be a little bit of a downside because of the layers involved. Cortical cataracts, again, the vision can be very good. Blue dot cataracts, all of these. So when do you really operate? In a monocular cataract, you have to get in very early because deprivation amblyopia is very strong. You have to commit to aggressive post-op rehab like amblyopia therapy, patching, glasses, contact lenses, all of that. If you can, please address it before 6 weeks, anesthetically possible. That is the ideal period, critical period for monocular cataracts. Now the problem I always have to mention this, and this is a constant deterrent because if there is a monocular cataract and it is a smaller eye and the horizontal corneal diameter is not as long as we would want it to be, 10.25 mm or above, implanting an IOL is going to be a problem. And in a monocular cataract, that can be disastrous. People are saying, people in the West do say that the contact lens can be a good option, but sometimes in smaller eyes, the contact lens that can't be retained within the eye, it comes out very quickly. So this is a very, it's a gray zone. So very aggressive patching therapy, 1:1 with +18, +20 glasses, that can be a little bit of a deterrent, but you have to address it. Some people in the West are saying in Europe and US, they could just leave it alone. They don't address the monocular cataract sometimes. The bilaterals are much better for us as pediatric surgeons because the cataracts being symmetrical, there will be less chance of amblyopia. Whatever it will be bilateral. So if there is risk of anesthesia or mental retardation or other syndromic children, then you can operate both of the eyes together. Typically before 8 weeks is a good time. If you can, obviously operate them one at a time at a probably gap of 7 days. Onset after 7 years, you can actually wait, observe, and at leisurely pace, not very leisurely, but yeah, you can take your time. Will you put in an IOL? Very important. The infant aphakia treatment study, as all of us have, we are aware of it. It actually proves that there wasn't too much of difference as visual outcome was concerned. This was in uniocular cataracts, the comparison of implantation of IOL versus keeping the child aphakic with contact lens treatment. Now that contact lens treatment is a possibility out there. I'm not saying it's not possible here, but we have to take into consideration the hygiene, the economy, and all of that, the corneal hygiene, the corneal adverse effects. So in the IATS, it was said that the visual results were almost similar, but glaucoma was slightly higher in the aphakic group, and the second surgery, additional surgeries, were commoner in the IOL group. So these are the two downsides. So these are the usual formulae, SRK, SRKT. So all of us are probably sticking to the SRKT in general because it's the least predictive error that we can have across all the axial lengths. So so there are the two things, whether you can leave the child hyperopic initially, then that will be, you have to have good compliance for glasses and contact lenses. Otherwise the child will have amblyopia. The other is you can make the child emmetropic now, but he'll have a large myopic shift, normally up to 8, 10. And these are the ways that you can reduce the IOL, Eli Dahan's formula or Rupal Trivedi group, Edward Wilson formula. You have to reduce that is the best way forwards, at least in the bilateral cataracts. Any of these formula is the rule of 7. So, okay, I'm really, now people are using the Barrett's quite a lot. Target post-op we just spoke about. We know that at birth, the axial length could be 16.6 to 17 mm, and a keratometry would be 50, 51 diopters. So, and then it evolves very rapidly over the first 6 months. And within the first year, almost 90% of eye growth is reached. So that is where putting an IOL in the first year can be a big challenge. We know that we need a clear axis. So addressing the posterior capsule is very important, but we do know that the pupil doesn't dilate much. The cornea has reduced, the sclera is reduced rigidity. Anterior capsule is quite elastic, and positive vitreous thrust can be quite a bit of a problem. So you have to be careful there. So you can't put in too much of dilating drops, because that itself can cause cloudy cornea. Corneal tunnel is the preferred way, and they don't self-seal. So I was very interested showing us that additional, of course, he's shown it before, and it's a brilliant technique. I do prefer to suture all my ports, all the 3 ports. I prefer a superior incision. It gets covered properly by the upper lid and protected by the Bell's phenomenon. Temporal, although it's more accessible, it's more accessible to trauma as well. Instruments are important. The anterior chamber can collapse very easily because of the vitreous thrust. That's where the high viscosity viscoelastic devices come in. So Ken Nischel's technique, vitrector X, is not something that I would prefer, but hydrodissection, be very careful, because quite a few of them can have PC dehiscence, primary PC dehiscence or polar cataracts. So if at all you want to do hydrodissection, it has to be multi-quadrant and small quantities at one time, not a large gush that will just open up the PC. It's generally irrigation aspiration, and you have to do a good PPC and a good anterior vitrectomy. That is absolutely important. Do have a high vitrectomy cut rate so that there is less traction on the vitreous. We don't want the complications of retinal detachment or CME. So this is what an ideal picture. This is what we are happy seeing. And in the bag IOL with a clear, this one, central. I don't have time for a video, right?
No, not really, sir.
No, okay, great. So I'll just wind up here. Thank you so much.
Thank you, sir. So that was a very informative talk. And our next speaker is Dr. Reshma Mehta. She is a pediatric ophthalmologist and also has a special interest in ROP screening and management. She would be talking about refraction in children today. Ma'am, you may share your screen.
Good afternoon, everyone. I thank MOS. You can hear me and you can see the screen now?
Yes, ma'am.
Yes. So I thank MOS and the MOS Scientific Committee and also Dr. Thakre ma'am to give me this opportunity to speak about refraction in children on this platform. An expert group of pediatric ophthalmologists from across the country met under aegis of AIOS and deliberated to reach a consensus for managing pediatric eye condition. The purpose of this consensus was to enable all ophthalmologists to have a broad set of guidelines for managing pediatric eye conditions, which are divided in 3 categories. The pediatric
your slides are not moving.
Pediatric eye examination, pediatric refraction, and amblyopia management. The economic impact of pediatric vision loss is huge and evident only after a child reaches adulthood. The pediatric population with refractive error needs regular assessment. Prescription should be adjusted according to the eye growth, and we know that the cornea reaches adult size by 2 years. The eye continues to grow anteroposteriorly from 16 millimeters to 24 millimeters. These 2 variables do not have a parallel growth. Hence, refractive error changes as children age. Determining and correcting a child's refractive error prevents and treats amblyopia, which ultimately helps to avoid the irreversible vision loss. The refractive error typically moves from hyperopia towards myopia as children age. Children between 2 to 6 years of age need complete refractive correction. If any myopia develops between 6 to 9 years of age, it increases up to adolescence. Astigmatism is relatively uncommon. As Dr. Nikhil has just pointed out, that the keratometry value is 51 diopters in a newborn, and in adult it is 43 diopters, which reaches by the age of 2 years. Hence, the focusing power of eye decreases as age advances. To begin with, the visual assessment should be done as one eye at a time. Using the age-appropriate methods for less than 2.5 years, we use the fixation target following movements, referential looking charts. From 2.5 to 4 years, we use symbols, alphabets, matching cards. Above 4 years, we use the Snellens and the logmark charts. A complete eye examination, cover test, extraocular movements, convergence, anterior segment examination, fundus, and complete squint examination is to be done. Assessment of the refractive error requires a complete cycloplegic refraction. That is the rule in children. It is because of the presence of strong accommodation. Cycloplegic refraction is done to reveal the total refractive status of the eye when accommodation is at rest. We use atropine, homatropine, and cyclopentolate eye drops. Important point is to keep in mind is the proper cycloplegia should be achieved, and this should be verified by performing dynamic retinoscopy while the child looks at distant and near objects, which reveals a constant value. Atropine drops are avoided as risk of systemic absorption and side effects is higher. In age groups more than 5 years with orthophoria, homatropine and cyclopentolate can be used. However, side effects must be kept in mind, and parents should be forewarned for the ocular irritation, lacrimation, contact dermatitis, dryness of secretions, and fever, which are often seen. The gold standard of objective refraction in a child is retinoscopy. It is a vital aid in calculating accurate refractive error in children. Hence, mastering the skill is essential. Retinoscopy allows observer to accurately measure patient's refractive error by determining the spherical power, the cylindrical power, and the cylindrical axis. It also provides information about the additional ocular morbidity. We can use autorefractometers, but it induces proximal convergence in spite of cycloplegia, hence leading to mild undercorrection of hypermetropia. In young uncooperative children, it is difficult to convince the child to place the head on the autoref. Also, handheld autorefs can overcome this problem. The refractive status of a child is constantly changing with age. Neonates are hyperope with astigmatism. The hyperopia is symmetrical, which is less than 4 diopters. Astigmatism can be less than 2 diopters. Both hypermetropia and astigmatism reduce with age. E-metropization has to be taken into account when prescribing glasses. Child less than 2 years, if has myopic error, this correction is not required. But if the child is above 2 to 6 years, undercorrection should be avoided. Overcorrection should be avoided. I'm extremely sorry. For myopes, we should not overcorrect. The lowest minus power needed for the best visual acuity should be given. So according to the ACOS chart, in myopia, if it is less than 1 year and the myopia is more than 4 diopters, we have to think about it, as the child is only going to focus for near objects. But more than 2 to 3 years, we need to correct the myopia. Coming to hypermetropia, it should be corrected earlier than myopia. Children having strong accommodation, which can overcome minimal amount of hypermetropia with ease. So this minimal amount of hypermetropia of 2.5 to plus 1.5 can be overcome. But children who are having more than plus 5 diopters of hypermetropia, We cannot neglect it. It has to be corrected completely and fully at age 1, 2, and 2 to 4. Because the amount of accommodation needed for near tasks would be in the range of +8, which can cause asthenopia. Amblyopia and esotropia are the most common outcomes of uncorrected hypermetropia. Amblyopia occurs if the child cannot overcome hyperopia at all times, especially for near. Low amount of hypermetropia leads to refractive accommodative esotropia and increases the risk of amblyopia. Hence, amount of hyperopia to be corrected depends on age. Mild undercorrection can be prescribed to allow some accommodation to occur. But undercorrection of hypermetropia should be equal in both eyes, and as accommodation is a binocular phenomenon. Hypermetropia with esotropia in these patients, again a cover test is mandatory prior to installation of cycloplegic. 2 to 5 diopters of hypermetropia present with squint should be corrected completely. More than 5 diopters of hypermetropia, these patients do not squint because of lack of accommodative effort for such a high power. Coming to the last part of astigmatism, accommodation can change only it can change the spherical refractive status of the eye by change in curvature of the crystalline lens. It cannot be overcome by accommodation. So this astigmatism will not be overcome by accommodation. Hence, the cylindrical power of 1.5 to 2 diopters can be amblyogenic. And according to this APOS guidelines, we need to correct both the meridians entirely and prevent amblyopia. Small cylindrical powers should be corrected completely. Spectacle fitting and centration is an important factor in high cylindrical powers. Parents should be explained importance of centration, as children often bend their frames, and prompt repair and tightening should be done properly. These practice patterns, which were designed, will enable the ophthalmologist to provide efficient pediatric eye care services and timely intervention for avoidable or preventable cause of blindness. Thank you.
Thank you, ma'am. That was a great talk. So our last speaker for today is Dr. Pradna Deshmukh. She is an associate professor and VR surgeon at MGM Medical College, Aurangabad, and she has a special interest in ROP and diabetic retinopathy. Ma'am would be talking about screening techniques and management of ROP. Ma'am, please start.
Yeah, can you hear me?
Yes, ma'am.
Yes.
Yes. So thank you, MOS office bearers and Dr. Thakre for inviting me for this talk. So I'll be speaking about screening, examination technique and management of ROP, what's new and what already being practiced. So as we travel from retrolental fibroplasia to retinopathy of prematurity, we all know that it's a disease of the smallest and sickest infants. But in Indian scenarios, we have larger babies also coming up with ROP, and the incidence varies from 38% to 51.9%, and with the more premature infants surviving because of better NICU practices, we are going to see an epidemic of this disease in future. So today we'll be covering why, whom, when, where and how of ROP. So why should you screen? It is a blinding disease. Identification of all babies at risk is essential to prevent blindness as well as undesirable sequelae of this. Whom to screen? Now the guidelines that are followed are the Rashtriya Bal Swasthya Karyakram Guidelines 217. It says that we should screen all babies with birth weight less than 2 kgs, gestational age less than 34 weeks, gestational age between 34 to 36 weeks but with risk factors, and all infants with unstable clinical course who are high risk as told by the neonatologist. The when to screen remains the same. Everyone should be screened before 1 month of life, and the babies who have less than 1.2 kg birth weight or less than 28 weeks gestational age should be screened earlier
to detect APROP at a very early stage. Where to screen? A warm, clean place. Can be an ICU, can you be your OPD, can be the pediatrician OPD, but the treatment should be done only in NICU and OT as these babies need monitoring. We all have learned indirect ophthalmoscopy with 28 or 20 diopter lenses, scleral depression, and this is how we have learned to do ROP screening. However, there has been a shift to the digital methods of screening technique. So the digital method can be contact, which is the RedCam or the RedCam shuttle, the non-contact with the advent of a really nice smartphones, or even the wide field photography where the baby can be put in a flying baby position. The advantages of digital screening is that it's a very good tool in telemedicine. So you can take your screening to a very remote area where the babies do not have access to the traditional screening. It is a very good counseling tool for follow-up, better for medico-legal documentation, and it is supposed to cause less pain and stress to the baby. The follow-up schedule will depend upon the retina. It might be bi-weekly for an immature retina, or can be as early as 48 hours for a ROP which is type 2. The ICROP has traditionally classified this into zones, clock hours and stages. However, ICROP has been revamped in the recent times to the third edition. Why the need was there to revamp this? This was because there was subjective interpretation of disease classification, and there have been recent advances in both imaging as well as treatment with the advent of anti-VEGF, which has changed the post-treatment sequelae. There are different patterns of ROP like blister ROP, bleb-like ROP or hybrid ROP that really does not fall into the classification gamut. Now the major recommendation of ICROP is it has divided the zones into a posterior zone 2, which is the margin between the zone 1 and the zone 2, a notch, which is an incarceration of ROP into a more posterior zone. It has classified pre-plus disease into mild and severe. Okay, and also has provided sample images. The acute disease stage has recommended the use of aggressive ROP in place of AP-ROP, and instead of using immature retina or no ROP, to use incomplete vascularization. Retinal detachment, also the stage 5 retinal detachment has been divided into stage 5A, 5B and 5C. The regression, reactivation and long-term sequelae also has been defined by this ICROP classification. The treatment protocol remains the same. Type 1 ROP requires treatment and the type 2 ROP requires close observation. Now this is a multidisciplinary thing. It requires the ophthalmologist, the neonatologist, the nursing staff and the parents. The treatment option, the gold standard is the laser, and the anti-VEGF is coming up. Surgery is for stage 4 and stage 5 ROP, and more focus on prevention and new therapies. Now current gold standard is a laser in which there is peripheral laser ablation. It has to be done within 48 hours after informed consent, as I said, in NICU or OT under topical sedation, GA, whichever it is anesthesia required, not without its complication. The main is myopia and anterior segment ischemia. Everybody should have their own set SOP for the laser procedure, which has led to the emergence of anti-VEGF as one of the potential treatment for ROP. Now the indications are a very posterior ROP or as a pre-operative measure. The dosage is half to 1/3. Now what are the points in favor of the laser on the anti-VEGF? So laser is the current gold standard. It is endpoint treatment, but it is not without its complication. There is more myopia, very stressful, time consuming. It is difficult to do it in a unstable baby with a non-dilating pupil, whereas the anti-VEGF has its own medico-legal issues, but it is easier to do it in a non-dilating pupil, easier to do posterior ROP, less myopia, it is less stressful and less time consuming. Not without its hazard. As I said, my preferred practice pattern is I use it only in zone 1 ROP, where even the macula is not vascularized, and I usually use a combination of anti-VEGF and laser to treat my babies. There have have been trials, will not talk about this because of time constraint. Have to remember that other than ROP, the child can have glaucoma, cataract, refractive errors such as myopia, anisometropia, astigmatism, and strabismus, which require close evaluation and management. Now the baby can have subnormal vision with or without ROP. So the causes can be an unfavorable structural outcome in spite of treatment, CVI, strabismus, myopia, and every baby on follow-up requires a thorough checkup, both visual and other milestones. Vision can be checked uniocularly or binocularly. Ocular alignment such as strabismus, nystagmus has to be changed along with the retinal examination. Refractive error, myopia, anisometropia, astigmatism have to be evaluated, and keeping in mind the other comorbidities like cataract and glaucoma. Now, as you can see, all the treatment have complications, both systemic and occur. So, can you prevent ROP? There are things that have been tried, like using an optimal oxygen level. So, oxygen is a drug. The role of antenatal steroids, which respiratory maturation, optimal nutrition like breast milk, decrease the blood sampling, and decrease the nosocomial infection. The future strategy, two of the most promising are propranolol and vitamin A, which are novel treatment, can be given both orally or as eye drop, which can reduce ROP progression by inhibiting the pathological angiogenesis. A note on AI in ROP. Now this can be used to study the images, so better application to demarcate and grade the ROP and decide the schedule of follow-up. So it has a role in telemedicine. Stem cells in ROP have been studied extensively in animal models of oxygen-induced retinopathy, and they have found promising results that it can help normalize the pathological vascularization. However, can it be translated into human trials? It remains to be seen. So last but not the least, everybody who does ROP has to have some faith in God, but we have to keep our powder dry. So document, and take adequate professional indemnity. Thank you very much, everyone.
Thank you, ma'am. That was a marathon session, and we have come to the end of our talks. Dr. Ragini, ma'am, if we could have some closing remarks from you.
She's not there. I would like to take this opportunity to thank all these speakers. We are overshot the time quite a bit actually. Thank you. Any comments before we leave? Mr. Kotkar, madam, Sinha sir.
It was an excellent speech, academic speech, where we could see cataract, refractive, myopia, allergic conjunctivitis. Excellent session.
Thank you, ma'am. Thank you.
And of course, the progression in myopia.
Une, madam.
I just like the videos which were shared, and all the congratulate all the speakers. They have done excellent job, and even ROP was also much needed and wonderful talk by each and every speaker. Thank you all.
Thank you all. Thank you, Sinha sir, for giving your precious time to us. I think Ludra sir has left. I think we will leave now. Okay. Thank you. Thank you, Mitali. Thank you all. I missed.
Yeah, thank you. Thank you, Dr. Thakur. Bye.
Oh, thank you, Reshma. Sorry.
Thank you.
Thank you.
Bye.
Okay.
Thank you.
Bye.
प्रेझेंटेशन बरोबर ओपन केलंय मागे फक्त हे फुल स्क्रीन करायचं.
Good afternoon, madam.
नमस्कार नमस्कार नमस्कार.
अच्छा मॅडम तुमचा व्हिडिओ ऑफ आहे आबा मॅडम.
मी ऑफ केला होता.
गुड आफ्टरनून.
गुड आफ्टरनून मॅडम. छान झालं तुमचा इन्स्ट्रक्शन कोर्स मॅडम. वर्षा मॅडम गुड आफ्टरनून.
हा वर्षा मॅडम आणि शुभांगी मॅडम. मस्त. नागपूर तुमचं अटेंड केलं बरं का औरंगाबाद वाला.
अच्छा म्हणजे हो ना तुम्ही होता तुम्ही फोन केला होता ना.
हा सर्जरी सारखंच टेन्शन असतं आपलं ते लॉग इन होईल का नाही शेअर स्क्रीन करता येईल का नाही माहिती नाही.
गुड आफ्टरनून सर.
हाय गुड आफ्टरनून डॉक्टर स्नेहल डॉक्टर आबा डॉक्टर.
हो नमस्कार नमस्कार.
वर्षा मैम शुभांगी मैम कहाँ चले गए? I was just having a look at her.
Yeah, I think she's trying. Yeah.
How are you मैम? आबा मैम कैसे हैं?
बिल्कुल बिल्कुल मजे में है आप बोलिए.
बस ठीक है मैम all well.
Yes.
And वर्षा मैम how are you? You are muted.
मैम आपण म्यूटेड. वर्षा मैम म्यूट आहात तुम्ही. हाँ नाही परत म्यूट झाले.
Yes. Hello sir.
हाय मैम.
कैसे चल रहा है स्पोसी? फुल एक्टिव.
स्पोसी चल रहा है.
एक्टिविटी. क्या बोलते हैं स्टॉर्मी.
स्टॉर्मी दिवाली धमाका.
We get to know few details from Mai. Rishikesh is there, no?
Yeah.
Hello, let's see.
Somehow the society, I mean, I don't like the way it is functioning, but
yeah.
Hope for some betterment.
Gradually.
If people continue, then you will. If people like you continue, it will.
Ma'am, it is. Yeah, the day before yesterday, I was talking to Vanita ma'am also. So ma'am was saying that like all the dynasties like Khiljis and Chalukyas and all those came to an end. So probably, is it not that this posse is coming to an end? I said, ma'am, aisa nahi mat boliye. Let us try our best. But it's not going very smoothly somehow.
Dr. Rishikesh, he's not. I mean, he's there, but he's not there.
This is like real world's daydreaming. You are there but not there.
Who are the
others? Good afternoon, everybody.
Hi, Rishikesh.
Hello, sir. Hi, how are you, sir?
All well.
Okay. So, welcome to Moscow, sir.
Yeah.
Welcome.
So you
sir.
have it. You have it on all weekends. I think 2-3 weekends. I guess 2 weekends.
2 weekends, sir. 2 weekends.
2 weekends.
Because it is.
Yeah, that's kind of better for virtual. That's a good thing for virtual that you can have it on selective weekends. Real, you can't have it spread over a week, no?
Very true.
Yeah.
I think it was like Bombay Ophthalmic Association meeting in
BOA. Correct. Summer focus.
Yeah, that was a wonderful idea. Every weekend for 1 month they had.
Yeah, they had it for every weekend.
Hi everyone.
Hi Dr. Shubhangi. Hi Dr. Uday. Hi. You are muted, Dr. Uday. You'll have to unmute.
Sir knows everyone. Huh? You have.
Hi everyone.
Hello there.
Hi.
सर इसीलिए मैंने AIOC में भी बोला था कि बॉम्बे ऑप्थेल्मिक सोसाइटी, महाराष्ट्र ऑप्थेल्मिक सोसाइटी, पुणे ऑप्थेल्मिक सोसाइटी, जो लोग सब फ्री में ऑनलाइन कर रहे हैं, तो व्हाई आर यू आस्किंग फॉर द चार्जेस इन AIOC?
I agree, मैम.
और पता नहीं मुझे ऐसा लगा कि पर मैंने सोचा कि जो मेरे मन में है वो मैं
ये थोड़ा
I was not knowing what are the charges because I had already paid them. जो ये वाला कॉन्फ्रेंस था ना उसका, so I was thinking कि पता नहीं 7 या 8 हजार या जो भी है whatever. And then I came to know कि it was 2000. So even if it is 2000, no problem. But अब ये लोग सब कर सकते हैं. इंटरनेशनल फैकल्टी को भी बुलाया था, MOS में बुलाया था, BOA में बुलाया था, पुणे ऑप्थेल्मिक सोसाइटी में बुलाया था. तो ऐसा मैंने कहा था. पर
So
शायद
ma'am, you were very right, because AIOS is the society which has maximum corpus of funds.
Yeah.
Still they were. I also didn't like the idea, but anyway, I had also paid like you. The early bird
Yeah.
we had paid.
Yeah,
And then
correct.
some amount got reimbursed, some amount did not.
Yeah.
So we didn't care how much is cut, but then it is fine.
Yeah,
But that's
सवाल
not the
पैसे का
correct
नहीं
way.
है.
Yeah, at least for
सवाल
the
पैसे का नहीं है.
Yeah, I think we are running. We'll start in
Okay,
time, Dr.
okay.
Snehal.
Yes.
Varsha ma'am.
Yes, yes. Hello, everybody. Dr. Malik Madam has joined. She's chairman for this.
No,
session.
madam.
I will call her.
Should we start or?
I think we can start. Wait for a minute or two. Just ask her.
So, good afternoon, everybody. Madam, would you like to start? Or?
Yeah, I think so. It's already 2:00 now. We don't want to leave
Yeah, we are on time.
Welcome you all for this meeting.
What do you say?
I am calling ma'am. I think meanwhile we can begin. Can we begin? Dr. Rishikesh?
Yes, sir. Yes, ma'am. I have got the introductions of everybody. So at the end of, before the start of the talk, I can introduce all the speakers.
Okay. So I think I welcome you all for this session on strabismus, and it will be a wonderful interactive and informative session. And we have got today Dr. Ankur Sinha, a prominent strabismologist and pediatric ophthalmologist. And we would like to hear from him the pearls for management of strabismus. So I welcome you, sir. And I think Rishi, I will ask Rishi, I will request Rishi to give a short introduction of Dr. Sinha before his
Thank you.
talk.
It is indeed a privilege for us to have Dr. Ankur Sinha for a talk in our meet today. Dr. Ankur is an alumni of the prestigious RP Center for Ophthalmic Sciences. He was a clinical observer at Yale Eye Institute, USA. He has presented, he has published more than 25 publications in peer-reviewed journals and 50 free papers and posters in national and international conferences, and 5 chapters in books and more than 200 conference participation. He was awarded the best senior resident of AIMS and also best free paper in annual conference of DOS as well as Rajasthan Ophthalmological Society. With this, I will invite Dr. Ankur for his talk.
Thank you, Dr. Rishikesh, for such a nice and elaborate introduction. I would like to thank MOS for giving me this opportunity to be a part of this. And it is nice to see all the seniors and friends here after a very long time, and hoping that we meet physically sometime. So I'll be starting with brief pearls in management of strabismus. So management of strabismus can be divided into non-surgical and surgical parts. So the primary thing is to prescribe spectacles. The spectacles are very handy in comitant strabismus. The common forms which can be managed by spectacles are accommodative esotropia, intermittent exotropia rarely, and consecutive strabismus. We can also plan to have Botox temporarily for paralytic squints and infantile esotropias. So this is a case of fully accommodative esotropia. The patient only requires is full correction of glasses to maintain binocularity and alignment both. This is the case of intermittent exotropia, minded that this patient is having a very high AC by A ratio. That is why we are able to give this patient overcorrected myopic lenses, and then we can see the alignment here. So a lot of intermittent exotropias do not have high AC by A ratio, and overcorrection of glasses does not help them. So giving glasses does not make the game over. The motive is to relax accommodation in case of accommodative esotropias and stimulate accommodation in cases of intermittent exotropias. So we have to check the fitting of glasses. Like both these children are looking over the glasses and the glasses are running down their noses. So they're not the good fitting glasses we need for these children. And this child also is having a very tight glasses over the ears. So the patient is having uncomfortable wearing of the glasses. And we can also see this redness here, which is hurting this child. So what we want is a proper fitting of glasses for which, with which the patient is comfortable and continues to wear them. We can also have drugs to manage strabismus, cycloplegia like atropine and hometropine for children. We can also prescribe glasses over them to avoid blur. Cholinergics can also be used to decrease central accommodative effort in case of accommodative isotropias. Prisms can also be handy, but they can only handle very small amount of deviation, say 7 to 8 prism diopters for each eye, or we have to move for Fresnel prisms. They can also be used to control post-surgical diplopia with over and under corrections, both in comitant and incomitant strabismus. Sometimes they can be used to support for poor convergence. Now, this is a case of exotropia who is operated for right RNR and the patient goes into consecutive esotropia. So what we do is we prescribe him prisms and wait for the drift. If the patient drifts back and aligns the eyes, till the time we elevate the diplopia. If it doesn't, then we have to plan for a resurgery in this patient. Orthoptic strizes are also very handy, but they work very well for small exos with asthenotic symptoms. Synaptophore is a very good device, but we can also make use of pencil push-ups and simple home orthoptic trainer. Now we move on to the basic principles of surgeries. So we have either a weakening or a strengthening, but mind it, both of them are misnomers because there is no true weakening and no true strengthening. All we do is we just alter the length tension curve of the muscle. Now this is the nomogram, which is showing you minimum and maximum of the recti. So if you do less than minimum, it is not going to be effective. If we go for more than maximum, then we are actually dealing with the muscle rather than the tendon, and then the results will be unpredictable. So it is always advisable to be in the range of minimum and maximum. Now, a few more points. Whenever we plan a surgery under GA, it is always advisable and good to have bilateral recessions because they can cause similar change in the globe position and similar change in the palpebral aperture. Also, recessions are reversible and there is no loss of tissue. Whenever we plan RNR, there is more effect per muscle of surgery, and large RNR can cause palpebral aperture changes, which has to be kept in mind. Now we move on to the surgical dosage. The recession is a stronger speed than resection. Medial rectus is a stronger muscle than lateral rectus. So medial rectus can give you 3 to 4 prism diopters per millimeter, while lateral rectus will give you only 2 to 3 prism diopters per millimeter. Larger deviations and younger patients tend to respond more than smaller deviations and older patients. Similarly, there are patient factors and surgeon's factors which can alter the surgical dosage which we have planned for. Then there are techniques of muscle exposure. So von Nuden is a very good approach where we give 2 radial and 1 circumferential incision, but it is good for beginners. It gives you a good exposure of anatomical landmarks, but there can be a problem of limbal bleeding. Parks is cosmetically better, but it is very important to understand that the exposure to anatomical landmarks is limited and it may be difficult for beginners. Swan can cause a lot of fibrosis. One can also utilize Prem Prakash's paralimbal incision. Now, it is very important to understand that under the block or under the GA, the eye can rotate. And Park's incision, though cosmetically better, it becomes all the more difficult for beginners. Now, these are the various procedures for weakening and strengthening of recti. We have to choose one very judiciously. Now, this is a case of partially accommodative esotropia that she still continues to have esotropia with glasses. So giving glasses is not just sufficient. So we have to plan something for her. We have to align the eyes. So we check for all the 9 gazes. There is no AV pattern, no oblique overactions. What we plan is just one muscle recession, that is right MR recession by 5 millimeters, and we align the eyes absolutely fine. Do not miss out the oblique dysfunctions. Now, both these girls are already operated in consecutive strabismus, and we can see that this girl is not showing any oblique overaction, but mind it, it is the primary gaze. So once we ask the patient to look into the tertiary gazes, we can clearly see that the inferior oblique overaction is there. So do not get carried away by horizontal deviation and just say that there's no oblique overaction. Often we receive such calls from younger people and general ophthalmologists. So we do a full 9 gaze evaluation. We see that there is a V pattern and inferior oblique overaction in both the eyes. So this girl undergoes bilateral LR recessions with inferior oblique recessions by 10 millimeters. And this is the postoperative photograph of the same child. So whenever we are planning inferior oblique surgeries, be careful for the anatomical landmarks. So once we have this 6 millimeter and 6 millimeter, this is the Finch point, which is about 8 millimeters. We go 2 millimeter back, this is 10 millimeter recession. Other two common surgeries are iliac and Nankin and modified iliac and Nankin. Iliac and Nankin can give you something like an anti-elevation syndrome, which can be utilized in DVDs. These are the various procedures for inferior oblique. Choose the appropriate procedure because oblique surgeries can sometimes be unpardoning. This is another case of IDS with superior oblique overactions, which are usually missed by general ophthalmologists, and they just do a kind of horizontal surgery, which is not good for this patient because A pattern is not acceptable. So what we plan here is bilateral lateral excisions by 5 millimeters and PTSOs. So this is the post-op photograph of the same patient where the A pattern is collapsed and superior oblique overactions are gone. Again, choose the procedure very judiciously, whatever we are doing, because obliques can be unpardoning. If you have problems in finding out the fibers of superior oblique, then you can either use trypan blue, gentian violet, or ICG to stain them and look at them. So in the end, I would just like to say, do not jump to surgery by looking at the strabismus. The glasses can play an important role. Also, do not delay surgical intervention when it is actually required. Proper assessment is the key, and surgery, the aim is not surgery. The aim is alignment, stereoequity, and in the end, do not allow an inferiority complex in a child that is relating to personal development of the child. Thank you for your kind attention.
Yeah, good talk, Ankur. You covered the talk well in that limited time. Very well.
Thank you.
And covered many points too.
Yes.
Thank you, ma'am.
So we have now Dr. Varsha, who would speaking to us on vision assessment in pre-verbal and preschool children, a very important topic which helps us in assessing the vision, which is the utmost important point.
Good afternoon, everybody. Is my screen seen? Visible?
Yes, ma'am.
My screen is visible?
Yes,
yes, madam. It's visible. Yes.
Dr. Ankur, very informative. First, I would like to thank Scientific Committee, MOSCON, especially Dr. Ragini Madam, Dr. Snehal, Dr. Himalini for giving the opportunity. I'll be discussing vision assessment in pre-verbal and preschool children. Vision assessment meaning estimating maximum ability to see. Two distinct points will be visible when two separate cones are stimulated. And the standard normal fixed vision 6/6 is equal to angular separation of 1 minute at fovea. In adults, it is very simple to assess the vision on Snellen's or logMAR charts, but measuring vision in pre-verbal and preschool children requires special skill, time, patience, and special tests. Traditional vision tests for adults are based on character recognition, and they are not useful in infants because there is no patient population and visual system is immature. So methods of vision testing in child depend upon child's age, abilities, knowledge, and available facilities. And one should always be aware of visual milestones of this particular age group in children. So for vision assessment, we have detection acuity tests, recognition tests, and various resolution acuity tests. The Cartford drum test, which is useful in infants and preschool children, it is a detection acuity test where pendular eye movements will be elicited as the child follows the oscillating drum. When dots with the dots, and that will be the smallest dot that evokes the pendular movement determines the visual acuity. But the disadvantage that it overestimates the vision by double or quadruple. Then the preferential looking test based on the preferring of the child to fixate on a pattern stimulus rather than a blank surface of the same brightness. And the commercially available PL cards are used in the clinics. Then the Taylor acuity card test, which is simple and rapid test for children up to 18 months. And the highest frequency grating, which is seen, gives a measurement of acuity. It can be converted into Snellen's notation, but again, drawback is that the tests usually does checks the near acuity only, and it may miss myopia, and sometimes it also overestimates the vision. Then the Cardiff acuity cards, which have pictures of vanishing octotypes, and these pictures vary at particular some distance and will give you the idea about the vision. Then the opticokinetic nystagmus drum, which is traversing slowly before a normal infant's eye will produce involuntary jerky nystagmus. And the smaller the target, producing optokinetic nystagmus will give you the idea. I mean, there will be a better vision if the smallest target produces OKN. But again, disadvantage is that it cannot be graded. Then VEP is highly advanced test to determine the integrity of nerve transmission from eye to occipital lobe. It is simple non-invasive test. It records the electrical signal generated by the occipital cortex in response to visual stimulation pattern detected by the surface electrodes monitoring the occipital cortex. It records the vision in up to 6 to 6-9 at the age of 6 months. Stimuli may be pattern or unpatterned flash. The objective record of underlying visual pathway by VEP gives good idea, but it excludes organic pathology. And again, it can sometimes overestimate the vision. Sweep VEP, on the other hand, is a rapid test, produces 20 stimuli in swift fashion, projected for 0.5 seconds and completed in 10 seconds for, again, screening purpose. So all these tests, which we have described earlier, need sophisticated instruments, and many times they are not available in our clinics. So for general ophthalmologist and also for basic examination, indirect assessment of visual acuity in infants is very, very important. And simple things like brief visual history, examination of anterior and posterior segment, pupil reaction, presence of squint, nystagmus, cycloplegic refraction, blink reflex, Bruchter's test, and fixation reflex will give lot of information regarding the child's vision. The blink, the baby blinks at birth. Sorry. The baby, there's a video. The baby blinks at birth, and we can see, even if it is so close, there is a poor vision can be just seen through this video. Then the fixation reflex is also very important, which is prerequisite for the normal visual development, and which is present at birth. And even with the light, if the child is not following the light, this simple test will also give you the idea that there is a poor vision from the fixation reflex also. So again, type of fixation, which is very, very important and must be seen by all to know the visual status. The central steady fixation means the child is fixating at fovea. There is no nystagmus, no ocular dominance, and it should be observed by both eyes open and separately. The gross eccentric fixation indicates very poor vision, less than counting figure 1 meter. Unsteady central fixation means less than 6/60. Steady central fixation, but it is not maintained, indicates that the vision is between 660 to 636. Central steady fixation, but preference of the other eye. Central steady maintained fixation, free alternation means good vision in each eye. Then simple this observing the child, that the preference of fixation in one eye over the other, that in this case, like right unilateral squint, not taking fixation, suggestive amblyopia, poor vision. If there is resistance to closure of one eye, which we can do easily in our OPD, indicates poor vision in the other eye and can give a clue about the visual status. Then induced tropia test, where we can put a 10 prism base down in front of apparently fixing eye, which causes both eyes to jump up if it is a truly fixing eye with good vision. But if there is no vertical movement, that means the eye in non-fixing, the eye which is non-fixing has a poor vision, and we can diagnose low vision in infants. For 1 to 2 years, child's attention is easily distracted after 9 months. So teller acuity cards, Cardiff cards they are not very useful. So we can have these small boy candy tests, where small edible candies of 1 to 2 millimeter size can they can serve as incentives also, and they are used as visual stimuli, and ask them to pick up and eat. If it is difficult, that means the vision is less than 6/24. So, and each eye is to be tested alternately, and difference is noted. Then with ivory ball tests, ivory balls of different sizes rolled on floor, the smallest ball pick up will tell us the visual acuity. In 2 to 3 years, miniature toys tests are there. Pair of miniature toys can be used. Coin tests with different size coins. Dot visual acuity test where smallest dot identified correctly on the illuminated box with the printed dots will give you some idea. In 3 to 5 years of children, matching principles, we can use tumbling E, Landot-C, Sheridan letter test, etc. So these are the various least symbol. Tumbling E will give you the idea about the vision in this age group, 3 to 5 years. So to conclude, that visual acuity tests in pre-verbal children needs expensive test material. They are operator dependent, they are time consuming, did not give correct vision always, may overestimate vision, we may miss amblyopia in this test. And the purely objective tests like VEP are again available in institutional setups and not available for all. So careful observation of the child is very, very important, and it is must, and that will give you important clues about the patient's vision from the fixation pattern and response to occlusion. And before all this, one should establish a good rapport with the child. The reward for positive response must be ready in the form of chocolate. Examination should be fun for them, and several tries at different times within the child's attention span are necessary. Thank you. Thank you for the patient hearing.
Thank you.
Yeah. I think you can.
Thank you, Varsha madam, for an excellent presentation. And I think it's good to into the insight into the visual assessment in pre-verbal children. I think we will move ahead to the next talk. The next speaker is Dr. Shubhangi Bhave madam. She is, I think she doesn't need an introduction as such. She is a pediatric ophthalmologist practicing in Nagpur since 37 years. And she has many publications in national journals. She is a recognized postgraduate teacher by Nagpur University. She was a past president of Nagpur Academy of Ophthalmology and Vidarbha Ophthalmic Society, and also a scientific committee chairman of Vidarbha Ophthalmic Society. She has been organizing chairman of Maharashtra State Conference 2 years back, which was done physically. And presently she is practicing at Drishti Eye Clinic and Squint Center since 1994. With this, I'll invite Dr. Bhave madam for her talk on acute comitant esotropia.
Good afternoon, Dr. Bhave ma'am, and I think you have introduced her so well. You cannot make out that she's practicing for 37 years because she looks young and beautiful always. Thank you, ma'am. Thank you, Dr. Varsha ma'am. Thank you, Dr. Sikesh. And thank you for this wonderful session. And I won't interrupt because we want to hear Dr. Shubhangi ma'am further. I've already interrupted, but I won't hold you longer.
Thank you.
Thanks, Ragini, and thanks, MOS, for allowing us to conduct this session. And thanks, Snehal. Today I'll be talking on this topic of acute acquired concomitant esotropia. Let's say that it is characterized by a concomitant, acute onset, non-accommodative esotropia. Each term is important. There is generally associated with diplopia and visual confusion. There is a good potential for binocular vision with highly favorable surgical result. Age is generally more than 5 years, and there is no tendency for spontaneous resolution. When all these characters are present, we tend to diagnose it as acute concomitant acquired esotropia. The age of onset is late. Normally, 3 types are described. Type 1 is following artificial interruption of fusion, that is one type. This is fairly easy to diagnose. Type 2 is in concomitant esotropia of Frankeschetti type. This is accompanied with diplopia and good potential for binocular cooperation. And type 3 is in concomitant esotropia of Bilchowski's type. These patients have myopia up to 5 diopters, have uncrossed diplopia for distance and fusion for near. But the distinction between type 2 and type 3 may not be this clear cut. And type 2 is moreover more difficult to diagnose. And concomitance in a case of esotropia does not rule out that there is no underlying neurological condition. It could still be associated with a neurological lesion. So it is very important to rule out the neurological lesion, if any, in these cases. Then one more point is more excess of near work and stress also is an important factor in development of this type of esotropia. Key points in examination: history taking as usual is important. Examination for uncorrected hyperopia, anisometropia, AC over A ratio, myopia. One has to do a detailed orthoptic checkup, Hess charting. The late age of onset and diplopia indicate absence of subduction. And neuroimaging, as I have said, is to rule out the intracranial lesions. We do not know why these exactly how these lesions could cause intracranial tumors, could cause acute concomitant esotropia, because it is not a LR palsy. Which is there in concomitant, but here maybe because of the hydrocephalus or maybe because of the effect on the Virgin centers in the mesencephalon or on the brainstem or cerebellum, we develop an concomitant esotropia. It is postulated that could be because of hydrocephalus. Differential diagnosis is bilateral six-nerve palsy, wherein we differentiate by esotropia, which is more for distance, then presence of near, it is better, and then the secondly divergence palsy and divergence insufficiency. These are the close differential diagnosis. Treatment, conservative treatment, we given trial of full correction of refractive error, treatment of amblyopia, of if any. Botox is nowadays coming up as a good option in these cases, but even surgery gives a good realignment and carries a good prognosis for re-establishing fusion, and one should not delay the surgery unnecessarily. And now, role of Botox versus surgery. Injection botulinum gives good results, especially in younger age group. Children have found to require lesser injections. They're found in studies that 1 to 3 injections may be needed. Surgery gives good result, and one has to be careful and against undercorrection. I prefer to use adjustable sutures in such cases. I just briefly discuss 2 cases. The 16-year-old female came with double vision headache since 4 months prior to seeing us. There was no significant history in recent past. She was a myope using specs since 5 years. The best corrected visual acuity was 6/6 with minus 3.25 and 3, and pupil and fundus were normal. The orthoptic, there was a right esotropia, and prism bar cover test showed 25 to 30 prism diopter for distance near and in the gazes. No abduction deficit in the ocular movements. So Hess chart also showed near symmetrical displacement of the eye inward, and MRI was normal. So this I felt was an acute concomitant esotropia query type 2. So the procedure she underwent after reassessment was right eye RN, medial rectus resection 4.45 millimeter on adjustable with lateral rectus resection of 5 millimeters. This is a Hess chart showing an symmetrical inward displacement, and she had a small angle, not a very, and these are the post-op result after doing an RNR procedure with adjustable suture, and these are the findings. And she remains under follow-up and is maintaining her orthophoric, neo-orthophoric state. Now, this is a surgical video of adjustable suture, but I think I'll skip this. I'll just take the last case. This was a 27-year-old male who complained of double vision since 6 months. There was no significant past history. The visual acuity was 6/9 with -6 in both the eyes. He had some stress in the recent past, in the death in his family. And rest everything was normal. MRI was normal. He had a larger angle, right esotropia again with 45 prism diopters of esotropia for distance and near. It was just grade 1 abduction deficit, and so probably he was addicted to his cell phone and used to be on the cell phone late till night before he developed this. So the procedure done was right medial rectus recession 5 millimeters on adjustable and right lateral rectus plication 7.5 millimeters. This is his video just before doing the adjustment. Need an adjustment, but as you can see, only for post-op day, the eyes are always straight. And this is the video where he was maintaining an orthophoria and a good binocular. So thanks for a patient listening.
Thank you, Shubhangi madam. Actually, following the use of mobile phones due to pandemic has actually resulted in not only myopia, but few cases are coming with sudden onset esotropias also. So I think that was a very interesting case which you presented. So with this, I would like to introduce our next speaker. He is one of my close friends, Dr. Uday Naik. He is a postgraduate from Shri Ganpati Netralaya, Jalna, and a fellowship from Shankar Netralaya, Chennai. He has also done a fellowship in Storm Eye Institute, Charleston, United States. He has been a consultant at Shri Ganpati Netralaya and at Choitram Netralaya, Indore. He's a faculty in many state and national conferences and has presented papers and instruction course in pediatric ophthalmology. Presently, he is working at Navtej Netralaya, super specialty eye care at Nanded. With this, I'd invite Dr. Uday Naik for his talk, please.
Thank you, Rishikesh, for the introduction. Till the time I share my screen, I would like to thank MOS organizing committee for giving me this opportunity to present over here. One thing about ideas I want to mention that for Corona, 2 waves came, but after that, lot many waves and tsunami came of webinars, and through those webinars, I arrived at a conclusion that anything and everything said about IDS is not wrong. But still, I would like to, shall I begin? Hello.
Yes, yes. Yeah,
okay.
Yeah, it's visible. You can start.
Okay. Still, I would like to talk on approach to intermittent divergent squint. As we all know that IDS is the most common squint entity which presents to us, and it is exodeviation which is intermittently controlled by fusional mechanisms. Usually the patients are asymptomatic, but the more vocal are the parents or peers who bring the patients to you. They complain of crossed eyes when the patient is either daydreaming or tired or sick. Few patients can come with asthenopia. Very rarely they come with transient diplopia. So depending on the presentation, the clinical phases of the squint clinical presentation varies. Most patient with phoria, mostly they are asymptomatic. The patient who are having IDS for distance, they may be symptomatic for distance. Patients who are having exotropia for distance, but either phoria or IDS for near, they have normal binocular vision for near, but suppression for distance. And when there is exotropia for distance as well as near, they completely lack binocularity. So in clinical evaluation, history taking is very important. Parents have to be made a partner in the management. We should involve them in decision making, and we should proactively tell them or demonstrate them that IDS is not a uniocular phenomena, it is a binocular condition. And in history taking, specific inquiry has to be done about frequency of the deviation or squinting, duration of the squinting, and in cases of children, you have to ask whether the child closes his or her eye in the bright light. As in all strabismus cases, sensory evaluation has to be done even before visual acuity estimation. So usually we lack, in private practices, we lack stereo acuity tests for distance, but at least for stereopsis for near should be tested on each and every visit. Accurate refraction has to be done, followed by orthoptic evaluation and ocular motility evaluation. So it is always a legacy and what I should say, luxury to have such a long 20 feet long examination room, but it helps it really helps in measuring IDS. We have to measure deviations in all the 9 gauges for near, for distance, as well as for very far distance. 86% of patients who undergo surgery for largest angle, they have satisfactory alignment, compared to 62% operated for standard distance, means 6 meter. So Kushner has even suggested that you make the patient to see outside the window or door, maybe for 1/4 mile, and then check your this deviation. One thing I would like to tell is that while measuring deviation, never ever allow the patient to see with both the eyes. Then measure near point of convergence. It is relevant in small angles, and if there is distant and near disparity in the angles, do occlusion test for at least 1 hour or +3 diopter lens test. So after doing measurement, we should arrive at a classification of IDS or a type of IDS, whether it is basic, whether it is divergence excess or convergence insufficiency type, or whether it is pseudo-divergence excess type. Then look for extraocular motility, and if there is any pattern, because we all know V pattern is very common in IDS patients with inferior oblique overactions. Also A pattern is common with superior oblique overactions. So what is most important to obtain a baseline evaluation, to monitor deterioration, and to monitor progression of intermittent exotropia. So here is the answer which I got. So there are many methods which are given for assessing the control, but what I personally feel is that a surgeon should adopt to a particular method. He should stick to it, and the method should be comfortable, and the surgeon should be consistent with it. So maybe what method I adopt may be different from others. So here is one clinical control score method in which the IDS is scored on a scale of 0 to 5, where 5 is the worst control. So here what we have to do is we have to observe the patient for 30 seconds without doing any dissociation. And in this 30 seconds, if there is constant exotropia, then the score will be 5. If there is exotropia for more than 50% of time, score will be 4. And if it is less than 50% of time, it will be score 3. So what I have found that this 5, 4, 3, they coincide with poor control. Now, after 30 seconds, we are supposed to do a cover test, and the squint will be manifested. And what we have to see is how soon the squint recovers. So if it is recovering after 5 seconds, the score will be 2. If within 1 to 5 seconds, the score will be 1. And if less than 1 second or immediate, it will be 0. So this 2 and 1 score corresponds with the fair control, and 0 corresponds with the good control. So here is the patient without doing anything, the squint is manifested. So definitely this is a poor control. In this child is taking a blink, and then the squint is getting recovered. So this is a fair control. Always give accommodative targets. Here, even after many rapid cover tests, the squint is getting manifested later, and on removal of the cover, the squint is getting corrected immediately. So this is a good control. So next, one more method followed is Newcastle score method, where they incorporate data from clinic and home, and they add up all the three, like the home data, then clinic data for near and distance, and they add up. If the score is 9, then it's a worst control. So what I personally do is I ask the parents, and if they say that the squint manifests rarely, and that too only at distance when fatigued, then I consider it as an excellent control at home. If manifesting less than 5 times only for distance, it's a good control. If manifesting more than 5 times at distance but aligned at near, it's a fair control. And if it is breaking frequently, it's a poor control. We can on stereo acuity estimation, if you are getting that binocularity is decreased, again it's a poor control. And we all know that natural history is yet to be fully elucidated. So in management, there is non-surgical and surgical, but again there is lack of clarity regarding criteria for intervention and optimal intervention. Non-surgical interventions are not much effective, but you can try it before as a method to buy times before proceeding for surgery. It usually can be helpful in less than 20 angles and with high AC by A ratio. PDGI is yet to come out with its final results regarding use of or minus therapies. There is insufficient evidence to recommend patching as a therapy, and prisms are not used most commonly. So indications for surgery are poor control, which is established by history and examination, presence of squint for more than 50% of waking hours, deteriorating stereo acuity, increasing size of deviation, cosmesis, diplopia, and suppression. All these are indications for surgery. Again, regarding timing, there are no consistent guidelines. But what literature says is that better sensory outcomes are achieved if the child is treated before 7 years of age or before 5-year duration of the squint itself. And if you find rapid loss of control noted, you can operate even before 4 years. Bilateral lateral rectus recession works well for all types except for convergent insufficiency, where we do bimedial rectus resection. But in literature, there is no difference found in BLR versus R&R. Importantly, this is the last one. Sorry for delay, but we can aim slight overcorrection for visually mature children, but for immature children and patient developing IDS after 10, we have to target orthotropia, and for long-standing IDS in adults, slight undercorrection. Target the largest deviation, but remember that even after good surgery, 1 in 5 have second surgery, may need second surgery. So these are some patients. Thank you very much. Thank you for delay. Thanks a lot.
Thank you, Dr. Uday. Actually, it's a very extensive topic, IDS. So 8 minutes obviously may not be enough. So thanks for a wonderful talk. I think I will invite the next speaker. We might run a bit short of time. The next speaker is Dr. Snehal Thakre. She is a professor in ophthalmology at MGM Medical College, Aurangabad. She has done a fellowship in pediatric ophthalmology from the prestigious L.V. Prasad Eye Institute, and also done an online course in managing myopia through Brian Holden Vision Institute in Sydney. She has presented many papers and posters in various national and international conferences, and also has publications in various peer-reviewed and non-peer-reviewed journals. With this, I will invite Dr. Snehal Thakre for an interesting talk on abnormal ocular movements. Dr. Snehal, please.
1 minute. Just a second. Huh? Yeah.
Yes, we can.
Can you see my screen?
Yes.
Is my screen? Yeah. Okay. Thank you for the kind introduction. Today, I will be talking about abnormal ocular movements. Think about beyond the eye, or maybe think unusual. So when we talk about abnormal eye movements, we think first thing comes to mind nystagmus or concomitant strabismus, which may be paralytic or restrictive. But sometimes there are patients like this young boy who is trying to move his both eyes, but they just don't seem to be moving. Or the child in the image on the right hand side whose eyes are moving in all the directions, but the movements are definitely not free and full in all directions of gaze. So what do we do now? It's best to take a step back, approach the patient again, take the history again, repeat the examination. History should be directed to towards the ocular complaints and details of diplopia, any anomalous head posture, diurnal variation, very important, and associated drooping of the lids. Neurological complaints also should be positively looked for, like difficulty in walking, balancing, any palpitations, tremors, history of any diagnosed neurological disorder now or in the past, or any relieving or aggravating factors. The evaluation of the ocular movements should be done properly, not missing out any of these vergence, ductions, vergences, saccades and pursuits, torsions, and FDTs and FGTs wherever indicated. A complete ocular examination will point toward the diagnosis, and maybe we should look for whether there is any proptosis, ptosis, cataracts, retinal degenerations, etc. Keeping these things in mind, I'll be discussing 4 cases. The first case is of a 16-year-old boy who came with a history of drooping of both the lids in the last 6 years, which was gradually increasing, and there were no other ocular complaints. He also complained of difficulty in getting up to sitting and standing position, inability to lift hands, difficulty in grasping, swallowing. There was no history of variability in either the ocular or the systemic complaints. I'll be just sticking to the positive findings on examination. His power was reduced bilaterally in both the eyes. Vision was near normal with the glasses. Then he had a severe ptosis in the right eye and a moderate ptosis in the left eye. The right eye showed a 15-degree Hirschberg's test. Cover-uncover test could not be done as no refixation movements were possible. Versions and ductions were severely limited. Convergence was absent in this child. There was a weak orbicularis. As you can see, you can easily open the eyes, and an absent Bell's phenomenon. Keeping all these things in mind, we did an ISPAC test, which is negative. The fundus examination was normal, and we kept a differential diagnosis of chronic progressive external ophthalmoplegia, congenital fibrosis of extraocular muscles, and ocular myasthenia gravis. CF-EOMS was ruled out because there was no history. This was since 6 years only, and he was 16 years old. There was no family history of similar complaints. Ocular myasthenia gravis also was ruled out because the ISPAC test was negative. There was no history of variability, and no other myasthenia-specific signs were seen. So keeping CPEO in mind, the patient was referred back to the pediatrician, and we did the lab investigations, which came out positive for myopathy. Keeping the myopathy, we did a muscle biopsy, and which showed the presence of ragged fibers, and which is strongly suggestive of a mitochondrial myopathy. Now, many mitochondrial disorders affect the eye, of which our patient classically fit into the category of CPEO with the presence of ophthalmoplegia, ataxia, short stature, lactic acidosis, and ragged red fibers on the muscle biopsy. So we made a clinical diagnosis of CPO and advised a confirmatory investigation of mitochondrial DNA analysis, but the patient did not refuse to do the same. He was sent back on symptomatic treatment with coenzyme Q and Benagilis and other to improve the mitochondrial functioning. The second case was again of drooping of eyelids, but this was only since 8 days and associated with high-grade fever. There was no history of variability, no other ocular systemic complaints in this 9-year-old boy. Systemic examination was normal. He had a normal head posture, but he had a mild to moderate ptosis in both the eyes. His ocular movements were limited, as you can see, but he was orthophoric in primary position. ISPAC test was done, though there was no history of variability, we did it. And because we do it in all patients of ptosis, basically. So you can see the improvement in the ptosis after the ISPAC test. But the limitations remained the same. So, but still keeping myasthenia in mind, I thought about doing an edrophonium or a neostigmine test, which was not available. We did an acetylcholine receptor antibodies, which were negative. But what 30 to 70% of the pediatric population is seronegative for myasthenia gravis antibodies. So the next test which should have been done was the single fiber EMG to confirm MG, but again, this was unavailable. But recent literature shows that the ISPAC test and the single fiber EMG have similar diagnostic accuracy with ocular myasthenia presenting with ptosis. So we made a clinical diagnosis of ocular myasthenia gravis, and we started the patient on pyridostigmine 20 milligram QID. He responded very well to the pyridostigmine, and you can see that his ocular movements are full and free now, and there is absolutely no ptosis. He actually went on to develop some dermatological association of the myasthenia gravis, which is called as pityriasis rubra. So we tip at the end of these two cases would be suspect myopathy or neuromuscular cause when ophthalmoplegia does not fit any particular pattern, associated weakness of other muscle groups and diagonal variation. Coming to the last two cases, I'll go quickly through them. 23-year-old female with complaints of diplopia and looking towards the left. She was admitted for postpartum PIH. And if you see, she had definite limitation of adduction in the right eye. And there is an nystagmus which was present in the abducting eye and convergence was present. Taking all the classical features, we made a diagnosis of internuclear ophthalmoplegia, right-sided. Patient was basically controlled with treatment of BP, but patient was lost to follow-up and her MRI showed an infarction in the pons. Lastly, a 4-year-old boy with outward deviation of the left eye. No other ocular complaints. Parents did not notice anything else. It was a known case of tuberculoma of the right frontal lobe at the age of 18 months. Vision was less, but this was, you can see, he had a compound hypermetropic astigmatism and a left hypotropia with a left exotropia. And if you see his ocular movements, there is definite limitation of the upgaze. Now, keeping all his clinical history and examination in mind, we came to a diagnosis of upgaze palsy with left eye exotropia, with left hypotropia, with both eyes meridional amblyopia. And this was status post neurotuberculosis of the right thalamus. So remember to keep nuclear, internuclear, supranuclear disorders when the gaze is involved, nystagmus is present, and history of neurological disease past or present. To summarize, I would say that abnormal ocular movements may involve both eyes not moving together, which we see more commonly, both eyes moving together but not completely. Take a good history, past and present. Neurological history is very important. History of variability should not be missed because myasthenia is a great mimic. As a matter of fact, myasthenia can mimic any of the cases, any of the 3 cases which I showed today. IcePack test is simple, cheap, and reliable. And do not miss the nystagmus. Lastly, pay attention to the details in ocular examination. Thank you.
Thank you, Dr. Snehal. Actually, it was a very nice presentation and very interesting cases. I mean, they are like a bit offbeat statistics and a lot of neuro-ophthalmological cases involved in that. So I think it was, I mean, very interesting cases which you had presented. And unfortunately, few of your, I mean, 1 or 2 patients had lost to follow-up. Otherwise, it would have been far more interesting to know what.
They were all actually at the time of this COVID began. So then we couldn't follow them up. So, though we called the myasthenia patient and he came back. Yeah.
With this, I would like to welcome Dr. Abha Kanade madam for her presentation. Dr. Abha is the first to receive Strabismological Society's Travel Fellowship award in 1994. She has been an executive committee member of Strabismo Society of India, which is now SPOCI, and organizing secretary of Strabicon in 2004. She was a treasurer of Pune Ophthalmological Society, and she has been a faculty in various state and national conferences, and also a registered faculty for Maharashtra Ophthalmic Society. With this, I would invite Dr. Abha for her talk, please.
Is my screen visible? Screen visible?
Yes.
Yes, ma'am.
Thank you. Yeah, I would like to thank Dr. Ragini Madam, MOS, and Chairman Scientific Committee, Dr. Himalini Samant, and Dr. Snehal Thakre for giving me this opportunity to speak on the subject. The incidence of Brown syndrome is very less. Means 1 in 450 cases of strabismus, you will find 1 Brown syndrome cases. Brown was first to describe the structural anomaly. It comes under the musculofacial innervational anomalies. With this entity, the amount of deviation doesn't correspond with the limitation of movement. You can see here that the deviation is not there in the primary position, but there is a large limitation of movement of elevation in adduction. The same way you can find in this also that there is hardly any deviation in the primary position, but absence of elevation in adduction with the hypertropia is there. The clinical features is the same: elevation of absence of elevation in adduction. There is unaffected elevation in primary and abducted position. Action of the superior oblique may be normal or overaction, and usually you will find positive post-action test. There are three main types. One is the mild, where you will see that limitation of elevation is present only in adduction. In the moderate variety, you will find limitation of adduction, limitation of elevation in adduction with the hypotropia in adduction. And in the severe type, all these two features are there, and you will find deviation in the primary position in the form of hypotropia. It is also known as Brown's plus. The main thing is that the complex machinery consisting of muscle, trochlea, tendon, which is especially vulnerable to a variety of developmental and acquired defects. In the congenital, there may be anomalies of the tendon, trochlea sheath, superior oblique muscles, or anomalies of the inferior oblique and adjacent structures. In the acquired, you'll find inflammatory, traumatic, iatrogenic, and miscellaneous causes in the form of pontine hemorrhage and metastasis from the carcinoma. Very rarely you will find that there is a slippage of the lateral rectus below the globe that prevents the elevation in adduction. So in this type of patients, the MRI is essential. In our patients, improvement after tenotomy, so LR, so there was no involvement of the LR. It was not the cause. The treatment is conservative and in surgical intervention. The conservative treatment, when because the spontaneous resolution is possible, I will show in my cases. Steroid injection at the site of the trochlea, especially in cases of congenital pediatric arthritis patients, and duction exercises. Surgical intervention when there is a deviation in the primary position and significant abnormal head posture. You need to see these patients and do the surgery. In this patient, which I showed, deviation in adduction. So this patient was asked for the follow-up. I just gave her adduction exercises, and you can see that her deviation improved. You can see the elevation has improved in adduction. I just called her 1 year back again, and this deviation is not there. She is a patient of, she's high hypermetro patient. There was a ESO deviation, and the left eye was unlit. I just wanted to record the movements, and accidentally I found that there is a Brown syndrome. Means there was as of elevation in adduction. Since the patient was high hypermetropic, so I gave her glasses and asked for the follow-up. The otherwise I was astrolepic, and you can see that, believe me, she is the same patient. She regularly comes for follow-up, and you can see that there is definitely improvement of elevation. This is a patient of Brown's plus. Here you can see that there is a hypotropia in the primary gaze, and there is hypotropia, and you can see that absence of elevation. This patient is very good candidate for the surgery, but patient didn't came for the surgery. So what are the surgical options? You can do a stripping of the superior oblique. You can do tenotomy, tendinectomy, Z-plasty of the superior oblique, depending on the amount of deviation, weakening or recession of the superior oblique at insertion, lengthening of the superior oblique using the 240 retinal band. But nowadays it is not mainly done because of lot of adhesions can occur. Mobart's suggested trochlear luxation, but not that. These are various diagrammatic representation of the various surgical procedures. I will not go into the details. This was a patient that had a limitation of elevation, and she had an abnormal head posture as well. So this patient was operated for. We did superior oblique tenotomy, and she improved, but there was overaction of the inferior oblique muscle. But since the patient used to come for the regular and there was no deviation in the primary position, so we didn't do anything. But as she grew, she was very much bothered about her inferior oblique overaction. Means, so we operated for the inferior oblique. The inferior oblique weakening procedure was done. Yeah. So just yeah, the patient of this patient had a convergent lesion, so and with the Browns. So as we were about to operate on the medial rectus, and we did the superior to the superior rectus insertion, and the patient improved. This patient came after a long time for follow-up, and very little inferior oblique overaction, but I don't think there is any need to do the surgery for that. So, in conclusion, cause, wait and watch. If there is no significant anomalous head posture, ask parents if they want to postpone the surgery, not to correct the head posture. Choose appropriate surgery. Long-term follow-up is essential. Inform your pediatrician and orthopedic colleagues that any patient with abnormal head posture, take ophthalmologist's opinion, because one patient received heavy doses of steroids, oral steroids for the abnormal head posture. One patient, in view of the abnormal head posture, was advised neck muscle surgery. So all these things are there, and it is my commitment that I always keep one slide for the nature, save nature. It is a concept of virtual water, that is hidden water, by Tony Allen in 1993. 1 cup of coffee requires 140 liters of water. 1 liter milk requires 1000 liters of water, and 1 kg wheat requires 1350 liters of water. 1 kg rice requires 3000 liters of water. And this is by the Mr. Atul Devgaonkar book Vishwase Arth. So we should respect water as well. Thank you. Thank you for patient listening, and thank you.
Thank you. Thank you, madam, for a wonderful talk on Brown syndrome. We are reaching the last presentation of today's session by Dr. Vaishali Une. Dr. Vaishali is a associate professor at Government Medical College, Dhule. She has done fellowship in pediatric ophthalmology from Arvinda Institute, Coimbatore, and AIMS, Delhi. She has presented at WCPOS at Milan, Hyderabad, and APACRS at Kuala Lumpur, and APOS, Jaipur. She has been invited as a guest lecturer at Orlando, Florida. She has multiple international publications, especially in JAPOS. Presently, she is, I think, she is the president of Aurangabad. She was the president of the Aurangabad Ophthalmological Society. I'll invite Dr. Vaishali for her talk on Duane syndrome.
Hello, am I audible?
Yes.
Yeah, sorry, I was
Yes.
Muted. Yeah, thank you so much, Dr. Rishikesh and Dr. Snehal and Ragini ma'am for giving me this opportunity. And it's an honor to present here amongst the stalwarts. So I'll now present my topic on management of Duane's retraction syndrome. So Duane's is a defective horizontal eye movements with palpebral fissure narrowing on adduction and widening on abduction. It is often referred to as Stilling-Turk-Duane syndrome because first in 1887, it was Stilling who first presented about this syndrome, and it was later popularized by Duane and Turk. So it is more commonly in females, about 60% of females. Unilateral cases are about 80%, and which involves the left eye. And genetics plays a role about sporadic. It is commonly seen in sporadic cases. There is a mutation in CHN1 gene. So my topic is about the management of Duane's retraction syndrome. So why do we need to manage the syndrome? The first and primary thing is about the altered head posture. So if you see carefully, that this is the face turn towards the right, and then there is limitation of abduction in the Duane syndrome. In type, there are various types. We'll come to that, and then there is gross retraction of the globe. So these are the three things, and for this we need to, these can be the indications for the surgery as well. So altered head posture, then the retraction of the globe, and limitations in adductions and abductions. So quick small video on how the various things we see in the Duane syndrome. So obviously this is ortho Duane's, but yes, we can see the abduction limitation in the right eye, and then you can see the upshoot, and the IPF is narrowed so much. So these are the classical findings which we see usually in a Duane syndrome. So etopathogenesis is paradoxical. Most important is the paradoxical innervation to the horizontal recti, and the left eye preponderance is seen in 75%, whereas the bilateral cases are around 20%. So now it is a part of the CCDD, that is a congenital cranial disinnervation disorder, and it is comes under restrictive pathology. It can be congenital acquired. Acquired can be of post-traumatic dysthyroid or retinopathy, or even in cases of cysticercosis, we can get this syndrome. So commonest is the type 1, where we have only abduction limited, and adduction is normal. There can be esotropia. So there are another variants are ESO-DRS, EXO-DRS, and ortho-DRS. So there is globe retraction, as we have seen earlier in the video, and the interpalpebral fissure narrowing on adduction and widening on the abduction. Type 2 is less common than the type 1. It can be associated with the exotropia, and abduction may be normal or limited and associated with globe retraction and narrowing of the interpalpebral fissure. Type 3 DRS, there is both abduction limitation as well as adduction limitation associated with the two other findings, that is globe retractions and IPF narrowing. The upshoots or the downshoots, which we saw in the video, was that is due to the co-contraction of the horizontal recti and the slippage of the globe under the tight lateral rectus while movements. So it does not follow the Sherrington's law, and the comfort we can confirm it by the post-duction test, where there will be so it is very important that we do a post-duction test in most of the cases of the restrictive strabismus. Differential diagnosis, primarily it can be lateral rectus palsy, then infantile esotropia with cross fixation. Also, we can get confused with it. But again, it will not be associated with the globe retraction and the decreased interpalpebral fissures. Then recovered third nerve palsy may mimic Duane's, so we have to rule out about that also. And when there is medial rectus entrapment after a fracture, medial wall fracture, that can also cause retraction of the globe. So the coming to the surgeries, so like in the previous slide I showed that altered head posture in cases of ortho-Duane's, then whether it is associated with esotropia, associated with exotropia, and marked globe retraction. Is there any medical management? In very mild cases and very small deviation, then only prisms can be helpful. And the surgeries can be for the, again, it can be differentiated into mild, moderate, the ESO or exod ones. So most of the times we do the medial rectus recessions, either if it is a mild case, we can go for unilateral. And if it is bilateral, then we can go for medial rectus, and depending on the if there is the isoduance angle is more, then we can go for both medial and lateral recessions, and the other eye ipsilateral as well as the contralateral recessions of the medial rectus. Y-split of the lateral rectus for the upshoots are most of them prefer the posterior fixation of the lateral rectus, and vertical recti transposition is now mostly commonly preferred when with or without medial rectus recessions. So just an thing that how the Y-splits helps. The Y-split is done almost 20 to 22 millimeters. The lateral rectus is split, and in between a difference of 20 millimeters is kept. And again, it can also be recessed by 6 to 7 millimeters, and it gives excellent results in these kinds of upshoots. So the vertical recti transpositions are the superior rectus are commonly used, and they are transposed either we can do a partial recti to the lateral rectus suturing, or sometimes even we can go for the medial rectus. To summarize, in unilateral ESO-DRS, we need to do go for the medial rectus recessions, unilateral, or we can do asymmetric recessions in both the muscles. And then if angle is small, we can go for just a single muscle. Large angles, ipsilateral as well as medial and lateral recessions are needed. Upshoots and downshoots can be managed by the bi-splitting of the lateral rectus. Severe abduction deficiencies can be managed by vertical recti transposition or superior recti transposition, especially so. And role of adjustable sutures is also there, though personally I haven't tried in any of my DRS case. So thank you all for a patient hearing, and thank you for giving me this opportunity. Thank you again.
Thank you, ma'am. Thank you, Dr. Vaishali, ma'am. Actually, you have to individualize every case of Duane syndrome, but thank you for a wonderful presentation. Actually, we are running short of time. Actually, we have exceeded the time. So with this, I think we will need to conclude the session so that we can.
Yes, that was the mainstay, that each DRS needs to be customized. So that is the mainstay that go according to case. Thank you very much. Thank you, Dr. Rishikesh.
Thank you. I'll hand over to Dr. Parikshit, sir.
Yeah, thank you, everyone.
Thank you, sir.
Thank you, everyone, and
Thank you,
happy
sir.
Diwali in advance. Stay home, stay safe.
Thank you all. Nice cases, nice talks.
Thank you, everyone. Thank you so much.
Thank you. Thank you all. Thank you.
Parikshit, sir, mute answer.
Thank you everyone for handing over the hall to the next session. I said it is slightly intimidating speaking in a hall full of so many strabismologists, and that too so many intelligent ladies. So we'll start with the next session. And once more again, thank you to Professor Ragini Parikh, Dr. Himalini Samant, and our young doctor from Aurangabad for putting this all together. So can I
thank you, Dr. Parikshit. I'll just interrupt you. The dynamic president of the MOS, Dr. Parikshit Bhai, and I won't interrupt him, but I just would like to give him a big hand of applause.
Thank you, ma'am. There is a small request from Dr. Manjushri Bhate that she had wanted to speak earlier, for which Dr. Zai Kerkar has kindly consented, so we can just swap their talks. And may I start?
All yours, sir.
Yeah. Can you see my screen on strabismus resurgery?
Yes, sir. Sir, I'm Dr. Shruti. And
Hi, Dr. Shruti.
Yeah, hello, sir. So
Hi.
I'll be moderating this session. So
great, thank you, doctor. So please point out if I am overshooting time. I'll try to make up. And this is actually a talk that should be right at the end of the session, because I have to do something again at 4 o'clock. They were kind enough to put me earlier.
Excellent,
Well,
sir.
for strabismus resurgeries, why do we do a resurgery? Well, as ophthalmologists or as any surgeons, nobody likes resurgeries because that means something not perfect had happened in the first. So we have to do it again. But then resurgeries are there if we have a planned 2-step procedure where one step was done earlier and now it's the second step. or in cases of a slipped or lost muscle in which the MR is the commonest lost and perhaps the LR is the commonest slipped. And in strabismus, we do see abandoned surgeries when somebody else has attempted a surgery but somehow could not go ahead, and then we have to deal with it. Very rarely we come across a wrong diagnosis, especially an accommodative component of esotropia that was missed. And I'm sure all of us must have seen at least a case in our career. Or a wrong operative technique, that is, the surgeon started wrongly or strayed midway during the surgery. Or an intermittent exotropia that was operated very early in life and later has become esotropia. Or sensory strabismus, when, of course, the eyes don't stay straight. Or resurgery is also there in restrictive strabismus, when it is difficult to accurately calculate the dose-response relationship, like in dysthyroid ophthalmopathy, secondary to trauma in paralytic squints. Well, resurgeries are common. But what we have to understand is almost 60% of strabismic surgeries will have a post-operative deviation of more than 10 prism diopters a decade after surgery. And this is data from the American Academy of Pediatric Ophthalmology and Strabismus in both exotropia and esotropia. And as we are operating children earlier and earlier in life, perhaps in the first half of the first decade, well, we are going to have some kind of a resurgery when the child is in the second decade. So the need for a repeat strabismus surgery is not uncommon. So, well, when do we do it? In undercorrections of up to less than 10 prism diopters, it is still acceptable because peripheral fusion is possible, but anything more than that would need a resurgery. In young children less than 4 years, a larger undercorrection negates the indication for surgery. An overcorrection of up to 8 diopters may be accepted, but more than that usually lands up in a problem. Well, to prevent something like this from happening, the refraction must be checked and rechecked before we are operating the patient. An amblyopia treatment must be completely done. An orthoptic evaluation must be done properly. And well, if we are doing it, then a force duction test is a must, because there, after the first surgery, some restrictions, some adhesions may have developed. The surgical plan is to be drawn and the patient is to be counseled. So everything that we do for a primary surgery, and some things even more and more diligently. So in esotropia surgeries, recess resect surgeries have lesser chances of undercorrection than bilateral medial rectus surgeries. If initially a bilateral MR recess is done, we could do a MR marginal myotomy or a LR resection or a bilateral LR resection. If there is an undercorrection of esotropia, if it's 20 to 30 prism diopters of undercorrection, then for one eye, we can do MR marginal myotomy with LR resect. With a much larger one, 30 to 50 prism diopters, both eyes marginal myotomy with resect. And of course, if it's more than 50 prism diopters, we will need a three muscle surgeries. If there is an overcorrection of esotropia, and God forbid we have had a secondary exotropia, well, we have to think of the Cooper's dictum, is to plan and execute the second surgery as if the patient has never had previous surgery. Again, for the treatment of overcorrection, do not reverse the original surgery. If ET has become XT, do not undo MR recess, LR resect, rather do the other eye, LR recess. Because every time we are touching the same muscle, there are chances that there will be more adhesions, and we are not sure of our dose-response relationship. If the overcorrection is less than 10 prism diopters, peripheral fusion takes care of it. In fact, small overcorrections can lead to faster reappearance of normal retinal correspondence. So when to reoperate? If it's cosmetically undesirable overcorrection of more than 12 to 15 prism diopters, we can tackle it after 8 weeks. But if it is in the immediate post-op period and a lost or a slipped muscle is suspected by a sudden large, often consecutive strabismus, then early intervention is beneficial. The sooner you do, the better it is. The usual equation changes. The dose-response relationship is difficult to predict. Adjustable sutures can be a great help, but then they need skill and patience on part of the surgeon and faith and cooperation on part of the patient. So even that is very, very important if we are thinking of adjustable sutures. They definitely improve chances of good outcome. So, I mean, almost 90% good outcome we can get. But there is a need for short general anesthesia for adjustment in children and uncooperative adults. And the adjustment has to be done on the second postoperative day. So there is a randomized controlled trial from Guru Nanak Eye Center, Delhi, which shows no significant difference if we do adjustable and non-adjustable. But another RCT from KGMC Lucknow and Venu Delhi has found modified adjustable sutures to be more predictable. But then in thyroid-related strabismus, people have even tried weak magnetic fields, scleral implants to help deal with whatever is the improper correction rather than doing direct resurgery. Sometimes we may need a horizontal rectus muscle transplantation, a long-term follow-up, of course, is needed for this. But the main pitfall in resurgeries, the normal anatomy is disturbed, and identifying the muscles needs experience and patience, and be prepared for surprises. Again, if in doubt, it is better to grade the surgery to tackle one or two muscles at a time rather than attempting multiple muscle resurgery. Thank you.
Thank you, sir. That was a really interesting talk, and you covered all aspects of resurgeries in general. Dr. Gogate, I think I couldn't introduce earlier. He's needs no introduction, sir. Is the president of MOS, and he's a gold medalist in MS Hospital, and sir is currently doing private practice in Dr. Gogte's eye clinic and has several publications to his credit, and his main interest is cataract, pediatric ophthalm, and community ophthalmology, in which he has done an MSc. Sir, excellent presentation, sir. Just a small question. Do you see any difference after surgery in cases when you have to go back and re-recess a muscle, for example, medial rectus? Do you see the deviation, the dosage change, the MM that we get, the PD correction that we get per muscle? Do you feel there is a change, sir?
There is a change. We can never be sure of the exact correction. So that is why if more than one muscle needs to be tackled, I would prefer to grade it. If it's an adult and if they are willing, then doing an adjustable sutures, this is perhaps the best technique that is there. But in India, of course, if we give general anesthesia, then it has its own this. So you can't post a child for GA today for surgery, again a short GA tomorrow for doing it again. So there you have to counsel the parents. But mercifully, I have only on 2 occasions have had to do a resurgery on a child, and that was operated somewhere else a couple of years earlier. But with adults, it is there. And as I think you grow in practice and as your hair get more and more white, and you've been in it, you see that resurgeries are not that uncommon. Earlier, we used to think that it's very rare to have a resurgery. That's not the case.
Right. So thank you so much. We'll now have Dr. Manjushri Bhate for the second presentation as requested by Professor Gupte. So Dr. Manjushri is one of the finest pediatric ophthalmologists from India. She has completed her training in pediatric ophthalm from Children's Hospital in Westmead, Sydney, under Dr. Frank Martin and team. And she has also done a short-term training from Akron's Children's Hospital in the USA. Dr. Bhate brings with her a vast and varied experience and has worked in John Hunter's Children's Hospital in New South Wales. And she is currently the associate ophthalmologist at LVPI, and her special interests are pediatric cataracts, strabismus, genetics, and pediatric neuro-ophthalmology. We welcome you, ma'am, and it's an honor to have you here with us today. She will be talking to us on thyroid strabismus. Over to you, ma'am.
Thank you so much. And can you hear me?
Yes, we can. Yes, we can, ma'am. We can hear you. We can see your slides as well.
Thank you. You might hear some background banging noise because of some construction, so I apologize for that. I'd like to thank the organizers and Himalini and Parikshit Gokte for giving me this opportunity to present at this session. So we'll go straight to the talk. It's on thyroid strabismus, and it's a vast topic, but I've tried to keep things very short and simple. So as we know, thyroid eye disease is an autoimmune inflammatory disease of the orbital tissues. And here, as you can see, is the Rundle curve, which basically talks of the timeline in a thyroid eye disease. So the initial active thyroid phase and later on the chronic or the fibrotic phase. So this usually goes on for about 24 to 30 months. The most important principle in thyroid eye disease is first is to control the active disease. So this can be done with the help of either systemic steroids, oral or intravenous, irradiation, monoclonal antibodies, and there's a lot of new interest in teprotumab, which is one of the newer monoclonal antibodies. And also we need to advise lifestyle modifications to the patients. Then we come to treating the sequelae of the thyroid eye disease, which involves correcting the orbital deformities in the form of orbital decompression. More so, this becomes urgent if there is any optic nerve compression at the apex. Then looking at the eye muscles, so treating the strabismus, and then is the eyelid. So this is best managed with a multidisciplinary team approach. Coming specifically to strabismus and thyroid eye disease, it approximately happens in a smaller percentage of patients. And in India, we see much lesser strabismus and thyroid eye disease, I would say, as compared to the Western world. Then all the muscles could be involved, and it's very often asymmetric. The common muscles is the inferior rectus, the medial, and the superior rectus involvement. And we usually see these patients as they present with diplopia, abnormal head posture, or sometimes with additional psychosocial issues as well. The aim of managing the strabismus is mainly to give the patient a comfortable field of binocular single vision, both in primary as well as in down gaze, and give him a good cosmesis. So with these in mind, we just come to a few examples. So to begin, first of all, our ocular motility workup needs to also match the MRI findings. As you can see over here, this patient has got a very large hypertrophy of the right eye. And when we match up with the MRI of the orbits, we can see these massive extraocular muscles, and the largest being the right superior rectus over here, which is straight away pulling the eye up. So it's important to collaborate the radiology as well as the clinical evaluation. So when we come to managing the non-surgical aspect, that is treating the patient if it's a reasonably small angle with prisms. Fresnel prisms are generally preferred more than ground glass because the angles may keep changing as the thyroid eye disease varies with the progression in the course. Then optical, so we can keep separate distance and reading glasses. Botox, this is used a little sparingly in thyroid eye disease, but does have a role, and monocular occlusion. Looking at the surgical management, so we need to basically make sure that the angle is stable before considering surgery. And in as far as surgical management is concerned, there are some controversies when it comes to the surgical management. So one is whether the patient should be operated under GA or LA. So this depends on the systemic condition of the patient. Then the choice of sutures. So there are, I would say, groups which are believers or non-believers of adjustable sutures, and some who prefer absorbable or over non-absorbable sutures. Personally, I prefer a Vicryl suture, a hangback technique, and if it's a horizontal muscle, then use an adjustable suture technique, not for the inferior rectus or vertical muscles. So let's look at a few examples. So this is a 56-year-old patient. He's a businessman, and he's had his thyroid eye disease, which has been stable for more than 1 year. So he had a decompression of his right orbit, and his strabismus and diplopia got much worse. Following that, he just refused to have an orbital decompression for the left eye, and all he wanted was strabismus surgery. And and the MRI images confirmed the enlarged muscles in both the orbits. So this is his pre-op assessment. As you can see, he's got a large right hypertropia and also reasonable right esotropia as well. He does have limitation of elevation of the left eye additionally. And so this patient then underwent a surgical procedure. He underwent a stage procedure, a superior rectus recession on hangback, almost to the tune of 12 to 13 millimeters, and also a right medial rectus recession. Post-operatively, there was a significant improvement in his cosmetic alignment and also with regards to his diplopia. And now he's cruising along with prisms. And again, as I said, he just refuses to have any orbital decompression for the left eye. He's not as much bothered with his cosmesis now. Next, we come to this patient, Mr. XY. So he basically again was stable on and well controlled. He was not advised orbital decompression because it was not necessary, but he had already had a previous extraocular muscle surgery, and he had already had Botox in the left inferior rectus. Despite all this, he had a left hypotropia of about 40 diopters, and also limitation of elevation, as you can see over here, of the left eye, and some limitation of abduction of the left eye. So he again underwent radiological imaging to confirm the bulky extraocular muscles, as we can see here, and then underwent a superior rectus recess of the right eye and an inferior rectus re-recession of the left eye. This was just to balance the defect. And so he was happy, and ortho in primary position, does have some double vision while looking down, for which he uses prisms. He may need a lower lid retractor repair later if at all he is concerned about that. So I'm just going to go through one more example just to sort of just reiterate that it is a complex strabismus and it needs to be individualized and tailor-made. So this patient had multiple systemic issues. He was diabetic, hypertensive. He had some heart issues as well. He had a stent. He was diagnosed elsewhere with the thyroid eye disease and has been managing his diplopia with patching for 1.5 years. And he had a left hypotropia of about 35 prism diopters, otherwise stable, and underwent strabismus surgery with again balancing the defect with the right superior rectus and the left inferior rectus. This patient underwent surgery on adjustable sutures and is doing reasonably well there. So just to conclude, so strabismus in thyroid eye disease is challenging, and the patients can be managed without surgery as well. With surgery, we need to delay until things are stable, and at the time of surgery, it's important to relieve the restrictions, make intraoperative changes to the surgical plan if required. And teprotumumab this may change the way we manage thyroid eye disease in the future. So this would be probably a game changer to look out for. Thank you very much for your patient listening.
Thank you, ma'am. It was a very interesting talk. Please excuse the sound in my background as well. There is a construction going on. So you rightly said that there is requires to be tailor-made. Each patient is different. Have you had any experiences where you have had a recurrence of the thyroid disease after the surgery? You know, if there's an uncontrolled thyroid, do they recur? Does the hypertropia recur?
I've had very few patients who have shown some recurrence and some worsening of their deviation after strabismus surgery, yes. And in those cases, I would tend to repeat the MRI because sometimes there can be newer muscles that could be affected. And more often I've had, I wouldn't say often, but in some cases I've had these patients who've come with oblique muscles being affected then. And in that case, it becomes quite challenging to then try and help their deviation. So again, it just depends on an individual case as to how that can be tackled. But that's not something which is totally unheard of. It does happen in a few patients, yes.
Thank you, ma'am. Thank you for that. We will have the panel discussion in the end. So I would like to introduce our next speaker, Dr. Zai Kelkar. Dr. Zai Kelkar is practicing in Pune. She's she's a director of Kelkar Institute, the National Institute of Ophthalmology. She has done her pediatric ophthalmology fellowship from the University Hospital at Ghent in Belgium. She has several publications to her credit. We welcome you, ma'am. And she will be talking to us today about monocular elevation deficit, another interesting strabismus entity that we see in our OPD.
Yes,
Over
thank you
to
very
you,
much.
Dr. Zai.
Yes, thank you very much for the kind introduction. Always nice to be a part of MOSCON. I must especially congratulate Parikshit Gupte sir, Lahane sir and Lagini madam for the seamless coordination of this conference. It's not easy to be doing a state level conference on the online platform. So kudos to you. With this, I start my talk. It's on monocular elevation deficit. So as we know, MED was originally called the double elevator palsy, but now it is defined as the limitation of elevation of the affected eye from any position of gaze with normal reductions in all other gazes. So only the up gaze is affected, and it is more accurate than the double elevator palsy because it encompasses everything like the isolated superior rectus palsy, the inferior rectus restrictions, and the supranuclear lesions as well. So what is the pathogenesis of MED? So superior rectus is the main muscle, as we all know, for elevation of the eye in adduction, abduction, or even the primary position. So in the presence of a normal superior rectus, the inferior rectus restriction can cause MED. Secondary contracture of the inferior rectus due to primary superior rectus palsy can also lead to MED. And Jampel and Fels suggested that unilateral supranuclear lesions in the pretectal area or inside the third cranial nerve can also cause MED. So it is characterized by three main clinical features. That's an elevation deficit, there can be ptosis or a pseudotosis, and Marcus-Gunn phenomenon also can be seen in about 25% of cases. So ptosis or pseudotosis is noticeable in more commonly noticeable when the normal eye fixates, and true ptosis may be present in about 25% of cases. So other features are that Bell's phenomenon is usually absent in cases of the inferior rectus restriction, which is expected because the inferior rectus is not allowing the eye to move up. Amblyopia also may be present if there's a constant deviation of the affected eye or if there's a associated true ptosis or anisometropia. Diplopia will be seen in cases which are acquired MED. It will be naturally absent in congenital cases of congenital onset. Abnormal head posture is also seen very frequently where the patient can present with a chin elevation. But again, there can be no abnormal head posture also if there is orthotropia in primary position of the affected eye or if the affected eye is amblyopic. There are three classifications of MEDs, type 1, 2, and 3. Type 1 includes patients with primary inferior rectus restriction or fibrosis. So they are often orthoptic in primary and the FDT is positive. In type 2, it's mainly the superior rectus palsy and the FDT here will be negative. While the type 3 is the supranuclear type, again the FDT is negative. So let's quickly consider the differential diagnosis. In the previous session, we have heard Kannada madam explain about Brown syndrome very nicely. So in Brown syndrome, the characteristic is that the elevation is limited only in adduction. Normal elevation in abduction as well as straight up is always present, so that differentiates it from Brown's. Vertical Duhan syndrome is also possible, but of course this is pretty rare. Then congenital absence of the superior rectus or the inferior oblique can also mimic, but these will be associated with craniofacial anomalies. Congenital fibrosis of the extraocular muscles, the CFEOM, can also affect the inferior rectus initially, and this can be confused with MED in the earlier cases. But bilateral presentation, involvement of the other extraocular muscles are the features which will help us to distinguish it. The most difficult part to distinguish is the third nerve palsy, because third nerve palsy may simulate findings of MED. But abnormal pupillary reactions, if present, again, they clinch the diagnosis towards the third nerve palsy. But a palsy of the superior division of the third nerve, which affects the superior rectus and the levator muscle, is very difficult, if present, to distinguish from the MED. So what is the management? Like in every case, management is medical and surgical. So correction of the underlying refractive error is of prime importance. As soon as we see a case of MED, we don't directly jump to surgery. First, look at the refractive error. Amblyopia, if present, should be treated provided the lid is allowing you to do patching for the other eye. And then, of course, surgery will be indicated. So indications of surgery are significant vertical deviation in primary gaze, significant abnormal head posture, deviation-induced amblyopia, diplopia in primary gaze, or restricted binocular phase. Goal of surgery is to improve all that and improve the position of the affected eye. well, you cannot bring it perfectly, but if you can get it into ortho position in the primary gaze, that serves the purpose for the patient. And this is what should be explained to the parents when we take up the patients for surgery. This is a very nice chart that I found in the DOS Times. If you have MAD, FDT is the thing which will help you decide what exactly, how you want to proceed with the procedure. If the FDT is positive, then naturally the inferior rectus is tight, so that the inferior rectus needs to be tackled first. In cases where if the inferior rectus is not restricted, then you can think about NAP surgery. Again, this of course, this chart is very useful, available on the internet also. And depending upon the degree of deviation, you can go on making changes to your surgical plan. So you can go on adding a few procedures. So let's look at the NAPS procedure. It is the commonly practiced procedure, well-established treatment. And the main idea is that you shift the tendons of the medial rectus and the lateral rectus to the superior rectus. Let's see this in a video. So an FDT is very important. So you see if the inferior rectus is weak or tight. So as you see, it was the medial rectus, you hook the muscle, secure the muscle, and then disinsert it. Same procedure is being done for the lateral rectus. This is the superior rectus muscle, hook the muscle. I feel you should keep that small bridge of conjunctiva intact so that the healing of the conjunctiva is very good. It helps reduce the fibrosis. The muscles close to the insertion of the superior rectus. You don't have to actually suture it to the superior rectus. That helps us with the helps us avoiding the anterior segment ischemia syndrome. With both the knots, make sure that you are passing it through the sclera and securing them close to the insertion of the superior rectus muscle. Do not want, because the sclera is very thin near the insertion of the muscles, it is better that you hold the muscle with the superior rectus forceps. Again, an FDT after the conclusion of surgery will tell you whether the muscle has, the eye is now, if it's a negative FDT or not. So this is one of few cases that this girl had a MAD pre-operative, and this is the post-NAP procedure. She will now undergo a ptosis surgery, but you can see that the eye is now orthotropic. The hypotropia of the left eye has reduced after the NAPS procedure. This guy presented with a MAD and
sorry to interrupt, madam. The time is
NAPS procedure. This is a post-operative video.
It's a beautiful video.
Have a look at the literature review quickly. So there are a few problems with the NAPS procedure also. So we should know how much the NAPS procedure is able to correct, what exactly the effect of transposition surgery will have, how will the corrections go on reducing over time. So remember that there's no grading in the correction of NAPS. A large variability in the amount of correction is obtained with this procedure, and there's a tendency to drift outwards with time. So the augmented NAPS is the procedure for choice and gives superior results. In augmented NAPS, you just put a posterior fixation suture on the horizontal recess. And they've done a series of 14 patients and the results have been very good. Again, same, Cooper and all also have said that the NAPS procedure, while useful, you have to be very careful. And if also horizontal deviation is present, you better correct the horizontal deviation in the other eye rather than doing this in the same eye. So to conclude, MAD is a challenging condition. Management of amblyopia should not be overlooked. NAPS is the procedure of choice, though it should be taken with complete understanding of how the procedure will work for that given patient. And the treatment is multi-staged. Proper counseling of the parents about the outcome is very essential. Thank you very much.
Thank you, madam. Excellent videos and excellent way of approach. Especially love the flow chart that you were able to show. It gave a very clear way of how to observe the surgical management for such entities. Dr. Manjushri, would you like to add? Maybe you have any comment or question? Anyone from the panel who would like to comment on this?
Shruti, do you do Nishidas or do you do NAPS for MED?
I still do NAPS, ma'am, but Nishidas is something that's coming up, but I still prefer to do NAPS.
Is there any particular reason?
No particular reason. It's just that I'm more
Do
comfortable with
naps
the
because
procedure.
that's the only surgery we
Yeah.
know for sure.
Yeah, we're more
I've been
comfortable
doing
with
it
that
for so long.
procedure. Yeah, exactly. So that's what. But Nishida's is coming up as a very promising thing. So definitely we should be trying that out. Do you have any experience, ma'am, with Nishida's?
So I've done both. And personally, I also prefer naps. I find Nishida sometimes a little difficult, because unless your
Yeah.
dissection is very neat and clean and deep, it's very difficult to really actually pull the muscles. It's not as easy as being discussed in conferences,
Right.
particularly if
And
your muscles are tight.
yes, ma'am. And I also feel augmentation with the naps gives a much better effect as well. So many a time I do end up giving an augmentation suture to.
Have you ever had an overcorrection with your naps?
No. Almost always I do feel that we cannot go wrong. There's always an undercorrection,
Never
if
an
not
overcorrection.
correct. Never an overcorrection.
I mean,
Almost
just
never.
about 7, 8 of them so far, but never over.
Correct.
Yeah.
We'll go on to the next talk, Shruti.
Himalini, can I interrupt you for a second? Just a second.
Yes, ma'am.
Thank you, Dr. Manjusha ji. Thank you, Zai. And thank you, Himalini. I must mention over here that Himalini for so many years has been doing the squint and the neuro-ophthalmology and the pediatric sessions, and a wonderful feast in terms of the speakers and everybody who are present here today. And I would like to thank all of you, Shruti, for conducting this so well, Dr. Kavita, and everybody present here today for your time. And thank you, the lovely Himalini, for the sessions you plan, and you are so perfect at doing it. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
That I needed to say.
Thank you, ma'am, for your kind
And
words.
Parikshit Gopte for being the ever supportive, the calm, and the helpful president.
Shruti and
Yeah.
Hema, can I make a comment about the previous about
Yes, of course, madam.
overcorrection of naps?
Yes, ma'am.
I think we should have a little word of caution in that. See, when we have done an inferior rectus recession first and we follow with the naps procedure, especially full tendon nap if we're doing, there is definite chance or risk for an overcorrection. We have had patients who have really had at least 20-25 prisms of hypertrophy because naps also has a time effect over time. Immediately it may appear fine, but so it's a very strong surgery, very effective surgery. But yes, there is a small risk, but yes, there is a risk, especially when we.
So you prefer half tendon? You prefer half tendon?
Not always, but if the deviation is more, what I'm saying is it's not that you cannot overcorrect.
Okay.
Yes.
We have had at least 2 patients in these years I have seen in a fellowship also and during consultancy also that there has been overcorrection. So just a little word of caution. That's it.
Yes, I think we need to do that many cases to reach to that point where we
exactly
start
combined
overcorrections.
Combined pool.
Yeah,
Anyway,
absolutely, madam.
thank you,
So the experience speaks. Thank you, madam. Thank you for that comment. So I would like to invite Dr. Prachi Agashe for the next talk. Dr. Prachi is a very well-renowned pediatric ophthalmologist and squint surgeon. She has done a pediatric fellowship at Arvind Eye Hospital, Madurai, where I have done mine as well. I have done my PhD there, and ROP fellowship at LVPI in Hyderabad, and she's currently doing a private practice at Agashe Hospital. She's a very dear friend and a colleague. I invite Dr. Prachi for the next talk on utility of Fard and suture in squint. Over to you, Dr. Prachi.
Thank you, Shruti, for the kind introduction. And a big thank you to Himalini Madam, Ragini Madam, and Gopte Sir to give me this opportunity. It's a real honor to be speaking in front of Gopte Sir because he has been my first teacher in ophthalmology right from my PG days. So it's great to be doing this presentation. Yeah, so I'll begin my talk. I have tried to keep it simple by trying to present a few cases where I have used this Fard suture. So let me just start off by a case presentation. So this was a 15-year-old boy who presented with upward deviation of the right eye following the trauma to the right eye with some bicycle handle. He gave history of some surgery being done with some tissue being excised. The details were not available. The best corrected visual acuity in the right eye was 612 and in the left eye was 6.6. The deviations are as mentioned in the box. So there was a large hypertropia in primary position, and we can see that the depression was restricted to a very large extent. If we see closely, we can also see a bit of a lid retraction, which indicates that the inferior rectus was probably severe. A CT scan was done, which showed focal atrophy of the right inferior rectus near the insertion, while the distal portion was thinned out. So surgical planning was done to explore the muscles, resuture and to either resuture the IR if it was found, to probably do an inferior oblique anterior transpositioning to overcome the big hypertropia, or probably an inverse SNAPS procedure. So during the surgery, this was what was encountered. There was a big mass or blob that was there, which was just incomprehensible, and in spite of trying to do a lot of dissections, was not possible. The post-duction test for the superior rectus was negative, and hence an inverse full tendon NAPS procedure was done, where the medial and the medial rectus and the lateral rectus were sutured near the inferior rectus and augmented with the Foster's suture. 6 months post-operatively, this patient was doing well in primary position and up gaze. However, in down gaze, the patient was still symptomatic and not happy. So we can see that the down gaze incompetence still persisted with the hypertropia being there. I will leave this case halfway in between and move on to the next case and come back to it again. Moving on to the second case, this was a 6-year-old female presenting with squinting of right eye since childhood. The vision was slightly suboptimal in the right eye being 660 and left eye 618, which was the best corrected visual acuity. Now this child actually had a dissociated horizontal deviation in the right eye. So if we see undercover, the left eye moves less while the right eye drifts a lot. So that is the dissociated horizontal deviation. This was also confirmed with the reverse fixation test, wherein when doing the prism cover test, we see an abducting saccade in the eye with the DHD, while an adducting saccade is there in the eye under the prism. So basically there is some amount of incompetence that is present. Going on to the next case. So this is a 4-year-old child who presented with acute onset squinting of the left eye following an episode of fever. The visual acuity in the right eye was 612 and the left eye was 6/24. There was a hyperopic astigmatism. The child was put in a full plus correction. However, the esotropia still persisted, and there was a near distance disparity, with the near angle being much more than the distance by more than, with a difference of more than 10 prism diopters. The ET reduced with the +3 glasses, and hence this was confirmatory of a high AC by A ratio. The patient underwent patching for a couple of months and then was planned for the surgical correction. So with these 3 cases kept halfway, I tried and introduced what Faden suture exactly is. So Faden in German means suture. It was first reported in 1912. It weakens the muscle in the field of the action without much slackening or alteration in primary position. So the principle on which this works is the muscle is sutured posterior to its insertion farther than the limit of its arc of contact. This shortens the lever arm, and it reduces the momentum only when the eye rotates towards the muscle that is sutured. So to try and explain this, so this is actually the lever arm. So when in primary position, it is fully functional. When we put in a Faden suture, it is marginally affected when the eye is in the primary position. However, it gets affected significantly when the eye deviates or eye moves in the direction of the eye, in the direction where the Faden suture is applied, and this arm significantly reduces. It's usually combined with a recession. When you get a larger effect of the recession, it is best suited for medial rectus owing to its short arc of contact. However, can be done on any of the recti muscles. The various measurements for Faden are as enumerated. For medial rectus, it is 12 to 14 millimeters from the insertion. For lateral rectus, 17 to 19 millimeters. And for superior or inferior rectus, 14 to 16 millimeters from the insertion. Now let us come back to the cases. Coming back to case 1. So I left the case over here at 6 months post-operative, wherein this incompetence and down gaze persisted. So to encounter this, a left eye inferior rectus Faden procedure was done, and it worked very well. This was a primary position correction. This was a pre-op. This was at 6 months, and this is a 2 years post-operative. And now we can see that in down gaze, both the eyes are almost straight, and the down gaze diplopia had almost resolved. Coming to the second case of dissociated horizontal deviation, this girl underwent a lateral rectus recession with medial rectus resection, along with the Faden suture of the lateral rectus. So these are her videos. So if we see in the pre-operative video, we can see a large drift that is there under cover. At 1 month post-op, this reduces significantly in the alternate cover test. While at 3 years post-op, this correction is still maintained. A small DVD is sometimes manifested when she fixes at distance. And coming to the third case, this particular boy underwent both his medial rectus recession with Farden over the medial recti. And these are his results. So he was orthotropic at 3 months. The bifocals were then gradually just weaned off. And at 3 years post-op, he's just in his hyperopic glasses and is orthotropic with fusion. So these are the common indications where Farden sutures are done in accommodative esotropias with high AC by A ratio, in Graves' disease, in orbital trauma, in dissociated deviations, either dissociated vertical deviation or dissociated horizontal deviation, sometimes in pulley abnormalities, in nystagmus blockade syndrome with adduction nulls, and 6-nerve palsies. So just to summarize, Farden suture is also known as posterior fixation suture surgery, used to weaken the rotational force of a rectus muscle when the eye rotates in the field of action of the Fardenized muscle. And it's a great procedure to address incomitant type of squints in particular cases. Thank you.
Thank you, Dr. Prachi. It was a very interesting talk and a wonderful case presentations as well to exemplify that. I would just have one question for you. We do have a Scots procedure as well, which is a recessed resect procedure. How do you compare this with the Fardens?
Can you just come again?
The Scots procedure, the recessed resect procedure. Yeah.
So probably technically performing a Scots procedure is probably easier. But on an individual basis, I find it slightly difficult to, get the measurements right as to how much to exactly resect and to how much to exactly recess. But yes, it has an advantage. Scots, we can use an adjustable procedure to it, which cannot be done for Farden. So Scots would score over that in certain situations.
And completely agree that Fardens might be a little difficult to reach out behind. And so there's an interesting technique, the adjustable, the modified Fardens.
By Dr. Manjula.
By Dr. Manjula,
for small angle.
That's an interesting technique as well. I've tried it and it works pretty well. So thank you, Dr. Prachi, for a wonderful talk. Any comments from the panel? Dr. Kavita would like to add anything?
Dr. Shruti, can I add a comment to this wonderful presentation by Dr. Prachi?
Thank you.
So this was in response to your question, comparing conventional Farden to Scots procedure. Like Dr. Prachi said, you can adjust the Scots procedure, which is not possible with the conventional Farden. Another drawback of the conventional Farden, though, is that resurgeries are very difficult. If you have to go in and operate again, you will find that the muscle which is anterior to your Farden suture has kind of fibrosed and necrosed and probably not functioning anymore. So resurgeries would be very difficult with a conventional Farden, whereas Scots procedure, you can operate as many times as you wish.
Agreed, yeah.
Yes, sir, that's a good point. Thank you. So we'll go on. For the want of time, we are going to be rushing through the next presentation. So that we'll have Dr. Anand Kumar with us. Dr. Anand is a leading pediatric ophthalmologist based in Kharghar, Navi at Utsav Eye Clinic. He has completed his fellowship from Aravind Hospital, Madurai, and he's done a fellowship in strabismus and neuroophthalmology from the University of Wisconsin-Madison under the master, Dr. Burton Kushner himself. So we welcome you, sir, and sir will be talking on surgery of small angle strabismus. Very interesting topic. Over to you, sir. So, are you there?
Yeah, I'm there. I hope my slide is visible.
Yes, both. You're audible and visible, sir.
Okay, great. I too would want to thank the organizers of this wonderful conference. And it's always a pleasure addressing the audience and such a learned panelists at such a high-level conference. Today, I would be speaking on surgeries for small angle strabismus. So by convention, strabismus less than 10 to 15 prism diopters are known as small angle strabismus. They are more likely to cause asthenopic symptoms because when the two images are close together, the abnormal visual experience can be more bothersome. And in such cases, our normal conventional strabismus surgery may not give us the expected result, as there is a very high chance of overcorrection. Of course, non-surgical treatment like prisms and botulinum injections do have their role, but their use is limited. We would be focusing more on the surgical treatment. The probably the easiest and the most conventional method of correcting such strabismus would be the single muscle recession and resections. Recession of a single muscle medial rectus has been extensively studied, and they have been found to be safe and effective for small angle esotropias. Such a surgery may also be performed under topical anesthesia to reliably and effectively correct diplopia. Here, rather than recessions and resections, we would be focusing more on surgeries which have been specifically designed for small angle strabismus. So the first of these is the partial tenotomy, which was reintroduced by Dr. Alan Scott in the year 2000. So in this case, we are performing a partial tenotomy on the inferior rectus of a muscle having about 8 prism diopters of hypotropia with vertical diplopia. So after the patient has been sedated and the surgical field prepared, we inject about 1 to 2 ml of lignocaine into the subtenon space just adjacent to the lateral border of the inferior rectus muscle. The muscle is then hooked with a Stevens hook and replaced by a Jamison's hook. The conjunctiva and the tenons over the muscle is then dissected. So now the Jamison hook is holding the inferior rectus muscle. The anterior ciliary vessels are cauterized using a wet field diathermy. And now using a blunt Westcott scissors, about 2/3 of the lateral edge of the inferior rectus muscle is incised. Here we can see that the posterior end of the muscle slides back easily. In case if you feel you want more effect, you can snip a few more fibers of the inferior rectus muscle. So like I said, this was revisited by Alan Scott in the year 2000. It was extensively studied by Al Biglen, and he found that the average vertical deviation in primary gaze decreased from 8 prism diopters to 2 prism diopters. And in the field of action of the treated rectus muscle, it decreased from an average of 8 prism diopters to 3 prism diopters. It was also effective in reducing the number of patients having diplopia post-operatively and the number of patients who required prisms. It was also published by Scott Olitsky group more recently. They performed this procedure in 9 subjects who had a preoperative deviation of around 5 diopters. Most of them were performed on the inferior rectus, and they found an average correction of around 4.67 prism diopters. The advantages of this procedure is that it is easy to perform. It can be done with under IV sedation and subconjunctival anesthesia. Intraoperative adjustments can be made. There is no need for suturing the muscle. Thus, a possible foreign body reaction is avoided. Because we are not passing a needle through the globe, there is no risk of penetration, very little chances of overcorrections. And if we don't get the desired effect, we can always convert it into a regular recession. The second procedure that we are going to look into is mini plication. So when a tightening procedure is needed for small deviations, the mini plication can be done. Here we are performing a mini plication on the lateral rectus for a small residual esotropia. After a swan incision is made over the lateral rectus muscle, the conjunctiva and the overlying tenons is dissected. The muscle is then lifted off the sclera with a tooth forceps, and a 6-vicryl suture is then passed through the middle 1/3 of the muscle belly. The muscle is then secured with the suture. The tenons, which is anterior to the insertion of the muscle, is dissected off so as to expose the sclera. And the needle of this 6-vicryl suture is then passed through the sclera about 1 to 2 millimeters anterior to the muscle insertion. And once the suture is tightened, the tied portion of the muscle comes anterior to the insertion, and this gives a strengthening effect. So Kenneth Wright studied this procedure and found that this reduced the vertical and horizontal deviations by an average of about 6.7 diopters. Advantages of this procedure are that it is less invasive and can be done with topical anesthesia. The third procedure that we are going to look into is the mini tenotomy. So it's a very simple procedure. We just hold the muscle through the intact conjunctiva, and once you are sure that you're holding nothing but the muscle, you incise the central 1/3 to 2/3 portion of the tendon, again through the intact conjunctiva. So by this, the central fibers of the muscle move back, and this gives a weakening effect. This again is a good procedure because it keeps the tendon poles intact, so the normal right rectus insertion is maintained, thus avoiding concomitance. So to summarize, all these procedures that we saw here are minimally invasive. Some of them can be done in the office with topical anesthesia, and they provide an alternative to prism glasses and conventional strabismus surgery. Thanks a lot.
Thank you, sir. That was excellent. Especially like the videos and how well they were able to, see show the procedure. The procedure is fairly simple, but planning for it is the difficult part. Dr. Kavita, would you like to comment? Like, what is your preferred conjunctival incision for such procedures, and what is your experience with these small angle strabismus?
Experience is relatively low, but. Okay. Otherwise, if it's this much mini plications, 1 or 2 patients I have done, and I open the way sir has opened, like I open close to the muscle and the plication Swan's technique. But generally for my other surgeries, I prefer a limbal incision.
Okay. So thank you. I think we'll move on to our last presentation of the session. It's none other than Dr. Kavita Kalevani.
Giving the best for the last.
Yes, and the topic as well. So like after we do the entire thing and we discuss everything, then we'll have to deal with the complications as well. Yeah. So Dr. Kavita is the right person to talk about it. She's a senior and experienced pediatric ophthalmologist from Shankar Netralaya in Chennai. She has immense experience in handling pediatric cataracts, complex strabismus, name it, and she's done it. She was my teacher back when I was a fellow, and I truly enjoyed her effortless surgeries, and that's how I call it, just effortless and just precise surgeries. I would enjoy her surgical sessions as well because there will always be music in the operation theater, and that's something I took back from her. Thank you, ma'am. She will be talking to us today about complications of squint surgery. Over to you.
Thank you, Shruti, for such sweet words, and thank you, Hemalini, for this wonderful opportunity. So yeah, like Shruti says, as a strabismologist or as any surgeon, we don't escape what is called complication. So we define a complication as any undesirable and unwanted result of a procedure. So for strabismus, we can have complications at any point, intraoperatively, preoperatively even, and postoperatively. So preoperative, what I mean is not really complications. Very, very rarely, it should never happen. All these things should never happen ideally in our practice. A wrong patient, a wrong plan, wrong muscle, wrong anesthesia, in the sense we sometimes think local anesthesia is sufficient, but the patient can become really uncooperative. So that maybe can be called as a wrong anesthesia. Otherwise, most complications are intraoperative or postoperative. So intraoperatively, again, these things should never happen. The wrong eye operating, sometimes you plan, you post, and then you have multiple surgeries. You may do a recess resect in another different eye or anything because the patient is under GA, you may not be sure. So these things should never occur. Otherwise, commoner complications intraoperatively we face is oculocardiac reflex. So as our anesthetists keep telling us, keep your ear open whenever you pull a muscle to the monitor. Bleeding, again, part and parcel of surgery. And scleral perforation is the most dreaded intraoperative complication, one of the most dreaded intraoperative complications. Again, it is avoidable if we take a lot of precautions while we operate. So other intraoperative complications can be muscle tearing or snapping, especially in situations where we have very tight or fibrotic muscles like thyroid ophthalmopathy. Like I said, similar situations, you can have a muscle slippage. Lost muscle is extremely rare, but it's a nightmare and one should never be facing it. Insufficient conjunctival closure sometimes can be a very nuisance, but it can happen. Buttonholing is a common thing that can happen. Corneal epithelial defects, sometimes incomplete irrigation or sometimes instruments or sometimes longer exposure can cause this. Otherwise, like I said, scleral perforation is a very common. Incidence is 0.13%. Recessions more commonly associated, obviously. Why? Because we do a scleral incision, scleral bites here. Larger recessions because of difficult access, you can have more complications. Recti versus oblique. Thinner sclera versus the healthy sclera. Spatulated needles more at risk. And complications of scleral perforations can be, if it is really deep or anything, can be retinal detachment, and it can act as a nidus to endophthalmitis. So prevention is now, with the advent of microscopic surgeries, it's very, very less compared to olden times. And hangback recessions, if you anticipate a large recession or a thin sclera, you can prefer hangback recessions, which avoids to a large extent this complication. And treatment is actually, the key is to identify when it happens. And it's useful to have a dilated pupil during the squint surgery as well. So a cryopexy or a laser, immediately managing the complication, really paves a long way to prevent complications. Muscle slip or loss. It's again a dreaded complication during intraocular, during the surgery. A slipped muscle rarely becomes not included in your suture, only the capsule gets included. So you get an empty capsule. So when you identify it, you need to gently trace along the capsule. After the surgery, if you anticipate this, an MRI helps us to know whether the muscle is still attached to the sclera. As compared to this, a lost muscle, you have very peculiar classic features of tight or fibrotic muscle can be prone to get lost. It withdraws immediately into the orbit if it is already very tight, especially a medial rectus. An MRI differentiates this from a slipped muscle where the muscle is not found to be attached. So how do you differentiate a slipped muscle from a lost muscle? So preoperatively, this child has 30 prisms of ET, bimedial recession is done. And this is the postoperative picture, day 2, 40 prisms of exotropia, and adduction is clearly limited, -2 limitation of adduction. So immediately you need to treat by exploring, and if you're lucky enough, you can reattach the muscle. Here it is not a lost muscle because there is still some amount of adduction present. As compared to that, a lost muscle presents like this, more prone, like I said, are tight muscles, fibrotic muscles, medial rectus, since it doesn't have an intramuscular septum. A severe limitation is there. Lid retraction gives a clue. Treatment is again to try to explore and reattach, which is sometimes very difficult. Otherwise, you resort to other options. Postoperative complications, immediate. We can have loose knots of the conjunctiva, slippage, etc. Corneal abrasions and epithelial defects. It's always a good idea to see a patient whenever possible in a slit lamp in your post-op period also. Anterior segment ischemia is a very, very important immediate postoperative complication which you have to look for. Infection, cellulitis, suture abscess is not very common, but yes, you need to be looking for it. Necrotizing scleritis, very rare, but it's very devastating if you pick it up, and if you're not able to pick it up. So again, you need to anticipate if you have a patient with the scleral issues prior to the surgery. And diplopia. So this is a granuloma. So anterior segment ischemia, how do you identify it? The risk. You do multiple recti in the same sitting, transposition procedures, previous buccal surgeries. Sometimes you can have absent recti, Graves, myopathy, radiation-related strabismus surgery. So all these exposed to high risk of anterior segment ischemia. Prevention is, of course, to stage your procedures, rule out systemic risk factors, to vessel sparing procedures. So how does it present? It presents as a mild anterior uveitis with pain and photophobia. When you identify it, it's simple to manage. Relieving the cause sometimes may be necessary, but otherwise topical steroids and cycloplegic beautifully restores the condition. Later complications can be conjunctival cysts, suture granuloma, steroids and surgical removal may be necessary. Diplopia. So diplopia, do we really call it as a complication? Like immediately if a patient has diplopia, it's very, very common to have diplopia that time. It's usually transient, and any type of strabismus patients can face it actually. When it is persistent, then we need to really worry about. So commonest reason for persistent diplopia can be under or overcorrection, or a new misalignment which is induced by your surgery. So how do you prevent? So in any situation, anticipation is the first role of prevention. So any acquired sudden onset strabismus, nerve palsies, long-standing deviation, sensory strabismus, you have to anticipate diplopia and counsel the patient basically. A PRISM trial or adaptation helps. Counseling is of prime importance. Intractable diplopia. What is intractable diplopia? In cases where you have anisoconia or central fusion disruption, the diplopia can be persistent despite motor alignment. So this is also a risk that you have to anticipate and look for. It may be self-limiting most of the cases. Reassurance really helps. Prisms if not resolving, and resurgery if the angle is large. Occlusion if there is a central fusion disruption. So what are undesirable effects? Sometimes there may not be complications, but an ugly scar is undesirable. Palpebral fissure changes. Diplopia again, undercorrections, overcorrections are invariable, but it's undesirable. Recurrences can happen despite meticulous surgeries. So again, anticipation, meticulous assessment, preoperative good counseling, and adjustable surgery techniques helps to prevent some of these complications. And you patch, prisms, and surgery is necessary when you have a larger strabismus. So finally, strabismus management is really challenging, full of surprises despite a meticulous approach. Key is in anticipating, and patient counseling is of utmost importance. Thank you so much.
Thank you, ma'am. Again, phenomenal talk, really nice. We've listed out everything. Just one thing, of late, I do see some of my juniors, or even I have seen one or two transient palsies following recessions surgeries. Have you had this particular complication? Have you observed this in your, it's transient, but then it gets better with time. There is an abduction limitation, but then it improves.
Transient weakness, you mean?
Yes, like there is something like a paralysis component, or there is a limitation in the movement, which definitely improves with time. Yeah, there is almost like a -3 limitation, and then it kind of improves over time.
I don't know, maybe the procedure that we do can have that, because last week I did one Faden, like Dr. Prakshi was saying, Faden on a medial rectus, and that I was not adducting till 3-4 days, and then gradually it improved. So we do see large recessions and large resections. There is a limitation of movement. But,
also, you think it could be because of pain? The patient may be having a little pain and so not moving the eyes.
Possibly, that definitely.
Particularly large resections, or even pediatric patients, they just may not move the eyes because of the severe pain sometimes.
Okay, yeah, that could be.
In such situations, we should be careful if there is a new deviation. So, like for example, you do a medial rectus recession, and you find that medial rectus is not really moving, the eye is not adducting. But if there is no exotropia, then I think you're not having to worry too much. Like Dr. Hemalini said, maybe it's a pain which is limiting her to move the eye. But if there is
Possibly.
an exotropia and the eye is not moving, then probably you have to really look more closely.
At a lost muscle or something.
Yeah.
Yes. We have a question from Dr. Neena. PITS, how do you anticipate and tackle?
Sorry?
And there is one more presentation in this session, no?
Okay.
Oh, not that I was informed of, Dr. Parikshit.
No, ma'am, because it's there in the printed program. So.
Oh, so we're running very late. Then I think we'll
I
skip
know.
this question and invite the next speaker, please.
Yes. So we'll have Dr. Rishikesh Mai with his next talk. He will be talking to us on vision assessment in specially abled children. Sir is from Nagpur and he's a senior ophthalmologist who's very well known in the pediatric ophthalmic circles. Sir, thank you for being here and over to you.
Thank you, Moscow. Thank you, Dr. Himalini Madam and Parikshit Sir and Ragini Madam. I will, because we are running short of time. Actually, there was a reschedule of this talk into this session, which I came to know in the afternoon. So I'll just briefly elaborate on few aspects about visual assessment in specially able children. Visual assessment does not only include the checking for visual acuity, but also other parts of the visual status of the child. So vision development is extremely important for sensory motor development of the child, and visual stimulus accounts for almost 40% of sensory input in early life. As a result of which, if there is a poor visual status associated with poor motor development, and it also leads to delayed milestones. Visual development helps in better academic and vocational performance in children in later life. So even with children with special needs, they can also have a better academic life. And I know a few patients who have gone on to become engineers also. So due to priority in motor and allied problems in differently able children, the visual development is usually neglected because visual problems are not easily seen by parents as well as the treating physiotherapist or pediatric neurologist. So how do you start the visual assessment? There are certain principles which we need to follow. Is that there should be minimum waiting period, preferably if they call for appointment, which is not possible most of the times here in Nagpur. So if they call and fix an appointment, should be given in the early morning, and try to have a child-friendly atmosphere and try to minimize the waiting period of the child. So once the child comes to the outpatient, I usually tell my receptionist to send the patient directly into the room without going into the optometrist room, and we do a history, visual examination, and squint assessment. And if dilation is required, many of the times the patient has just come for a review or infections, we see the patient directly without making him wait for dilation. Many times for follow-up, we don't do dilated diffraction. We just compare the previous reading with that of the previous reading with what we got now. So the normal visual functions are the visual acuity, visual field, and stereopsis, which we need to check. Now, among preferential looking charts can be used. Cardiff acuity is available, but I mean, it's comparatively more commonly available. It needs a bit of practice, but without just looking at the child also, we can come to know about the visual status of the child, especially what kind of vision the child might be having. Just if the child is able to follow the moving objects in all positions of gaze. The second part is what is the confrontation fields, which was described by Dr. Leah from Leah Symbols. You take a couple of objects, just two toys, ask the patient to keep looking straight and try to bring the object from periphery towards the center. If the child is able to follow in different while the moving object, probably the visual field in that particular gaze is good. As in this child, she had problems with up gaze, so at least now we are aware that her up gaze field is not as good. Depth perception, again, it is difficult using a titmus fly if the child is severely spastic paraparetic. So just to check for the depth perception, you can ask the child to try to touch in something like a pen or pencil in the field, and as you can see that the superior field, which this child did not have a good visual field, actually she is trying to just pass point it, and she is not able to freely locate that particular, the pain in that particular position. There are various theories. I will skip this part. There are certain leading questions which we need to ask to the parents. One is what is the basic visual skills of the child has, whether the child is able to focus at objects, moving objects, and light. That will give you a clue about how much amount of vision the patient has. And also task-oriented visual skills, whether the child is able to identify familiar faces, whether he responds to the various facial expressions which we are giving, and also whether he is able to, concentrate or just look at TV or computer screens once they are on. Simple resistance to occlusion can be tested in a child. If the child is able to resist occlusion in either eye, probably the vision is equal in both the eyes. So this is a simple test which can be applied for pre-verbal children or children with special needs, and also for central state maintained fixation. Like this child with exotropia in the right eye, the moment you close the left eye, he has got a nystagmoid movement in the right eye, so probably it is central, unsteady, and unmaintained in the right eye and maintained in the left eye. So many of the clinicians have tried to extrapolate this CSM vision into Sillon's acuity, but it is not very accurate. The only conclusion which we can draw is that the vision in the right eye is less than that in the left eye. So this is another child who had cerebral palsy, and she was just starting holding the neck. Remember, neck holding is very important for visual development, and you can see the nystagmoid movement, and the child is trying to look only in up gaze where she's able to perceive light. And after a couple of years, now she has a good neck holding and she is able to look at the moving objects. So probably, though she has the nystagmoid movement is present, the vision is obviously delayed, but she has better vision than what she had in the previous visit. These are certain conclusions which you can draw just looking at the child itself. Visual evoked potential, it gives a better idea about the visual status of the child even in less than 1 year of age. So VEP, what we have here is flash VEP, but checkerboard is much better. We check the responses from the occipital cortex, not only especially we concentrate at the positive wave at 100 milliseconds, which gives us a better clue about whether there is any latency or reduction in amplitude of VEP. So we should have a tailor-made approach for visual problems in children, because once the visual status is known, we can actually decide on what kind of the visual field we are dealing with and what kind of visual status we are dealing with, and accordingly we can counsel the parents. Like if the patient is not able to look in lower field, the parents can be asked to be careful when the child is negotiating climbing the stairs up and down. Just a few statistical analysis from India. 26.8 million children have learning disability, and almost 29% are children less than 19 years of age. 76% have ocular problems, and the chances of having ocular problems, especially retinal and optic nerve diseases, are much more common in in children with special disabilities. The visual problems usually get neglected, especially in early childhood in child with special needs, because of the neglect from the parents, from the physiotherapist, and even by the treating pediatrician. And children with these problems are interpreted as attention deficit or disobedient, instead of thinking that they might have visual problems as well. So visual health is very important for not only for the occupational part of it, but also for normal routine activities or day-to-day activities of the child. So with this, I would like to conclude that the chances of visual problem in differently able children are more, and almost 76% of them are reversible if they are treated at appropriate time. And visual development is important for sensory motor development of the child, and also to improve academic and vocational performance. With this, I would like to invite all of you for the 46th annual conference of VOS, which we are scheduled on 11th and 12th of December. It will be a physical conference. Thank you. Thank you, Moskan, for giving me an opportunity.
Thank you, sir. Perfect timing and excellent talk, and your videos were really nice. Thank you so much for helping us understand the nuances of testing vision in special children. I think we are a little short of time, so we will go on to the next session. Thank you all panelists, chairman, co-chairman, convener, Dr. Himalini, Dr. Parekh, for giving this wonderful opportunity, Dr. and Moskan. Over to the next session. Thank you so much all for joining in.
Thank you, Shruti. And without wasting much time, we'll start the neuro-ophthalmology session. I welcome all the panelists as well as all the speakers. Just to introduce Dr. Kumudini, are you here? Okay, Dr. Kumudani is chairing this session. She's a graduate from AIMS and she's done her fellowship and training from Canada and USA. And she's also a fellow of the NANOS and has several publications. I'd invite my first speaker, Dr. Neena. Dr. Neena is a senior consultant at Giridhar Eye Institute in Cochin. Welcome, Dr. Neena.
Thank you, Dr. Himalini. So shall I share my screen?
Yes, please.
So let me thank Moscon and Dr. Himalini for this invite and opportunity. I'll share my screen now.
Go ahead, share your screen.
Yeah, it's coming on. Am I audible and visible?
Yes, ma'am.
Yeah. So thank you once again. Let me start with the topic. The topic is internuclear and supranuclear disorders of ocular motility, lesions and presentations. So as ophthalmologists, we are all well aware of the 6 extraocular muscles, which are supplied by the 3, 4, 6 cranial nerves having their nuclei in the brainstem. But how many of us are aware that there is a 3-tier level of ocular motility control, starting with the cortex and the cerebellum, which is called as a supranuclear pathway, then the nuclear pathway in the brainstem, and the internuclear connections, and the infranuclear pathway. So if you look at the ocular movements, you can classify them as in many types as possible: introductions, versions, vergences. From the neuro-ophthalmic perspective, you can classify them as gaze-shifting movements or gaze-holding movements, or you can classify them as fast ocular movements like the saccades, or slow ocular movements like the pursuits, vergences, the OKR, and the vestibulo-ocular reflexes. So these 2 pictures tell you something about the supranuclear control centers and the internuclear connections. So not to get confused, just remember that there is a separate center for both horizontal and vertical gazes, although they share some of the common final pathways. So let's start with the horizontal eye movements. We have to brush up a little bit of anatomy to understand this. So I'll touch upon a little bit of anatomy here. So to remember that the horizontal gaze center lies in the pons, at the pontine tegmentum, and there is a final common pathway via the paramedian pontine reticular formation and the 6th nerve nucleus. So let's start with a horizontal saccade. So this is a video which shows you horizontal saccades. So these are fast movements which help us to fixate between 2 objects. So if you have to look to the left, if you have to generate a saccade to the left, the command has to come from your contralateral frontal eye field. It'll come down and cross over to the ipsilateral paramedian pontine reticular formation and 6th nerve nucleus. And from there, the connections go to the contralateral 3rd nerve nucleus via the MLF. So there is a conjugate movement to the left. So they can be voluntary saccades or reflex saccades. You have to look at the speed, smoothness, and accuracy of the saccades. This video shows you the pathway for the horizontal pursuits. Now, pursuit, P for P. The pursuit pathway comes from the ipsilateral posterior parietal cortex. Again, the horizontal gaze center is the PPRF and the 6th nerve nucleus via the MLF to the contralateral 3rd nerve nucleus, and a conjugate movement to the side happens. So now moving on to the vertical gaze center. Now, vertical gaze center is in the midbrain at the thalamo-mesencephalic junction. And let's see some videos showing the vertical saccades here. So these are slow tracking. No, these are movements which help us, again, saccades, help us to track between, to shift our gaze between 2 objects held across the vertical field. Again, the saccadic pathway, it comes from the contralateral frontal eye field. But this time, the center is in the midbrain at the level of the rostral interstitial MLF and the interstitial nucleus of Cajal. And from there, impulses go down to the 3rd and 4th nerve nucleus, creating the vertical eye movements. So to have a vertical saccade, you need simultaneous firing of both frontal eye fields. So this is a vertical pursuit which is happening. Again, the command comes from the ipsilateral posterior parietal cortex. It goes to the midbrain and again to the 3rd and 4th nerve nucleus. Now for torsional ocular movements, you need to activate the rostral interstitial MLF, and activation of the right rostral interstitial MLF produces a clockwise rotation, and left interstitial MLF produces an anti-clockwise movement. Now coming to the vergences, we know are disconjugate ocular movements which help us in bifoveal fixation of an object. So retinal blur acts like a stimulus for accommodative vergence. whereas the image location disparity is the stimulus for fusional vergence. So vergence centers are located in the 19 and area 22 of the occipital cortex. It goes to the midbrain reticular formation and pontine tegmentum, from there to the third nerve and the sixth nerve nucleus. And this results in a reciprocal activation and inhibition of the medial rectus and lateral rectus muscles, which brings about the convergence and the divergence respectively. So this is a convergence and divergence which is happening. Now moving on to the vestibulo-ocular reflexes and the optokinetic reflexes. So these act like the peripheral controls of the horizontal and vertical gazes. So in simple words, the vestibulo-ocular reflex helps the eye to move in a direction opposite to the head. So in other words, it's also known as the oculocephalic reflex, so the doll's eye movement. So what happens is that if there is a rotation of the head to the left semicircular canal is stimulated. It stimulates the same-sided vestibular nucleus. Now it has connection to the contralateral sixth nerve nucleus, which activates the same-sided lateral rectus. It has connections to the contralateral MLF and third nerve nucleus. So there is a conjugate movement to the opposite side. Now the OKR response helps us to track a moving object with our eyes, and you need an intact visual pathway for this response. Finally, the cerebellum, it acts like a master modulator. It is important in all sorts of ocular movements. It is responsible for suppression of the vestibulo-ocular reflex. It controls the smoothness of the pursuits and the accuracy of the saccades, which is the reason why in cerebellar lesions you get hypermetric saccades. So this picture tells you the important connections of the cerebellum to the other supranuclear gaze centers. So coming to the disorders, I'll just touch upon some of the common ones due to lack of time. So let's go on to the cortical disorders affecting gaze. Can I take 2 minutes? I think we have 10 minutes, no?
Yeah, but Dr. Neena, we're running short of time. So if you could quickly show us some cases and then.
Yeah. So this is a video. You can see this lady has a paralytic lesion of the frontal eye field. So if you have a paralytic lesion of the frontal eye field, you have a contralateral gaze palsy and patient will look towards the side of the lesion. In contrast, you go to a irritative lesion of the frontal lobe where you have a contralateral gaze deviation and patient looks away from the lesion. So again, now coming on to the horizontal gaze palsy, we know it's a lesion in the PPRF or sixth nerve nucleus. Again, this is to be differentiated from a fascicular sixth nerve palsy, because in fascicular sixth nerve palsy, you will really get an abduction defect, whereas in a nuclear sixth nerve palsy, you will also have a contralateral adduction defect. That's a conjugate gaze palsy. MLF lesion, we know, produces an internuclear ophthalmoplegia. I'll come to that. So this is a video. You can see a patient with binocular internuclear ophthalmoplegia. You can see as he tries to abduct, there is a dissociative nystagmus in either eye, and there is lack of adduction in both eyes. So he also has an exotropia in primary position. And if you look carefully, you can see he has a vertical nystagmus. So often the convergence is spared. And patients also have sometimes problems with the vertical gaze because the MLF is also the integrator for all sorts of vertical pursuit and vestibulo-ocular responses. So this is a Webino 1.5 syndrome. There is conjugate gaze palsy with ipsilateral adduction limitation. Now moving on to the Parinot's dorsal midbrain syndrome. So this young lady has, you can see classically, she has a sunset sign, that is conjugate down gaze in the primary position. And she also has an upgaze palsy. So basically they have a loss of supranuclear inhibition, control of all the oculomotor nuclei at the level of the pretectum, which leads to hyperactivity of the oculomotor nucleus, resulting in the constellation of syndromes. PSP. Now, sometimes you get a patient with Parkinson's-like feature coming to you with vertical gaze palsy. So in contrast to the Parkinson's patient who doesn't have a vertical gaze palsy, this patient will have a vertical gaze palsy, especially the down gaze will be affected. So if you do an MRI, you get this characteristic hummingbird or the Mickey Mouse sign, and the prognosis is usually bad. Now, Parkinson's patient can also come to you with sometimes exotropia and diplopia, very often due to a convergence paralysis, and you may help them by giving some prisms. So how do you differentiate a supranuclear palsy from a nuclear lesion? You have to do a vestibulo-ocular reflex. If the vestibulo-ocular reflex is intact, you know it's a supranuclear lesion and not an intranuclear pathology. So let's move on to some cases quickly. So this was a young boy who had a severe RTA and extensive brainstem hemorrhage. You can see that he had a partially resolved third nerve palsy in this eye, but the problem was not that. He was having inability to read. So if you see, he was having total absence of up gaze or down gaze and bilaterally dilated non-reacting pupils. And you can see that when he tries to look up, he goes into a horizontal nystagmus. So he had total paralysis of his vertical gaze center in the midbrain. Now, this was another gentleman who had a stroke, brainstem stroke. You can see that he has a small exotropia with hypertropia in this eye, which is much better when he lies down in supine position. So this was something like a skew. It was mimicking a trochlear nerve palsy, but it was definitely more on same side, the hyperdeviation, and there was no extorsion. In fact, there was intorsion. So this was more like a skew deviation due to a brainstem stroke. So this was due to a loss of, asymmetrical loss of inputs to the otoliths due to the brainstem stroke. So this is the last case. This child was brought by his parents with complaints of abnormal head position. You can see that when he tries to shift his gaze between two toys, he uses a head thrust rather than, turning his eyes. So this is very characteristic of oculomotor apraxia. So he's unable to generate a voluntary saccade, but uses a doll's eye maneuver or an oculocephalic reflex to generate the saccade instead. So he had this characteristic feature on MRI, that is elongated superior cerebellar peduncles. He had Joubert syndrome, and this was a case of OME. So to summarize, I'd say that you have to check saccades and pursuits and vergences along with your ductions and vergences. Remember that they can sometimes produce diplopia, although they don't usually produce diplopia. The supranuclear lesions involve both eyes simultaneously, and check for the vestibulo-ocular reflex and supranuclear palsies to differentiate it from the infranuclear lesions. Thank you. Thank you for your patient hearing.
Thank you, Dr. Neena, for your lovely presentation. I'll request Dr. Shubham Malpani to, start preparing his screen. Meanwhile, we'll ask a question. You can, stop sharing. Neena, what is your experience in giving prisms to PSP patients since they have a difficulty in down gaze?
Yeah, I haven't given prisms for vertical gaze palsies, but I have given prisms for Parkinson's disease patients with convergence insufficiency, but I haven't given for down gaze palsies.
Okay, and what about horizontal gaze palsies? How do you treat them?
Horizontal gaze palsies, actually, most of them will recover with time, because most of the time it is due to ischemic damage in the brain, and it usually recovers. So if they are having, like for example, INO patients, we have sometimes given prisms when they have a pure adduction deficiency. Then I have operated on a few patients who were unlikely to improve, coupled with 6-nerve palsy. I have operated on them when they have persisting exotropia or persisting squint in the primary position. I have operated on them, but pure gaze palsies per se, I haven't done any surgeries.
Dr. Kumudini, do you have any comment to make? Okay, I'm not sure if she's here. Shubham, you can start with your talk. Thank you.
Am I audible?
Yeah, you're audible.
Okay. Please bear with me as I am hell of nervous right now, because this is my first presentation at a podium as large as MOS. My topic today is review of ischemic optic neuropathies. A quick look at the blood supply of the optic nerve head. The anterior part is primarily supplied by the posterior ciliary circulation, and the posterior part is supplied by multiple sources. Types of ION are mostly dependent whether there is disc edema or not. Anterior ION present with disc edema, posterior present with a normal fundus appearance. Arthritic, non-arthritic, surgical, perioperative depend on the injury that has occurred, insult that has occurred. Most important for any person is to identify whether the disc edema is pallid or hyperemic. The image that you see on the left side of the screen is that of a chalky white disc edema. There are hemorrhages which might confuse you, but this is chalky white optic disc edema. And that on the left side of the right side of the screen is that of a hyperemic disc flush with vessels. How does it happen? In arthritic forms, thrombotic occlusion of the posterior ciliary circulation is the insult that has occurred because of systemic vasculitis. Most common cause is GCA. Non-arthritic form, something that every person has to see daily and almost at a very frequent occurrence in their clinics, is transient. The pathology here is transient non-perfusion or hypoperfusion of the optic nerve head. The trigger most likely is fall of blood pressure during sleep, because the most common presentation of this patient is when they get up from sleep, they experience the visual loss. Systemic risk factors and local risk factors play an important role. Posterior, a very big dilemma and a diagnostic confusion, because it is very difficult to diagnose, and although it is a diagnosis of exclusion. Triggers for surgical cases are severe and prolonged arterial hypotension because of general anesthesia, and hemodilution because of excessive use of intravenous fluids. Local causes may also play a role. It is most important to identify these patients properly. Arteritic forms. Who are these patients? Most likely women more than 60 years of age, presenting with severe visual loss, and amaurosis fugax can be a sign where you can catch it really early. Very insignificant clinically, because we often confuse it with other signs in this age. What will it look like? Acute stage will be chalky white optic disc, as we have already seen, may be associated cotton wool spots, central retinal arterial occlusion, serioretinal arterial occlusion. The picture would be drastic in what will you see? Because either you'll see just an optic disc which is very pale and the vision is very low, or you'll see the associated findings. In chronic stage, it is important to understand that it resolves with glaucomatous cupping and a pale rim. Non-arteritic forms, who are these patients? Middle-aged, elderly patients, maybe very rarely, but also yes, young, presenting with a normal or subdued visual acuity, with complaints of sudden painless loss of vision after waking up from sleep most commonly. Acute stage edema would be hyperemic disc edema, and in chronic stage, this would resolve as a generalized or sectoral pallor. Most important investigation here is perimetry and an absolute inferior nasal defect, rather than what we assume as an altitudinal defect, is the most common pattern and most important pattern that is seen in these patients. Diabetic patients, the picture is already very confusing because of the presence of diabetic changes, and optic disc edema can be confused with NVD. And these cases can be termed as diabetic papillopathy or papillitis, but it is very important to understand what insult has occurred. Posterior ischemic optic neuropathy, diagnosis of exclusion. You have to see at all the other factors, exclude all the other diagnoses. Now coming on to the most important part, let me quote: there being no other disease in which the prevention of blindness depends so much on prompt recognition and early treatment. Your suspicion should be very high. Your threshold should be very low. No symptoms does not rule out the possibility of arteritic forms of ischemic optic neuropathy, raised ESR or a normal ESR. It can be anything. But profound visual loss, pallid chalky white disc edema is a very important measure to assess whether what should be done. Main goal of therapy here is to do a ESR CRPs at the onset and see whether they are raised or normal. And if you feel the patient needs steroids, he is suspected to be suffering from arteritic form, do not wait. What is not to be done is the most important point. Do not refer the patient without starting them on oral steroids, never. Counsel the patient for undergoing confirmatory test for GCA, not to be done. And alternate day corticosteroid therapy, maybe half-hearted corticosteroid therapy is not advocated, not advisable. Now coming on to some cases
Shubham,
you'll have to wind up, Dr. Shubham.
Is it 8 minutes? Okay.
Timer is off. They're not timing you. I'm timing you. So you'll have to wind up because of restriction of time. We cannot discuss.
I have just a few slides to go through, if you can allow.
Yeah.
This is a 65-year-old male smoker. You can see the fundus photographs on the right side. Very drastic appearance of an hyperemic disc edema. Blood panel pre-diabetic, complaints of sudden loss of vision since one day after getting up from sleep, altitudinal defect on perimetry. Your suspicion is confirmed. Few other cases of NAION, hyperemic optic disc, altitudinal field defect. This is another case where an old ischemic optic neuropathy insult may be confusing because the disc is not that hyperemic, but perimetry confirms your suspicion. And old AION can also be confused because these patients are often referred for glaucoma evaluation, like this patient which was referred to me for glaucoma evaluation, 624, 66, 24, 22, right, for these general ophthalmologists, because the pressures are high. Now, as we look at the ONH, what we see is not that glaucomatous a disc. We do a OCT, normal OCT, the ONH analysis on OCT is normal, not that of a glaucomatous disc. And we see a perimetric result, which is more of an altitudinal defect from the fixation point. This avoids unnecessarily starting the patients on anti-glaucoma medications, or maybe keeping them on life for such issues. Now, very important for a general ophthalmologist or even everybody is to counsel the patients that this can happen in the other eye also. Even this, like this patient, which who was under regular follow-up, ESR and CRP were normal, presented with similar complaints in right eye, whereas the left eye, you can see there is pallor because the similar problem occurred 2 years back. And fundus examination, as you can see, because of the disc edema, there are no points on the visual field. Steroids, another matter of contention, another point where people often are in dilemma whether to start or not. I'm just showing you this case because steroids is a double-edged sword. It can actually hamper the treatment with patients because the side effects are too high, especially when your patients are diabetic, hypertensive, and more so. This is a patient who came to us with complaints of right eye visual loss. Now, this is the OCT of right eye. Let me give you a recap of what happened in left eye. Left eye had disc edema with cilioretinal artery occlusion. Very compliant patient. All investigations were done and she was given IVMP. And then later on started on oral steroids. What we can see is in the upper side, we can see a neurosensory detachment at macula with PED, that because the steroids led to CSR. As soon as the steroids were stopped, the NSD resolved. This is another patient where diabetic patient was put on steroids and sugar went over the roof. Now, the last case, most important case
Dr.
is
Shubham,
this is
you will have to wind up. I'm really sorry, but we have 4 more speakers to go ahead of you.
Thank you, ma'am. Thank you so much.
Thank you so much, and sorry to abruptly.
No problem, ma'am. Thank you so much for the opportunity.
Dr. Neena, you have any comment? Dr. Neena, are you there? Do you have any comment?
Yeah, I think you can, in case of genital arthritis.
Sorry, Dr. Shubham, stop sharing your screen, please.
Yeah, in case of genital arthritis, we can also try doing a Doppler of the superficial temporal artery. Sometimes they could pick up this halo sign, which is like a perilesional, I think halo sign they pick up, and that is also quite a non-invasive technique, and which may also tell us that this patient is having more, genital arthritis. But as you said, rightly start the treatment and then only send the patient for any investigations.
Secondly, there is another entity, occult GCA, that we should be aware of, because they don't have any systemic features. They just present to us with a temple pain and sudden loss of vision. So that is an occult GCA. There was an editorial by Harry in our IGO also. So those are the cases they come to us only.
Okay, I'll introduce myself. I'm Dr. Himalini Samant. I'm currently an honorary at JJ Hospital, and I'm an ex-consultant from Shankar Netralaya, currently now in private practice. My topic is non-arthritic AION with obstructive sleep apnea, and I'm grateful to Shubham for making my job easy because he's already introduced this topic to you. My screen is visible, right?
Yeah.
Okay. So obstructive sleep apnea is characterized by recurrent episodes of partial or complete airway obstruction causing cessation of breathing during sleep. Some of the risk factors for OSA are if you have nasal obstruction, or if you have a large neck circumference, or if you have craniofacial abnormalities. The severity of the sleep apnea may be increased by smoking, alcohol, sleeping in supine position, and an individual who has minimal physical activity. So what is the proposed pathophysiology linking OSA to NAION? Well, the common factor is hypoxia, and this hypoxia causes a dysregulation of the autoregulation of the optic nerve. Both these factors together induce an AION. So summary of some studies regarding the association of OSA with NAION. Mojon in his study had 12 out of 17 patients with NAION had OSA detected by polysomnography. Palombi had 24 out of 27 NAION had OSA detected by polysomnography. And Stein's study was a retrospective study where patients diagnosed with OSA and not treated had 16% risk of NAION as compared to controls without OSA. Now, diagnosis of OSA is basically based on polysomnography, also called as sleep studies, which remains the gold standard. But the downside is that it is an expensive and a time-consuming treatment. But a common questionnaire that I always ask all my AION patients, the non-arthritic ones, Number one, are you sleepy during the day? Do you fall asleep more easily than normal? Does your partner comment that you snore? So many a times the patient himself is not even aware that he or she is snoring, but it is the wife or the partner, the husband or the wife, who realizes that the partner is snoring. Has your partner witnessed any episodes where he has stopped breathing? So some of these questions, and maybe you will get an answer. So based on this background, I have this case of a 75-year-old gentleman who was a known patient of hypertension and IHD. He was also a diabetic. He complained of sudden loss of vision in the right eye, described it typically like a curtain in the field of the vision. Right eye documented elsewhere was 618, and in the left eye it was 6.6. He was diagnosed as a non-arthritic AION, treated with steroids, IVMP, in view of documentation of progressive loss of vision. So this patient was treated elsewhere. He came to me only for a second opinion. So when we found that the vision loss had been progressive, we got an MRI done. The MRI correlated with the diagnosis. For completion, NMO and MOG were done, which was normal. CRP and ESR, because Dr. Shubham rightly pointed out that we must rule out arthritic AIONs in elderly patients. Inflammatory markers were normal. The vision in the right eye deteriorated from 618 to finally finger counting close to face at the end of 6 weeks from presentation. And the fundus, which initially revealed just a sectoral disc edema, went on to disc pallor. So this is the fundus photo of the patient when he had presented much earlier with 618 vision, where he just had this inferior disc edema here. This is the MRI. So now we often come across patients with AION who suffer from progressive loss of vision. So in these patients, have we missed something? Should we ask for history suggestive of obstructive sleep apnea? So a simple question that we asked for this patient is, sir, do you snore at night? And the wife's response was, of course, I can't sleep at night with him. We sleep in separate rooms. So based on this response, we got a sleep study done. And the sleep study was positive, which recommended a severe obstructive sleep apnea with obesity and was advised an urgent CPAP titration using an auto CPAP at night. And if you look at this, he had 170 episodes of significant oxygen desaturation. The average oxygen saturation was 94 and the lowest being 89. So the diagnosis based on polysomnography was that this patient was having NAION secondary to IHD and hypertension and diabetes, but aggravated by OSA. He then was put on BiPAP machine. And remember that the aim of the treatment is not to recover the vision in the right eye, but simply to protect the left eye vision from NAION. So to conclude, optic disc edema with NAION generally resolves in 8 weeks. If it fails to do so, or if the vision loss is progressive, then alternate diagnosis should be considered along with the possibility of OSA. Understanding the strong connection between OSA and NAION can help prevent loss of vision in the other eye. And ophthalmologists must be vigilant to ask questions pertaining to OSA in NAION patients and refer them for sleep studies when required. Thank you. Dr. Kumadani, Dr. Neena, any comments? While we have the next speaker ready with his presentation.
I think we go to the next speaker. It's a nicely you have presented everything very clearly.
So the next speaker, Dr. Varda.
Hello, ma'am. Am I audible?
Yes, yes.
Yeah, I'll just share my presentation. Is it visible now?
Yeah, it's visible.
It's visible.
Okay. So first of all, I would like to thank MOSCON team and Dr. Himalini madam for giving me this opportunity to present. So my topic for today, no, it's not moving, ma'am.
Yeah, it's moving.
Okay, so my topic for today is nutritional optic neuropathy. I have no financial interest. Nutritional optic neuropathy was endemic after war and famine. There are multiple examples after war worldwide that Japan faced optic neuropathy in prisoners of World War II. Cuban endemic optic neuropathy was well studied. Jamaican sugarcane workers had the Strachan syndrome of deafness, neuropathy, and neuropsychotic disorders. Nigerian had tropical amblyopia, and Tanzanians had endemic optic neuropathy. Nowadays, we are facing optic neuropathy because of bariatric surgeries and complete vegan diet. So coming to the topic, nutritional optic neuropathy, it is a part of metabolic neuropathy group, which includes heredodegenerative, toxic, and nutritional optic neuropathies, which are characterized by mitochondrial metabolism impairment. Majorly, we found the deficiency in vitamin B complex. These are vitamin B12, B1, B6, B9, and copper. Riboflavin and niacin may cause nutritional optic neuropathy rarely. Herewith, I am presenting one case of 43-year-old gentleman presented with gradually progressive painless loss of vision in both eyes since 2 years. There was no predisposing illness like viral fever or trauma. There was no systemic illness. His best corrected visual acuity was 20 by 40 and 8 in right eye and 20 by 50 and 12 in left eye. Pupils were round regular reacting to light. There was no RAPD. The intraocular pressure was normal in both eyes. Low contrast visual acuity in both eyes was subnormal. Color vision was also subnormal. He could read only 5 plates of Ishihara chart with right eye and 2 plates with left eye. Anterior segment examination was within normal limits. His fundus examination showed marked temporal pallor bilaterally. This is a red photo which shows temporal pallor, and if you can make out, there is a light dark light pattern because there is typical thinning of the papillomacular bundle. Visual fields were done which showed a central scotoma. PP was done which showed decreased amplitudes but with normal implicit time. So at this point of time, I would like all of you to think about differential diagnosis of young male 43-year-old with bilateral progressive loss of vision. Mostly I thought it should be nutritional optic atrophy or toxic optic neuropathy, LHON. It can be hereditary optic neuropathy. Along with this, we should also think about so here are some tips. If depending upon the onset, if it is acute, then think about trauma, inflammation, and ischemia as an etiological agent. Then if the onset is insidious, think about intracranial space occupying lesion or orbital tumors as an etiology. If it is bilateral, more towards nutritional, toxic, intracranial space occupying lesion or inherited optic neuropathies. If there are CNS signs and symptoms, then more of intracranial lesions and metabolic etiology. We can do many more investigation depending on what we are thinking. If we are thinking about maculopathies, FFA and MFERG can be done. If more of a history of hereditary optic neuropathy or LHON-like symptoms, then genetic testing should be done. MRI brain, I feel, should be done in all cases of unexplained vision loss, mainly to rule out demyelination, compression, infiltration, and ischemia. There can be a non-organic vision loss also, having normal optic nerve, no thinning of peripapillary RNFL, and normal ganglion cell analysis. Here we dig into the history and we could find out that this patient was a strict vegetarian, not even consuming milk and dairy products. So he was further investigated, MRI brain was normal, vitamin B12 levels were done, which were very, very low, like 119 picograms per ml, and which clinched the diagnosis of nutritional optic atrophy. So is a recent review article showing normal levels of vitamin B12, which is a huge range of 200 to 900 picomoles per liter. And folate level should also be noticed, that is 3 to 20 nanograms per milliliter. This patient was advised oral supplementations of vitamin B12, folic acid, and pyridoxine. After 5 months of follow-up, his vision was stable. Vitamin B12 levels were increased up to 461 picograms per ml, and folate was also increased from actually 4 to 17.34 nanograms per ml. Fields were repeated after 5 months, and we could appreciate there is some improvement in total deviation, but the central scotoma was still there. So nutritional optic neuropathy is a syndrome characterized by papillomacular bundle damage, central or centrocecal scotoma, dyschromatopsia, and there is no RAPD in these cases. Pathophysiology is that there is a damage to the mitochondria due to lack of nutrients, interruption of electron transport system, and consequently there is a reduction of ATP production leading to poor vitality of cells. The causes are mainly inadequate diet like alcohol consumption or vegetarian diet, atrophic gastritis, pernicious anemia. There can be pancreatic insufficiency, renal ileal resections. Drugs like metformin can cause interference with vitamin B12 absorption, bacterial overgrowth, and transcobalamin deficiency. The population at risk is elderly people, vegans, people with gastrointestinal disease, a person with raised vitamin 12 requirements like pregnant women and breastfeeding women, with those who are under treatment with proton pump inhibitors, metformin and H2 blockers, and those with renal disease. Major symptoms, clinical manifestations they are categorized into hematological, neuropsychiatric, digestive, and hyperhomocystinemia. These symptoms are microcytosis, thrombocytopenia, or neutropenia. Neuropsychiatric problems can be peripheral neuropathy, ataxia, optic atrophy, and dementia. Digestive, look for glossitis, angular stomatitis, jaundice, or lactate or bilirubin level, and thromboembolic episodes in cases of patients with hyperhomocystinemia. We should always do complete blood counts to look for, with the peripheral sphere, to look for anemia, microcytosis, neutrophilic hypersegmentation. Vitamin B12 levels should be measured along with serum cobalamin levels. Levels of vitamin B12 metabolites are very, very important. If the vitamin B12 level is normal and this methylmalonic acid and homocysteine are raised, they are again pointing towards nutritional optic atrophy. So the treatment is mainly dietary. We can give oral supplementation as well as intravitreal, intramuscular doses of vitamin B12. The outcome depends on the cause. If the cause is reversible, there can be some improvement in the vision, but few patients may have some degree of vision loss. So my take-home message is we should dig into the history about diet, alcohol, and drugs. General examination for stomatitis, glossitis should be done. Look for causes of malabsorption. Prompt vitamin replacement can prevent irreversible and permanent neurological damage, and we definitely need a physician guidance to monitor vitamin B12 levels. So I would like to acknowledge Dr. Virender Sachdeva, who is my mentor from LVPI, and definitely we don't want to have this endemic, so we need a world peace. Thank you so much.
Thank you, Dr. Varda. While the next speaker is ready with the talk, any questions for Dr. Varda, Dr. Kumudini?
I think Dr. Varda, you didn't get the CBC done in your patient.
No,
that would have helped you to cleanse the diagnosis at the first place.
No, the CBC was normal in my patient. He did not had any signs of anemia, but typically.
What about peripheral neuropathy? Was there any peripheral neuropathy?
No, ma'am. In this patient, there was no signs, no other signs of peripheral neuropathy or no history of malabsorption or anything.
How would you differentiate LHO in these patients from nutritional optic neuropathy? Though the age was one, like
yes,
it was 43.
Age is there. There is.
And what is other point you can differentiate the two?
There is a sequential vision loss. First, one eye vision is lost, and then there is the other one having same problem. In
by nutrition, which is simultaneous.
Male.
Okay, good. We can move to the next patient. Next
I welcome Dr. Susha. Dr. Susha is practicing in Bombay. Susha, you can go ahead.
Yeah, can you see my screen?
Yes.
Okay. Good afternoon, everybody. After such wonderful talks in this strabismus session, and Dr. Nina has covered all the supranuclear and nuclear causes of which can lead to diplopia. So I would just like to thank MOS, Dr. Himalini, and quickly I would just run through the approach to diplopia. I have made a very simplified presentation, not a lot of cases, so that any general ophthalmologist knows what they should look for when a patient comes to you with this complaint of diplopia. So getting familiar with the term, in Greek, diplos means double and ops means eye, hence diplopia is a double vision. So let us take a stepwise approach to decipher the symptom that the patient presents to us with a lot of apprehension and distress, because it most often disrupts their daily routine activities. The patient themselves is the first clue. So like any other patient entering our clinic, each one stepping into our examination room must be closely observed with regards to their head posture, facial symmetry, presence of visible physical disabilities, the gait, the posture, the speech, and so on, which can give us major clues of a neurological, psychological, musculoskeletal, neuromyogenic cause which can be associated with the presenting complaint. The second clue is the presenting complaint, the way the patient presents the complaint to us, as in, doctor, I can see blurred, I can't see clearly, there is a ghost image behind anything that I see, there is a clear double image, there is a shadow behind the image that I see, there are multiple images, not two, and some people can even appreciate that the image becomes single when they close the apparently affected eye. So a detailed history, as in the origin, duration, progress of symptoms, always gives us a clue in every case, whether there is an exacerbating or relieving factor, whether any associated symptoms like a TIA, a headache, or anything that can point us to the cause, whether any history of an injury or a fall, which probably they did not consider very seriously, but after which the diplopia has started. So then the probe begins. Is the diplopia monocular, binocular? Is it a comitant or an incomitant one? Is it crossed, uncrossed? Is it a horizontal, vertical, or oblique diplopia? Is it a constant diplopia? Is it intermittent, goes on and off? Is it fluctuating? That is there a diurnal variation? Is it more for near as compared to distance? Or is it posture related? So there is this is a chart in which you can see that if there is a monocular diplopia and there are repetitive images, not only two, then it may be a cerebral polyopia, which is a non-organic cause. If there is a ghosting image which improves with blinking or pinholes, then it probably is a refractive error. If it is not improving with blinking or pinhole, then it may be a retinal disease. If it's a binocular diplopia, now whether to call it a monocular or a binocular, you have to specifically ask the patient if they see a single image after they close either eye, not the affected eye, not just one eye, because it is quite possible that in the OPD they might close one eye and say abhi nahi dikh raha hai, but that is actually to be seen if either eye is giving you the same single vision. So if it's a binocular diplopia, then the alignment of eyes should be checked with a cover test. Subtle squints may be missed when we do a cover test. So if there is absolutely no misalignment and the images are dissimilar, then it could be a metamorphopsia like in a macular disease or a marked refractive asymmetry. If the images are similar and they are constant, then it might be a physiological or a non-organic cause. If it is an intermittent kind of diplopia with similar images, then you have to rule out myasthenia gravis. Most importantly, if the misalignment is a comitant strabismus, it could be a childhood strabismus. If it's acquired, it could be a Virgin's paresis or a skew deviation, in which especially you have to ask about the deviation when the patient is lying down. If it's an incomitant strabismus, it could be a restrictive disease, a cranial neuropathy, supranuclear disorder, oculomyopathy, or a neuromuscular junction disorder. So if it's a monocular cause, then the diplopia persists on occlusion of one eye. It could be refractive corneal lenticular, iridectomy, iridotomy, dry eye, very, very commonly seen nowadays because of the COVID situation and a lot of screen use. Many people do complain of double vision, which disappears on blinking their eyes, retinal maculopathy, cortical diplopia, or psychogenic. If it's a binocular cause, like we have already explained before, decompensating heterophoria, where the angle of deviation is same in different directions of gaze, or an incomitant one, which may be myogenic, like a thyroid, neuromuscular junction disorder like myasthenia, paralytic nuclear or infranuclear one. Generally, the supranuclear lesions will not present with diplopia, or a restrictive blowout fracture, orbital tumor, a Brown syndrome, an orbital apex, etc. So whether it's a comitant or an incomitant strabismus, comitant strabismus is generally congenital. The secondary deviation and primary deviation is the same as compared to incomitant, in which the secondary deviation will be more. No limitation of movement, no abnormal head posture, whereas there will be a limitation of movement in incomitant strabismus, and people may compensate with a head posture. The diplopia may be the presenting complaint in an incomitant strabismus, generally not in a comitant one, unless it is decompensated later in life or post-cataract surgery or any of these things. Suppression may cause a depth perception to be absent until late onset or maybe very mild, whereas depth perception may be all right with a head tilt if the patient has already adopted a head tilt. So I'm just giving you a representative image of the corresponding areas on the retina for per image. And if it is falling on the opposite side, then it may have a false image, as in crossed and uncrossed. So we have to have a systematic approach to all these patients. So the vision, uniocular and binocular, distance and near, and a pinhole test should be done. Color vision and confrontation should always be done in order to rule out any optic disc abnormality, optic nerve pathway abnormality that you're missing. A confrontation test as well. Refraction, torchlight exam, swinging flashlight, and a Hirschberg's test. Alternating cover test in all 9 positions of gaze. Extraocular movements, ductions and versions. Saccades and pursuits, as nicely explained by Dr. Neena again. Convergence, light near dissociation, and accommodation. All cranial nerve examination should be done. You should not stop at only examining the 6th nerve in a lateral rectus palsy. You have to examine all the others. You have to do a motor and sensory examination of the limbs. Do a Maddox rod diplopia charting, double Maddox rod test. Slit lamp examination and rule out all the causes of monocular diplopia. Fundus examination to rule out macular or retinal regions. So there is a diplopia grading score by King Kwan Wu, which has been published in the British Journal of Ophthalmology. We don't generally use it, but it's worth to have a look about it, whether the diplopia is within the 40 degree of the visual field or not will determine whether it is mild or severe. So I'm just browsing through the Maddox rod test, the double Maddox rod test, the Parkes 3-step test, as we all know, which eye is hyper in the primary gaze, in the right or left gaze, and in the right or left head tilt will give us an approximate idea to which muscle is the paretic muscle. Diplopia charting, I generally prefer to do it with a red blue glasses and with the retinoscope. So that will also give us whether the image is crossed or uncrossed.
I think you can summarize the...
Yeah. So just a few fields with the Hess's chart. And the force duction test, which is very, very important. This is just a pro forma to show if the FDT is free and the force generation test is positive, and if the FDT is restricted and the force generation test is positive, what can be the differential diagnosis. So after we have found out what the diplopia is and after all the tests have been done, yeah. So this is just a chart to show the treatment and the investigations that we need to do for the particular cause. So the treatment is generally to treat the cause: patches, Fresnel prisms, orthoptic exercises, surgery, and Botox. Thank you so much for your time and attention.
Can I request Suja, stop sharing the screen?
Yeah, done.
And the next speaker, can you please load your presentation? While she loads, are there any questions for Dr. Susha? Shelly, are you here?
Yeah, Susha, comprehensive presentation, nicely done. I just wanted to ask you, we are seeing a lot of kids ever since the lockdown has started with acute acquired comitant esotropia. Do you see as well? Do any of the others also see? Because I see 2 types of patients: myopes who stop using their glasses getting esotropia, then non-myopes, mild hyperopes coming to me with either it could be a decompensated esophoria going into esotropia. Any thoughts on that? Anybody?
Yeah, so I have seen many of these decompensated cases, especially after the advent of these online classes and online lecture series. One more thing that I have noticed is maybe they are presenting to me now because post-COVID, after all these screen use, the parents are more apprehensive when the child says, I have a blurred vision, or so I see many of them with convergence insufficiencies, a lot of them with convergence insufficiencies. And incidentally, a lot of them with, like Dr. Varda said, B12 and zinc. So just supplementation of this, doing a few orthoptic exercises.
I was talking about esotropia, acute esotropia, not exotropia.
I think, Neena, I think those cases do well with surgery, in my opinion. What about you, Neena?
Yeah, that's what the ones with divergence insufficiency, I send them for exercises because the angles are very variable, isn't it? The ones who have decompensated and gone in for large angles, I operate them.
Yeah, as long as you document that they're constant.
Yeah, always do an MRI to rule out that it is not a CNS
fossil lesion.
CNS abnormality.
Thank you, Dr. Sushan. I welcome Dr. Shailaja. She is a consultant in the Department of Pediatric Ophthalmology, Strabismus and Neuro-Ophthalmology at the Shroff's Charity Eye Hospital.
Go ahead, Dr. Shailaja.
Yeah, thank you, all the office bearers of Maharashtra Ophthalmic Society for giving me this opportunity, especially Dr. Himalini. And localization, it actually means where the lesion is present, which is accounting for the patient's clinical signs and symptoms. So in neuro-ophthalmology, we often have to think about localization of a lesion before ordering an neuroimaging. And it is important to think about and come to a location, because that is where you will direct your imaging to. And it is good to do that. Otherwise, you may not get the report that you want, because a busy radiologist may actually miss the area which you are interested in. So it is very important to think in your mind where the location may be present. Localization, it begins with a thorough understanding of anatomy and physiology of the oculomotor system and the visual pathway. And some of this anatomy has been elucidated by Dr. Nina earlier, so I'll not go into much details. Apart from knowing the anatomy, you have to have a proper history-taking examination, especially to the age, the onset, the duration, what is the primary complaint, which nerves are involved, is it one nerve, are there multiple nerves, has already been some recovery has happened or not, and all the negative histories. Apart from that, your examination should include all the cranial nerves, the orbital signs, strength of the limbs. You have to check for muscles, you have to check for your force reduction test and force generation tests. Do not forget to examine the pupils and your extraocular movements. Apart from that, systemic examination like cerebellar signs, presence of tremors or loss of balance, and the reflexes can be very useful. Again, do not forget to examine all the cranial nerves, especially till the 8th nerve. It is very important for an ophthalmologist to know from 2nd to the 8th especially, and we will see how they are linked together. So coming to each nerves one by one. So the 3rd nerve, this is a simple diagram showing the course of the 3rd nerve from the origin, from the midbrain to the orbit. And whenever you see a 3rd nerve palsy, you have to think whether the palsy is isolated or not. Okay, first thing that you need to think that whether you are dealing with a simple or a single nerve, or are there multiple nerves. So looking at this anatomy, you can see that if there are multiple nerves involvement, then there are certain areas where it can be associated with a 3rd cranial nerve with other nerves, like in the orbit, in the cavernous sinus where it is associated. The other area could be the brainstem area where the other nerve nucleus are there. Along with that, they may also have systemic involvement. So if the 3rd nerve is not isolated, then you look for what other features are also there, whether they are systemic or whether they are cranial nerve. If there are no systemic, only cranial nerve, then think about orbit or till cavernous sinus. If there is systemic involvement, then think about the brainstem. Additionally, in orbit, if the lesion is in orbit, then you may have orbital signs as well, as discussed. So the isolated part then would be localized to this subarachnoid space, where it courses to the subarachnoid space. When it is isolated, then you should think about whether it is complete or incomplete. By complete, I mean that all the components of the 3rd nerve are involved. That means the superior division and the inferior division, all the muscles are involved. Incomplete means either one is paired. So it has a bearing. Why? Because when we talk about complete palsy, if there is a pupil sparing complete palsy, then it could be ischemic. If there is an incomplete palsy, then you cannot rule out, even if the pupil is spared, you cannot rule out a impending tumor or a compressive lesion. The nuclear lesions of 3rd nerve can themselves have very classical features which can localize it to the part of the nucleus as well. For example, if it's an ipsilateral nucleus lesion, then we know that the levator palpebrae has a single nucleus, and the superior rectus nuclei, the fibers cross to the other side. So the patient will have a bilateral ptosis and a bilateral elevation deficit, along with one-sided 3rd nerve palsy. If there is a horizontal lesion in the nucleus involving both the nuclei, but it may spare the levator palpebrae, it may spare the Edinger-Westphal nucleus. So you may have normal pupil, you may have a syndrome where there is a bilateral 3rd nerve palsy and the normal levator function and normal pupils. So on and so forth. If the fascicle is involved, then it's a complete ipsilateral third nerve palsy. These are all these syndromes which are associated with the brainstem lesions. I'll not go into the detail. We need to know some of them. Whenever there's systemic involvement, it has to be correlated, and one can refer to a chart or a diagram, or Google also whenever they you come across this case. But important is to examine the systems, especially the gait, the power in both the limbs, and if there is any tremors or ataxia. So as I mentioned, that the isolated third nerve can be localized to the subarachnoid space, where the most common is the IC aneurysm, or the aneurysms which can compress them, apart from neoplasms, meningitis, herniation, and trauma. And pupil involvement may help to distinguish, but as I mentioned, pupil involvement may be present even in ischemic palsy, and it may be absent in a impending compressive lesion, where it is just starting and causing an incomplete palsy. So aberrant regeneration again points towards a traumatic lesion or a compressive lesion. This is the other area where multiple nerves can be involved. Keratocavernous fistula may have other signs like these corkscrew vessels. I'll just skip this, go to the sixth nerve. Now, sixth nerve is a long nerve. It has 2-3 bends in the two bends in the brain, and it is very subjected to trauma. Again, the same thing applies, that if it is isolated, think about the subarachnoid space. If it is systemic involvement, then think about the brainstem, and if there is orbital signs, then think about the orbit. Again, some of the syndromes which are associated, like the Raymonds, the Millard-Gubler, the Fovels, I'll not go into detail. I think this part has been covered by Dr. Nina, that it could be Guy's palsies because of the pontine involvement, and very useful clinical test is to check for convergence. If convergence is present in a patient who cannot adduct when trying to abduct to the opposite side, then it localizes it to the PPRF and the associated areas, MLF and PPRF lesions. I'm sorry, the MLF, not the PPRF. So internuclear lymphoplegia, Guy's palsy, 1.5 syndrome, these are all part of this part of the brain. And in the subarachnoid space, it can be a false localizing sign, where it can be compressed against the tentorium by raised ICT. And you can think that maybe it is a compressive lesion, but actually it is just the raised ICP due to lesion anywhere else in the brain. So that is why it is called as a false localizing sign. When it is involved with the fifth and the sixth and the seventh or the eighth cranial nerve, then you have to think about the temporal fossa lesions, the Grady-Negro syndrome and the pseudo-Grady-Negro syndrome. The CP angle tumors and nasopharyngeal carcinoma can mimic a Grady-Negro syndrome. So the take-home message is that check for the corneal sensations and hearing in sixth nerve palsy. Coming to the fourth nerve, it is the longest intracranial nerve and is the smallest one as well. It crosses from the dorsal aspect and arises from the dorsal aspect of the brain, while the others arise from the ventral aspect. It has a single muscle supply. Most commonly, however, it is congenital palsies because of nuclear dysgenesis or anatomical tendon abnormalities. Acquired are pretty low on the incidence side. So look for other cranial nerve involvement may suggest tumor infections and aneurysms. So isolated, non-traumatic fourth nerve palsy is most likely congenital other than acquired. Coming to the last segment, which is localization based on the visual pathway lesions or the visual field defects. We all know about this diagram, that we need to look at the visual field defects in any patient who has an optic nerve dysfunction. And the first thing, which is whether it is vertically respecting a field defect or a horizontal, can give you a clue whether it's a brain lesion or a eye involvement. And amongst the brain, then from the optic chiasma, because of the anatomy of the tracts and the visual pathway, you can have bitemporal hemianopia, which localizes it to the optic chiasma, and thereafter it will be a homonymous hemianopia. The anterior lesions would be incongruous, and more posterior the lesion, it will become more congruous. And some specific field defects of the occipital cortex would be, the homonymous hemianopia involving only the macula, or the macula sparing ones, or the temporal hemisphere, the crescent or the crescentic defect in one eye. So all these are very important to be known. The mnemonic is pits for the pie in the sky and the pie in the floor, which are the temporal cortex will lead to an inferior defect, and the parietal cortex will lead to an inferior defect, and the temporal cortex will lead to a superior defect. So PITS is something which you need to remember. So localization is tells you have to understand what is the minimum damage to the neuroanatomy that accounts for the patient's signs and symptoms. If the lesion is where you suspect, then you should look for all the findings that you expect, and if it should explain all the findings. If it is not explaining, then can the lesion be somewhere else? So these are the thoughts and these are the questions that you should ask yourself while trying to localize a lesion. So thank you. Sorry for overshooting a little bit.
So I would like to add one thing, when you have a multiple carrier palsy, like third, fourth, and sixth now, you always test V1 and V2. If along with the third, fourth, and sixth, V1 is involved, it's the anterior cavernous sinus. And if it is along with the V1 and V2 is involved, then it's a posterior cavernous sinus. That is one more. And then look at the pupil. And if the pupil is small in the size, then that means again favors you that it is in the cavernous sinus, because sympathetic parasympathetic are together there. Bilateral multiple canyon palsy also suggests midline lesion, like pituitary apoplexy, where the sudden expansion of pituitary is there with paracavernous sinus extension of both the sides. So, or metastasis to the your dorsum sali or your clival area. So the multiple canyon now both the sides will be affected. That's the only thing.
Dr. Shailaja, I just wanted to add one more thing. Very nice presentation. I have seen quite a few patients with altitudinal hemianopias, bilateral altitudinal hemianopias, superior or inferior, due to bilateral occipital lobe lesions. So often they have bilateral symmetrical ischemia of either the inferior lips of the calcarine fissure producing superior altitudinal hemianopia, or the superior lips of the calcarine fissure producing bilateral inferior altitudinal hemianopia. So it's a very, very tricky situation. You think a patient is having AION or PION because you get an altitudinal field effect. Sometimes they can be macula sparing and sometimes macula involving. And when we have imaged, we've got this sort of picture. So I think the anatomy corresponds to that. So you can get an altitudinal field effect also in bilateral occipital stroke.
Yeah, thank you, ma'am. I was
homonymous hemianopia with relative upside pupillary defect on the contralateral side also suggests a tract lesion. And
Yes.
while in the
But
radiation, you won't get any pupillary effect, only homonymous hemianopia would be there. The one thing that can also happen to the tract or it's a weak defect is because of the radiation involvement.
And one more thing, if you want to localize it further to the occipital lobe or to a parietal lobe, in fact, you want to know whether it's a parietal lobe lesion in a homonymous hemianopia, check the ipsilateral pursuits on the ipsilateral O'Kane response. Because in the long tract signs, you may have a patient with homonymous hemianopia and sometimes contralateral hemiplegia. If the ipsilateral pursuits are defective, it's likely to be a parietal lobe lesion, because ipsilateral parietal lobe is responsible for your ipsilateral pursuits. And similarly, the ipsilateral O'Kane response will be diminished. So pursuits we can do in our OPD. O'Kane may not be there with everybody. So these are some points which I've learned with practice. Yes, nice. Anyway.
Very practical points, Dr. Neena. Thank you for sharing them with me. So there are no more questions. I think we'll call the session to an end. I must appreciate Dr. Neena taking out her time. And Kumardini Madam, thank you so much for agreeing to chair the session at a short notice. I thank all my speakers for a wonderful session that we've had today. Thank you, everyone.
Thank you.
Thank you, Himalini. Thank you, everybody.
Thank you, Shailaja. Bye.